I have this proud privilege to introduce Ranjana, who everybody over here knows. We will have people walking in as we start, but I thought we'll start on time since you're waiting. And actually, I'm very, very eager to listen to what you have to say. I know you'll discuss the ASH updates and we'll have maybe questions of problems that we face day to day with many of these new drugs. So all yours, Ranjana.
Thank you. Thank you for the invitation. And I will go ahead and share my screen now.
So we have Dr. Sumit who's co-chairing, and both of us will be there for your lecture.
Okay. Can you see my screen?
Yes. Yes, Ranjana.
Okay. So again, good morning to all of you, and thank you for inviting me to give this lecture. This is basically focusing on checkpoint inhibitors and Hodgkin's lymphoma, what was presented at the recent ASH meeting in December. Why my slides won't go forward.
Just click twice in the center of the screen sometimes, and just click twice.
Yeah, there we go. Okay. Yeah. So when you harness the immune system to treat classic Hodgkin's lymphoma, we have, basically two classes of approved drugs. One is brentuximab, which this audience doesn't need me to explain to them. And the others are the checkpoint inhibitors, basically nivolumab and pembrolizumab, which work through the PD-1, PD-L1 axis. So if you look at the 2023 Hodgkin lymphoma guidelines, the place for novel agents in the frontline setting is only with brentuximab along with AVD based on the results of the Echelon-1 trial, but none of the other checkpoint inhibitors are part of frontline therapy right now. And most of the role is in relapse setting, whether it's in first salvage or subsequent salvage. And in first salvage is used in combination with either brentuximab with nivolumab or with chemotherapy, pembro with GVD, nivo with ICE, pembro alone, and so on and so forth. So at this ASH, we heard a few updates of the existing conditions as well as some new ones. So if you have to think about harnessing the immune system to treat classic Hodgkin's lymphoma and how we incorporate these novel agents, I've broken up the talk into frontline therapy, where in early stage, the ongoing studies the role is to define its potential to reduce the number of cycles of chemotherapy or radiotherapy. And in advanced stage, how do we improve upon ABVD? Then in second line, as first salvage, where you can give a combination of novel agents or novel agents plus chemo, and then in post-transplant and remission or post-relapse after transplant, when patients have pretty much had whatever is approved. So starting out with early stage Hodgkin lymphoma, if you look at the PET adapted strategies, and I'm not going to belabor too much on this slide, but whether you do, rapid or the ERTC way, or you start out with the German way and the CLGB trial, just focus on this column over here, which is the PFS for the patients with interim PET negative, is well above 90%. Yes, there are some which are 88 and some 86, but a lot of those also had some patients with the arms where there was chemo alone. But if you look at patients who got like combined modality therapy, it's like 95%, 94%. So really, really very excellent results, which honestly are really hard to beat. So the first thing, the focus of the early stage trials are, can we get rid of radiotherapy? So by combining a novel agent. So this is data from the Memorial study, which we participated into, where they gave brentuximab with AVD, so no bleo. You do 2 cycles, do a PET scan, and repeat 2 cycles, and then do a PET-4. And at that time, if it was PET negative, there were 4 cohorts. The first 2 were with radiotherapy, 30 gray, 20 gray. The third cohort, which was a very conformed radiotherapy only to sites more than 1.5 centimeters. And the last cohort was no radiotherapy. And these cohorts were defined as they had to have at least one risk factor by the EORTC criteria and by the German Hodgkin study criteria for lymph node site. But for cohorts 2 onwards, bulk was decided as any mass more than 7 centimeter, not the traditional 10 centimeter definition for the mediastinum or mixed cellularity disease. And you can see over here that this short course of BV-AVD in all the 4 cohorts, including number 4, which was no radiotherapy, had excellent outcomes, and there is a pretty much overlap of all these curves. So what they presented at ASH was actually looking at the metabolic tumor volume and the PET status, as well as a 4-year update. So they looked at metabolic tumor volume on the interim, at the baseline scan and the interim, and they used a 41% maximum standard SUV value for the threshold. And then patients were stratified by MTV high or MTV low. And the PET2 results were reviewed using the Deauville score. So you can look over here, the progression-free survival by cohort. Of course, all the cohorts are just as good. You look at by the interim PET, it's not, you don't need imagination, but if you're PET negative, you do much better than PET positive. If you look at baseline metabolic tumor volume, if you have a high baseline tumor metabolic volume in red here, the outcomes are worse than if you have a low metabolic tumor volume where the PFS is like 100%. Even for the high, it's 91%. But when you combine PET and metabolic tumor volume, you can really pick out a subgroup of patients whose metabolic tumor volume is high and the interim PET was positive, which was defined as a Deauville 4 or 5. Their progression-free survival is only 60%. And for the rest, it's like 95 to 100%. So the conclusions of the authors was that this short course is has very good results. And even at 4 years, even the absence of consolidative radiotherapy in patients with bulk, late events are rare. And combining baseline metabolic tumor volume and PET2 identified a group of patients who are at high risk for refractory disease. And so this supports expanded exploration of this paradigm, and that is under development. Now, the Germans updated the results of the Nival study. Now, this was combined modality therapy, but in this study, they combined Nivolumab to AVD, and they had 2 arms. One had a concurrent arm where they gave it with AVD, and they had a sequential arm where they started out with 4 of Nivo, and then they gave the chemotherapy with Nivolumab AVD. And this was then followed by radiotherapy in all the arms. And you can see that whether you gave it concomitantly or sequentially, at the end of therapy, that the final remission status in dark green is the complete remission rate is well over 85, 90%, and patients do very well. That was published. So what we they presented at ASH was that the correlation with other metabolic tumor volume, quality of life, and long-term outcomes. So you can see now that at a median follow-up of almost 4 years, at the whether you do it concomitantly or sequentially, the progression-free survival is 98 to 100%. So excellent. And if you look at the quality of life, this is just the fatigue score. You can see that it significantly improves with time, and the patients are more tired during chemo, but then after radiotherapy, it goes down, and comes to basically to normal levels by year 3. So there's no worsening or long-term side effects of adding the Nivolumab. They looked at organ function and second cancers, and this is just the FEV1 and the DLCO. And you can see that at baseline is in blue, after 1 year after therapy in orange, and in green is 3 years after therapy. There's absolutely no change in lung function. There's no cardiac events more than grade 1. They did LVEF at 2 years and 3 years. It was normal in 95% of the patients. And at a median follow-up of 4 years, there was no second cancer. It's, of course, early to talk about second cancer. They looked at the main immune-related toxicity. It's actually hypothyroidism. Again, that was the one thing which stood out, that at about 3 to 4 years, it's about a 15% of patients, mostly female, who developed hypothyroidism and needed a replacement therapy. So the conclusions of the authors were that the Nival approach had outstanding long-term efficacy, whether you did it sequentially or concurrently. And all patients who had a PR at the end of therapy converted to a CR without further treatment after radiotherapy. The 3-year PFS and OS are 99% and 100%. The late toxicities were temporary, no second cancers. Hypothyroidism was frequent, 21%. Mostly affecting females, but grade 3 was 15% of the patients who required medication, and no patients required immunosuppressive treatment at last follow-up. The global improvement in quality of life. So their conclusion is it's highly feasible, it's effective. So of course, the question is, do all patients require the full course of chemotherapy or even radiotherapy? So they have taken on this bold trial design, which is not yet going to start, where it's called the INDI trial, which is the individualized immunotherapy in early stage unfavorable Hodgkin's. So this is patients with stage 1 or 2B with risk factors. They get a checkpoint inhibitor called tislelizumab, and just for 2 cycles. And if they're PET negative, they just get 4 more doses of the Tisel drug. If they're PET positive, only then do they get that combined with chemotherapy. And at the end of therapy, if they're PET positive, only then do they get a radiotherapy. If they're PET negative, they don't get any radiotherapy. So again, moving the field to does everybody with early stage need chemotherapy? Does everybody need radiotherapy? So what about other studies where radiotherapy can be omitted? Okay, so this is now yet another approach which used both the agents. It used brentuximab and nivolumab. So they called it ANAD. So this is basically you give, it's basically BV-Nivo in the beginning, and then after that, the chemotherapy is adriamycin and dacarbazine. And they get 4 cycles based on day 1 and day 15 for early stage. And you can see that the overall, in this preliminary report of 76 patients, the overall response rate is 95% with a 92% complete remission rate. This trial is still accruing, so they did not provide any PFS or overall survival data, but the CR rate is extremely high. It was well tolerated. They had a very low incidence of neuropathy, again, because there's no Velban. You're giving brentuximab, but there's no Velban. And they just had 4%. There was no febrile neutropenia, no deaths. And 8 patients had some treatment-related serious side effects, mainly pneumonitis and pyrexia, which also resolved. The same study looked at the same combination in advanced stage Hodgkin's as well. But here the patients got 6 cycles. And they had more mature data for this. But again, here, the overall response rate is 93% with a CR rate of 88%. And you can see that at a median follow-up of little less than 2 years, the estimated progression-free survival is 94.5%. And of course, the overall survival is excellent. And if you look at the treatment emergent immune side effects, basically it's any event which was more than 2% was reported. So 35% overall, but mostly grade 1 and 2. And the usual ones which we expect. There was no increase in toxicity with the combination. So the conclusion of the authors for this combination of brentuximab, nivolumab, followed by then dacarbazine, was the use of 2 active agents with distinct complementary mechanisms of action in the first-line setting was promising, and the interim efficacy for both early stage and advanced stage was encouraging. And the 12-month progression-free survival was 95% in advanced stage disease, well tolerated. And for the early stage, the study is ongoing. Another study looking at trying to avoid radiotherapy was looking at BV-AVD, but instead of giving BV-Nivo and then chemo, this gave BV-AVD and followed it by nivolumab consolidation in patients with limited stage Hodgkin's. So if you look at this study design, this is, as I said, they got 3 cycles of brentuximab AVD. They got a PET scan. If they had PET negative, they just continued to get consolidation with nivolumab for 8 cycles. If they were PET positive, they got a 4th cycle of, they got 4 cycles of actually brentuximab and nivolumab before they got nivo consolidation. So a little bit of a long study design, but the primary endpoint was a 3-year PFS of greater than 95%. So if you look at this is again for early stage patients. So 80 patients, and you can see over here that most of the patients had stage 2 disease, and about a third had B symptoms. They really didn't comment on how many of these patients had bulky disease or not. If you look at the results, CR rate was 96% in the interim PET and 100% at the end of therapy. And this is shown over here. You can see the Dovell 1, 2, and 3 is what is considered PET negative. And this went from 96% to 100%. If you look at the duration of response, you can see that this is firstly the overall survival is like 100%. And you can see that the median follow-up is over 2 years, 28 months. And over here, the swimmer's plot shows that most of the patients actually are doing quite well, are in follow-up. There were very few, you can see these 4 yellow dots, which was they got non-protocol treatment. And there is almost no patient. I don't think I see any pink star for deaths on study. And again, the most common greater than grade 3 adverse event included neutropenia and some LFT abnormalities. So the peripheral sensory neuropathy, like you saw in the echelon 1, is about 34%, and Nivo was well tolerated. So compared to the previous study where the neuropathy was only 4%, that's because they didn't give Velban. So the minute you give brentuximab and Velban, I think you're getting about a 30% neuropathy rate, all grades, but the grade 3 or 4 is about under 5%. So the conclusion of this study was that it's the largest study to incorporate 2 novel agents in patients with limited stage disease. And this abbreviated course of BV-AVD followed by Nivo consolidation has very encouraging outcomes. So 96% of the patients, that's all they got because they had a negative interim PET. So remember, if you were PET positive, you were going to get BV-Nivo before going to Nivo consolidation. Only 4% of the patients needed that. 100% overall survival. And this is being evaluated further, mainly from a cost benefit, because this really jacks up the cost of treatment tremendously and long-term quality of life. Now, moving on to advanced stage disease. So, escalated BRCOP is very effective. These days, based on the HD18 trial, just 4 cycles is enough. And that does reduce the toxicity significantly, but it's not 0. So the HD21 trial is comparing standard BRCOP, escalated BRCOP, to something called BRCAD, where they've incorporated brentuximab. And in BRCAD, there are some differences. Firstly, there's no bleomycin. The etoposide dose has been lowered so that you reduce the hematologic toxicity. The ADRIA has gone up a little bit. The cytoxan stays the same. Brentuximab is added. There is no vincristine. There's no procarbazine. Prednisone has been replaced by dexamethasone so that the bone toxicity will be less. And procarbazine is replaced by dacarbazine to reduce gonadal toxicity or secondary endpoints. And in this trial, 85% had stage 3 or 4 disease, and half the patients had a high IPS. The patients were well matched. And you can see the primary endpoint was treatment-related morbidity. And compared to escalated BRCOP in blue, which are 4 cycles, 4 cycles of BRCAD was significantly superior in terms of much lower transfusion need, lower peripheral neuropathy, and normalization of the FSH. So sterility is not a problem. And for the entire cohort, you can see that the progression-free survival as well as the overall survival is excellent. And it's very comparable to the HD18 results. So I presented data on something called the Keynote C11 study. And this was a study which looked at evaluating the efficacy of a PET-adapted regimen of sequential pembro monotherapy followed by AVD in a PET-adapted approach without radiotherapy. So this was for patients who had advanced Hodgkin's stage 3 or 4, but also included stage 2 with bulky disease, bulk being defined as greater than 10 centimeters. So everybody gets Pembro for 3 cycles, they get PET2, and irrespective of the results, they continue with AVD for another 2 cycles and then get a PET. And for patients who are PET negative, they go on to get Pembro consolidation. So depending on the stage, if they are early stage, they just get a total of 4 cycles of AVD. If they're advanced stage, they get 6 cycles. For PET positive patients, they go on to get BIACOP. And when they finish, they all get Pembro maintenance for 4 cycles. And this was a planned interim futility analysis after the first 50 patients were enrolled. So we enrolled 146 patients, and you can see that about 14% were in the US, 34% in Europe, and 51% in the rest of the world, because they really wanted this to be a global study, not just a US study. About 40% of patients had unfavorable disease per the German criteria. Half the patients had stage 3 or 4 disease, and 22% had bulk. The primary endpoint was the investigator assessed PET negative rate, and you can see it was 84% had PET negativity. So it met its study endpoint where it had to be more than 50%. So study will continue. The treatment-related adverse events, it's not surprising that you could see the grade 3 and 4 are the dark blue and black, which is mainly seen in the chemotherapy part of it. And you can see that in dark blue over here, you have it's with BIACOP with the grade 3 or 4 thrombocytopenia, some anemia, but the rest of the toxicity was pretty mild. It was just grade 1 or 2. If you look at the AEs of special interest, mainly the pembrolizumab, you can see the typical immune-related thyroid issues, but none of them were more than grade 3. So overall, it was very well tolerated. And escalated BIACOP, there are very, very few patients, only 3, and we really didn't see much. So the conclusion of this was that it met its futility analysis. The mid-treatment PET-adapted regimen has promising activity, and therapy was well tolerated. Per study design, this is continuing. And if the results pan out, then this Pembro induction followed by chemo may also be another effective treatment option for patients with advanced Hodgkin's lymphoma. Of course, in the end, these will all have to be randomized against echelon 1, which is BV-AVD to prove, but these are all like proof of concepts trying to get the field to move forward and avoid a radiotherapy or avoid salvage with transplant. So what happens when patients relapse? So our standard regimens are, we do ICE chemotherapy or DHAP or something, take them to transplant. I've published data looking at combining brentuximab with nivolumab with very encouraging results. So this is now updated results on nivolumab plus ICE. So the Nivo ICE was published a couple of years ago, where it had an amazing response rate. Most of the patients actually achieved the CR with just Nivo. And so this trial now was modified to explore it specifically in a higher risk cohort. So all patients had to have at least one risk factor: primary refractory disease, relapse within a year of completing frontline therapy, B symptoms of relapse, extranodal disease, and they all had to have had a brentuximab containing regimen. And with that, you can see that the overall response rate was 100%, with 89% achieving a CR. 32 patients proceeded to go to transplant, and then 8 patients received the post-transplant maintenance. So the 1-year PFS was 90%, and in primary refractory disease, 95%. And then 10 months post-transplant, it's 96%. So really, again, very, very good results in patients even with primary refractory disease. The most common adverse events were as expected. It were all grade 1, except to Nivo alone were all grade 1, except some hypertension, pruritus, and fatigue. But the one thing to watch out for, whether you use Pembro or Nivo, when you take these patients to transplant, we're seeing about a 10 to 20% rate of engraftment syndrome. And that is patients get fever and LFT abnormalities during the transplant period. So you really have to be aware of that so that you start patients on steroids. So the conclusion of the authors was that Nivo ICE was very effective at toxicities compared to ICE alone, very active in high-risk patients with a very high CR rate, and excellent post-transplant progression-free survival. So what happens if patients now have had BV and they've had Pembro-Nivo and they've had a transplant and then they relapse? So this was a looking at combining a drug called favezelimab, which is an anti-LAG3 antibody. So LAG3 is yet another checkpoint which is co-expressed with PD-1 on anergic T cells. So you can give a checkpoint inhibitor, but if the T cell is anergic because of LAG3, it won't just work. So this looked at combining the LAG3 inhibitor with Pembro in patients who have either ineligible for transplant or they had progressive disease after already getting 2 doses of either Pembro or Nivo. So these are patients who have been refractory to a checkpoint inhibitor. You're adding another inhibitor called LAG3 to see if you can reverse this anergy. So this was a study of 34 patients and a median follow-up of 18 months. You can see that 93% of the patients had tumor reduction, and about 70% had already had a checkpoint inhibitor at baseline. The median time to response was about 3 months, and the duration of response about 21 months, and PFS 10.7 months. And you can see that it also had a manageable safety profile. It had about 18% AEs grade 3 or 4, but nothing more than what we don't know about, mainly the thyroid issues. So there is, it suggests that this combination shows a potential to reinduce a response in this patient population. So now there is a phase 3 KeyForm study, which is just about to start, which will look at a co-formulation of both these drugs in patients versus Pembro alone in patients who are refractory to anti-PD-1 therapy. Now, the last slide is just cautioning when we use these checkpoint inhibitors that interim scans may not be as reliable for outcome. And you can see over here that this is looking at it along with circulating tumor DNA. So this was a study which looked at Pembro plus AVD in advanced Hodgkin's lymphoma. And you can look at the interim PET. You can see that the PET CR rate was only 66%. Okay, so most of these patients would have been called a PR. And if you were in a PET adapted therapy, the therapy would have changed. But that didn't happen in the study because they also looked at in a circulating tumor DNA. And you can see that most of the patients had a negative, did not relapse. You can see that over here in green, they did not relapse. They all dropped their circulating tumor DNA. Only one patient here relapsed. And at the end of treatment, again, you can see that there are some patients who are PET positive. So the CR rate is only 82%, but none of the patients have relapsed, suggesting that PET in this era of checkpoint inhibitors is not as critical, is not as reliable, and you might have to use other parameters. So we use lyric criteria, but also that's where circulating tumor DNA is coming into the picture. And you can see over here this correlation of circulating tumor DNA, that when that starts rising, that there is relapse or some problem. So I think that is my last slide. So where the immunotherapy strategies are being evaluated is both in frontline and the relapse setting. There are still many unanswered questions. So will efficacy at relapse vary if these agents have been used in the frontline setting? And many of them are being used now. So will they work again? We just don't know. What are the long-term outcomes for the frontline approaches needed for both efficacy and toxicity? How do you sequence these? And of course, last but not the least, a very important cost consideration. Just simple for the most favorable patient, 2 to 4 cycles of ABVD and 30 gray cures about 90-95% of the patients. So in early stage, I don't know if we need all these fancy things because it just jacks up the cost. I think if you pick the right patient for radiation, like high neck disease, and you don't radiate very young people, you can avoid a lot of the later effects due to radiotherapy. In advanced stage disease, I think for the highest IPS patients, echelon 1 is not a home run. So there is work to do to see whether adding checkpoint inhibitors there will improve the outcome. So there is a US intergroup trial ongoing now, which is comparing BV-AVD to Nivo-AVD. And that has completed accrual. So hopefully results of that will help us learn some more. So that is my last slide, and I'll stop sharing my screen. And thank you for your attention. I think these were the 20 minutes I had. I'm happy to take questions.
Thanks, Ranjana. That was an excellent presentation and lots to look forward to. Never seen curves about 3 years back, which was so horizontal in their being. And now you've shown us so many horizontal curves. So if there are any questions, yes, Hemant is ready with his question. He'll ask you
So
first.
Ranjana, thank you very much. I think that was very nice being less than generous. That was an awesome presentation. My,
Thank you.
my apologies for not picking up your phone. It was on silent. So my
No
question,
worries.
my question to you is like, how far are we from approval of checkpoint inhibitors in the first line in the US and the rest of the world?
Quite far. It hasn't even gone to the FDA as yet because we don't have any preliminary results. The only randomized trial which is required to be a registrational trial is the one which is going on in the US intergroup, comparing BV-AVD, which is a standard based on the echelon 1, to Nivo-AVD. That trial has just completed accrual. So once we see results of that trial, there have to be enough events for them to read it out. And if that shows that it's superior, then, we'll know. But right now, the others are all basically, as proof of concept.
Single arm studies. So if you have a stage 4 patient tomorrow, you wouldn't give that patient first line checkpoint inhibitors
On trial.
on trial, only on trial.
You can put it on one of the existing trials.
Okay,
but not off trial.
Okay.
It won't be approved. We won't be able to get it.
Thank you.
Any other questions? Yes.
A really interesting and exciting talk in the field of Hodgkin. So cost, as you had mentioned, is a big constraint, more so in our country. So is there any predictive markers, any predictive tools to say like this patient is not expected to do well on chemotherapy, maybe in the relapse setting, and where we would benefit from using a checkpoint inhibitor in the like?
So I mean, those are coming, right? Like, so circulating tumor DNA, metabolic tumor volume. There's some studies looking at TARC levels to see where patients who, if you at the end of therapy, if you still have detectable circulating tumor DNA, you don't do well. If you have a high tumor metabolic volume, those are the ones who don't do well. So combining those scores are all coming. I mean, I focused my talk only on the ASH abstracts, but those are the ways where one is looking. I mean, there is no test you can do up front. The only baseline thing you can do is look at metabolic tumor volume and combining that with interim PET. If you are interim PET positive and have a high metabolic tumor volume, those are the ones where the progression-free survival is only 60%. And you wonder that in that patient population, should you switch therapy earlier in, say you start out with ABVD and they have a high tumor metabolic volume and the interim PET is positive, maybe in that patient population, coming in with a novel agent earlier will improve outcomes. Or if you have somebody who's relapsed within a year, and again, depending if you cannot get them into a CR with standard therapy, at that point, again, looking at circulating tumor DNA to see if that's still high, then that's a group of patients where you might want to give a salvage with the checkpoint inhibitors or brentuximab or something rather than conventional chemotherapy. And
will the IPS still retain its relevance in the checkpoint era?
Well, it's become less and less, right? It's already become less and less. The original Hasen-Cleaver IPS, the high risk patients defined as 4 or more factors had a PFS of only 40%. In this day and age, the Vancouver group looked at it, and in ECOG we looked at it. We actually came up with a simpler 3-point scale. Even the highest risk group, the progression-free survival is 70%. So it's already gone up with the PET-adapted approaches, with the better supportive care. So, I mean, like the IPI, it has continued to hold its relevance. So it's at least useful for patient stratification in the beginning. I mean, I think it comes up at the practical level every day in clinic when you have a patient with, say, stage 3 or 4 Hodgkin's. Well, brentuximab AVD is approved for that group, but is it really the right answer for each and every person, given the cost and, the neuropathy and the toxicity? So if you have somebody who has a low IPS score of 0 to 1, that patient can be treated per RATHL. You can give ABVD and drop the bleo and they do just fine. If you have somebody with a high IPS greater than, 4 or more, the results with ABVD are at best 75%, so not most optimal. So that's the group then I would prefer to give, either the echelon 1 approach, or you start them with, BRCAD or BRCOP or something and try to do better in that group. So IPS is important for stratification right at the beginning. That's the only clinical tool we have.
Thank you.
Any other questions?
Can I
Yes.
ask
Yes,
a
please.
question? Thank you for such a wonderful presentation. My question is that in the relapse setting, adding checkpoint inhibitor to AVD, which checkpoint inhibitor do you add, and what is the criteria besides brentuximab and other checkpoint inhibitors that which you add to the AVD on what basis? Is there any other criteria other than the cost? Adding nivolumab to AVD or brentuximab to AVD or combination of nivolumab to and brentuximab to AVD, on what criteria do you select the checkpoint inhibitor at your center?
You mean, why did we do the trial?
No, I mean, on what criteria do you select the checkpoint inhibitor that you add to the AVD? Is there any other factor other than the cost on which you select? Okay, we will add brentuximab to the AVD or nivolumab to the AVD or brentuximab.
Well, the only thing you can add right now where you can get approval for is brentuximab. Nivolumab and pembrolizumab are all research questions. Okay, so you can't add those off trial. Those are trying to see, can we make the outcomes with chemotherapy better? So that's why those are added as part of investigation. Brentuximab to AVD is approved, and it's approved because it was compared head-to-head with ABVD in the echelon 1 trial. And when you compare those two, ABVD to brentuximab plus AVD in stage 3 or 4 Hodgkin's, there's a 7% improvement in progression-free survival and about a 5% increase in overall survival in favor of the brentuximab arm. That's why that is added. And as I explained now, if the role for it is mostly in the highest IPS risk group of patients. It's not a question of cost or anything. Of course, if it's not available where you practice, it's not an option. But if it is available, and you have to pick and choose who you will give it to, you probably give it to the highest risk patients at the get-go. I don't know if I'm answering your question or whether I've not understood.
So that means, in other words, that nivolumab and the combination of nivolumab to brentuximab with AVD is yet on a trial.
They are all
Yes.
clinical trials at the moment.
Okay,
So
that's all clinical
practice. Yeah.
Correct.
Thank you, Ranjana. There are many questions still, but we will have to wind up for the sake of time. The next speaker, I think, is already online. Thanks very much, and hope to see you in person very soon in India. Thank you.
Definitely.
Bye-bye.
Yeah. Take care. Thank you.
Thank you. Bye-bye.
Thank you, Dr. Ranjana. Thank you, Dr. Reena Nair, and all the participants. Thank you, Dr. Sumit Gujral, for your presence. And next, may I request Dr. Naveen Gupta. Dr. Naveen is Associate Professor in the Department of Clinical Hematology at this university. Along with him, Dr. Aparna Parikh. Madam is well known to all of us. She is Executive Director, Global Scientific Affairs at IOSICON PLC. Session is on immuno-oncology in myeloma.
Good morning, everybody. It is my pleasure to introduce Dr. Nupur Raje. She is the Director, Center for Multiple Myeloma at the Massachusetts General Hospital, Professor of Medicine at Harvard Medical School in the US, and she's going to talk on immuno-oncology in myeloma, bispecifics, and CAR T-cell therapy. Thank you. Nupur.
Okay. Thank you so much for this invitation. I'm just going to try and get to share my screen. All right. Can you guys all see my slides?
Yes.
Okay, perfect. Again, thanks so much for this invitation. I was in India a few weeks back. If not, I would have been there in person because Jaipur is a city I love. But what I was asked to talk about today was advances in immuno-oncology and specifically focus on bispecific T-cell engagers as well as CAR T-cells and focus mostly on the ASH 2022 updates. So as you all know, we are very excited about BCMA as a target, and BCMA can be targeted in several ways. For the purposes of today's discussion, we're going to focus mostly on BCMA bispecifics as well as some of the CAR T cells. And towards the end, I will talk to you about some of the newer targets which are in clinical trials as well as some close to approval as well. So before we talk about bispecifics, I think it's important to understand the types of antibodies that we have. All of you are familiar with the naked antibodies. We have daratumumab, which has been really useful in the context of multiple myeloma. This is a naked antibody. We also have an antibody drug conjugate in the way of belantamab mafodotin, and most recently now we have these bispecific antibodies. These are engineered so that one end binds to obviously the multiple myeloma tumor cell antigen and the other end binds to the T cells and activates the T cells. Again, the bispecifics have very different and many platforms. The BiTE strategy, which has been spearheaded by Amgen, is somewhat left by the wayside right now. This is a bispecific T cell engager. There are dual affinity retargeting DART-like antibodies, and this is the first one, the Janssen teclistamab is the one which is approved, and there's a whole host of others where once you understand the platform, really we are again, in my opinion, at the beginnings of the use of bispecifics in the context of multiple myeloma. So BCMA, as I've already mentioned, is the target which has been furthermost in its development. BCMA is used, stands for B-cell maturation antigen. It is present on all plasma cells. And we know that BCMA, which belongs to the TNF family of proteins, plays a role in the survival and prevents apoptosis of multiple myeloma cells. Now, when you think about these IgG-like bispecific antibodies, there's one from, there's the Janssen duo body, which is teclistamab. There's an anti-BCMA CD3 Pfizer antibody elranatamab. We have alnuctamab from BMS and several others, which I will just mention in today's talk. So we'll start off with teclistamab. Although teclistamab, this data was not presented. The reason I'm presenting this is the first-in-class bispecific T-cell engager, which has been approved in the context of multiple myeloma. Now, this was based on a phase 1 trial. Close to 120 patients were treated. One was initial, about 80 patients were with the IV formulation. Then they moved to the subcutaneous formulation, and we have the recommended phase 2 dose of this. With this, what you see in the context of teclistamab is that in general, teclistamab is well tolerated. We do see cytopenias. Cytopenias is a common toxicity seen with all bispecific T-cell engagers, and we tend to see it pretty much throughout the use of these bispecifics, given that we are, as of right now, continuing to use them on a continuous basis. The other side effect of note with these bispecific T-cell engagers is the risk of infections. We've seen about 51% of infections in patients who had the recommended phase 2 dose of teclistamab, and 45%, about 20 or 25% of these were grade 3 and 4 infections. Outside of that, in general, it was otherwise well tolerated. If you look at the response rate of teclistamab, we saw an overall response rate of about 63%, with about 40% of patients achieving a CR or better, with nearly 60% of patients achieving a VGPR or better. The median follow-up on the teclistamab trial was a little short of 8 months. The median time to first response with all of these bispecific T-cell engagers is about a month or so. And if you look at the progression-free survival at a median, the median progression-free survival was about 11.3 months. MRD negativity was measured, and again, these are very heavily pretreated patients. About 25% of them were MRD negative at a sensitivity of 10 times minus 5. Now, if you look at those 40% of patients who'd achieved a CR, about 42% of these patients actually achieved MRD negativity. So this was the teclistamab trial. The teclistamab is now approved in the context of myeloma. It is approved in the setting of more than 4 prior lines of treatment. I presented the MagnetisM-1 study at this year's ASH. This is elranatamab. This is a very similar bispecific T-cell engager, again targeting BCMA and activating your CD3 cells. We did a first-in-human phase 1 dose escalation trial, starting with doses of 215 micrograms, going all the way to 1,000 micrograms, and now we have a recommended dose. With this, we saw an overall response rate of about 64% in the entire patient population. What was neat about the MagnetisM-1 trial was the fact that prior BCMA was allowed. So about 54% of these patients had had a prior BCMA-directed strategy. Obviously, it was not a bispecific T-cell engager. They could have had CAR T cells, or they could have had an antibody-drug conjugate, and we saw half and half of those, half of them having had CAR T cells. A couple of these patients had had both the antibody-drug conjugate as well as the CAR T cells. The overall response rates in patients who'd had prior BCMA was a little bit lower, but not that much lower. So the overall response rate in the entire patient population was about 64%. When you look at those who had prior BCMA-directed treatment, it was about 54%. And again, as with teclistamab, the median time to response with this was within the first month or so. And as you can see in this swimmer's plot out here, you have ongoing responses going way up to 3 years or so with elranatamab. The median duration of response in the responders was about a little over 17 months. And if you look at the median progression-free survival of all patients, it was 11.8 months. I don't have a toxicity slide on this, but very similar to teclistamab, the CRS rate was about, if you take all grades, it was about 80%. Once we did the step-up dosing, it went down to 62%. Most of the CRS with elranatamab was grade 1 and 2 and was easy to manage. This is just a highlight of all of the different bispecific antibodies which are in clinical trials. Up top is teclistamab, elranatamab, and there's several others which are in clinical trials. The one which is different is the ABV 383. It's different because it's IV fixed dosing and it's given once every 3 weeks, unlike some of the others. Alnuctamab was also presented, and early data with alnuctamab, which is the BMS monoclonal antibody, looks quite promising as well. So moving on to what do we do with this? Well, there was some data which was presented. This is the TRIM2 data where teclistamab has been combined with daratumumab. This was done in 37 patients. The idea here is to improve upon the response rates in this patient population. All of these patients, a lot of these patients had had prior exposure to daratumumab, and in fact, about 60% of these were in fact refractory to daratumumab, which is in general the patient population that we see when they're going for all of these treatment strategies. What was notable with the TRIM2 trial was that the toxicity in general, well-tolerated combination, and we are seeing an overall response rate of about 80 to 100%. So certainly combining with daratumumab, teclistamab, you're seeing a slightly higher response rate. The duration of response, it's too early to tell, but we are seeing people responding well beyond a year as well. I think the key to look at in this data set is going to be the rate of neutropenia, the rate of myelosuppression, and the rate of infectious complications. And I think we need a longer follow-up with this combination to figure that out. These are some of the other targets that are being studied in the context of myeloma. Talquetamab. Talquetamab is a bispecific T-cell engager targeting the G protein coupled receptor. And then there's civostamab also, which is targeting the FcRH5 protein on the multiple myeloma cell. So this was data on talquetamab. The NEJM paper came out simultaneously as Dr. Chari presented this at this year's ASH meeting. Again, talquetamab is a T-cell bispecific antibody which targets GPRC5D. We know that GPRC5D is a novel antigen-targeted myeloma. I still think it's a little bit unclear as to what the mechanism of this protein is in the context of myeloma biology, but nonetheless, given that it's overexpressed on myeloma cells, it seems to be a good target for these immune therapy strategies. If you look at the overall response rates with the Monumental trial, the overall response rate is about 74%. There were 2 doses which were tested, 0.4 and 0.8, given either Q weekly or Q2 weekly. And going forward, I think they're going to be giving it every other week, and they're going to use the 0.8. This was again in a heavily pre-treated patient population. Clearly, these patients were not BCMA exposed. Again, the median time to response with all of these bispecifics is very early, happens within a month or so. And the median duration of response in all of these patients was about 8. When you take all patients in total, it was anywhere between 8 to 11 months. If you take patients in complete response, these patients are actually continuing to do well, and their median duration of response has not yet been reached. Obviously, you know, these are off-the-shelf treatment strategies. As of right now, when we're doing them in the context of clinical trials, we are admitting our patients for the first week when they come in for their step-up dosing with these bispecific T-cell engagers. So I thought this was a really interesting trial, which Suzanne Trudell did. This was using civostamab. Civostamab is the bispecific T-cell engager targeting the FcHR5D protein. And what they did here was pre-treated patients with tocilizumab. And the idea here was to see if these, in fact, can be given as outpatient. So just to recap again, civostamab targeting FcRH5, it's a CD3 bispecific antibody. And what the investigators here did was give tocilizumab before patients got even the step-up dosing of this civostamab. So on day 1, they got 8 milligrams per kilogram of tocilizumab. Then they got the step-up dosing of civostamab. And what was noted out here was, you know, without the use of tocilizumab, the rate of CRS was 90%. Most of it was grade 1 and 2. And with the addition, or with the pre-treatment with tocilizumab, it was significantly downgraded to about 38%. Again, making the case that we could actually think about using these approaches in the majority of patients as an outpatient, which would be the future for bispecifics. Again, giving tocilizumab to these patients did not seem to impact efficacy of civostamab in any way. What about the future of bispecifics? Well, as I mentioned when I started off, we are still in the very early days of bispecific antibodies. I showed you those different platforms. There's a whole lot of things one can do. And there's already work which is happening with tri-specific T-cell engagers, wherein you're targeting the T-cells, you're targeting the antigen of interest, and we are also including a co-stimulatory protein domain such as CD28 or CD3 zeta, very similar to what we're doing with CAR T cells. And with that, we're seeing, at least in preclinical models, really significant killing of anti-myeloma cells. There is ongoing trials with a tri-specific antibody as we speak. It's targeting CD38, and hopefully you will hear about data coming out very soon in the next couple of years. Shifting gears now, I'm going to talk for the next few minutes on the CAR T cells. You're all familiar with ide-cel or idacaptogene bacleucel, which was approved in 2021. This is an autologous CAR T cell product, targets BCMA, and it has the 4-1BB co-stimulatory domain. Along with this, we have another one, which is ciltacabtagene autoleucel, or cilta-cel, which is also approved in the context of multiple myeloma. This was approved late last year. And as of right now, at least in the United States, the FDA label suggests that patients have to have 4 prior lines of treatment. They have to have had an IMiD, a proteasome inhibitor, and a CD38 monoclonal antibody before they can get CAR T cells. Now, if you compare ide-cel and cilta-cel, both of them from a toxicity standpoint were in general comparable. Obviously, because they are different drug products, their kinetics of when the toxicities happens was a little bit different. With cilta-cel, we see the median onset of CRS is about 7 days. With ide-cel, we see it within 1 day. This becomes important if one starts thinking about doing CAR T-cell approaches as an outpatient. As far as the immediate ICANS was seen, very comparable toxicity, infectious complications were the same. What was different with cilta-cel was a slightly higher rate of delayed neurotoxicity, 12% or so, and this was grade 3 or 4 and progressive and not reversible. And we believe that this is an on-target off-tumor toxicity seen wherein patients develop this Parkinsonian-like syndrome. Obviously, efficacy is also quite different between cilta-cel and ide-cel. The overall response rate with cilta-cel is 98% with a CR rate of 82%, whereas the overall response rate with ide-cel was 73% with a CR rate of 33%. MRD negativity, again, very different, 92% for cilta-cel versus 26% for ide-cel. The PFS not reached with cilta-cel. The median PFS for ide-cel is 8.5 months. Overall survival at 24 months is 74% with cilta-cel, with a median of 19 months with ide-cel. So from an efficacy standpoint, clearly differences between ide-cel and cilta-cel. In terms of kinetics of manufacturing and failure rate, surprisingly, we were able to manufacture in the majority of patients. There was really very low failure rate for manufacture in the late relapse refractory states of multiple myeloma. So in the context of CAR T cells, what's next? Some of this was presented at this year's ASH as well. Clearly, we are very interested in understanding why CAR T cells in the context of myeloma stop working. And the mechanisms of resistance could be diverse. They could be CAR T cell intrinsic, they could be tumor cell intrinsic, or also dependent on the microenvironment. And there are different strategies which are already ongoing in the context of myeloma to try and overcome these different resistance mechanisms. Strategies to overcome T cell fitness, for example, there is the PBCMA CAR T cell, which uses the transposition method of transfecting these T cells with the idea of ensuring that you have a more naive memory-like phenotype so that these T cells last longer. We did a study with a PI3 kinase inhibitor, BB21217, again enriching for the naive memory-like T cells. Obviously, surprisingly in myeloma, we are seeing such high response rates in patients. So I don't think we are in general able to activate T cells in the majority of myeloma patients. But in the subset of patients wherein they have such a high degree of T cell dysfunction that none of these immunotherapies work, I do think allogeneic CAR T cells may be a strategy. There's already a allogeneic CAR T cell trial which is ongoing, and early data looks quite promising. We at MGH are doing another CAR T cell. This is a CAR T ddBCMA from Arcellx. And what it does is utilizes a novel synthetic binding domain of the BCMA. And with that, you can add different linkers, different binders. And by doing so, you can target BCMA surface antigen much, much better and more tightly. And with this, at least our early data, which was presented by my colleague at this year's ASH, shows a very high response rate, and response rates very similar to what you're seeing with cilta-cel already. Other things which can happen is loss of BCMA or downregulation of BCMA. And to overcome that, we know that gamma secretase inhibitors can in fact increase BCMA expression on myeloma cells. So not at this year's ASH, but at last year's ASH, the Fred Hutch group, Andy Cohen, presented this data wherein they pre-treated patients with a gamma secretase inhibitor. By doing so, they were very nicely able to see an increase in BCMA expression on myeloma cells. A lot of these patients had already had prior BCMA, and you are seeing high response rates. I think the word of caution by using gamma secretase inhibitors is we did see a significant amount of neurotoxicity, and this is something we're going to need to watch for in the future. Again, loss of BCMA or biallelic loss of BCMA has been described in the laboratory. It happens in the minority of cases. About 2 or 3% is the incidence of this total BCMA loss. And if you have this, you should go after a different target. And like you've seen data with the bispecifics against GPRC5D, there's a CAR T cell, the MCAR-H109 CAR T cell product is in clinical trials. This data has now been published by my colleague at Dana-Farber. And what was seen here was patients who'd had prior BCMA as well, with a really high response rate of close to 80%. So nice data with this CAR T cell directed against GPRC5D. At this year's ASH, we had the BMS CAR product, again targeting GPRC5D, was shown preliminary data on the first 30 patients was 20 patients was presented. Half of these patients had prior BCMA. And again, the overall response rate in this patient population is extremely high. So another novel target with showing efficacy with this CAR product, and response over time seems to deepen, and we see responses going well beyond a year as you go up to the recommended phase 2 dose of this GPRC5D CAR T cell product. Obviously, there are, again, opportunities for us to do a whole lot better, opportunities for combining, and these trials are already happening in the context of some of these CAR T cells. For example, combining the CAR T cell with an IMiD is already ongoing. And obviously, we've tested all of these CAR T cell products in sort of end-stage myeloma. There's a whole bunch of early phase clinical trials which are ongoing as we speak. The KarMMa-2 cohort 2 was presented at this year's ASH. Cohort 2 was close to 100 patients. The 2A cohort was presented, and these are patients who had an early relapse after their initial therapy. An early relapse was defined as within 18 months of them having had a stem cell transplant, and these are generally the high-risk patient population. Now, the primary endpoint here was met. You saw 49, close to 45% of these patients achieving a complete response with an overall response rate of 83%. And this translated into a median duration of response of about 15 months. And those patients who achieved a complete response, their median duration of response was close to 2 years. Other upfront trials are ongoing. So very similar to KarMMa-2 is CARTITUDE-2. You have similarly two cohorts, cohort A and cohort B. Again, high response rates. And I think we just have to wait and see as to what the duration of response with all of these CAR T-cell drug products are going to be. There are ongoing trials which are accruing as we speak. CARTITUDE-5 is a randomized phase 3 trial in newly diagnosed patients who are not intended for transplant. And similarly, there's CARTITUDE-6, wherein CAR T-cells are being placed against an autologous stem cell transplant so that they are being used in the upfront setting of multiple myeloma. So I think, just to summarize all of this, the future, obviously, we are just in the beginnings of where we are with all of these amazing immunotherapeutic strategies. There's a lot of work which we can be doing. We've talked about some of these already, but we could have tandem bispecifics followed by CAR T cells. You could have dual targeted CAR T cells, and you could have tri-specific antibodies as well, which are in the works as we speak. So I think in general, the immune system obviously is really important across myeloma. BCMA we've shown as a validated target. And in addition, I've shown you data with GPCR5D as well as FCRH5, both antibody drug conjugates, bispecifics, as well as CAR T cells are showing very promising efficacy. And we're already doing trials now where we're combining CAR T cells with bispecifics with the idea of improving upon the duration of response. So with that, I'd like to acknowledge my team at MGH, which helps take care of all of these patients. These are tough to take care of patients, but we have an incredible cellular therapy team as well as a myeloma team. And I thank you for your attention and happy to answer questions. Thank you.
Thank you, Nupur. I really appreciate you being present virtually, and listening to a recorded talk is not the same. So thanks a lot. And listening to you, 2 times, one face to face and one virtually, over 2 weekends, consecutive weekends, my myeloma knowledge is really going through the roof. So thank you again. So my question to you. So my question to you, Nupur, is that with these new agents coming in, the bispecifics and the CAR T cells, and I'm sure they're going to move up front in the newly diagnosed high-risk patients also, will we be able to do away with the transplants? Are you investigating a time like that?
I hope so. So I'm very enthusiastic about CARTITUDE-6, which is why I showed you the, if you'd asked me when with just a Abecma out there, I would have said probably not, which is ide-cel. But the data that we're seeing with cell-to-cell, there is real hope that we're going to see long-term disease control. Obviously, we have to offset the toxicity. And even, if you look at the CARTITUDE-2 second cohort, we did, despite the mitigation strategies for the neurotoxicity, we saw a little bit of neurotoxicity in that patient population. So I do think we have to balance the efficacy with the neurotoxicity, but ultimately, if we are able to tumor reduce these patients and really decrease the incidence of this long-term Parkinsonian-like syndrome, absolutely, we should be replacing an autologous transplant.
Thank you very much.
Yeah, nice talk, Nupur. So I know that T cells are the fast horse compared to the other component of the immune system, which is required for the immunotherapy. Considering the toxicity available with the CAR T cell trials and experiment, I mean, just for my knowledge, I'm asking what is the scope of the CAR macrophages? Because macrophages is also a very important component of the multiple myeloma and other tumor microenvironment. So did you ever combine with the clodronate or any specific drug or CAR macrophages? Because howsoever T cells work, if the macrophages are in a good mood or bad mood, they dictate the T cell activity. That's at least we have seen in the pancreatic cancer. So what is your take on that?
Yeah,
Considering
no, I
the
think,
toxicity, considering the
yeah, no.
toxicity.
So, I think you bring up a really good point, and that's why I told you at the outset this, we are so much at the beginning of immunotherapies in myeloma. I do think learning about macrophages, using macrophage CARs as well would be actually very useful. We're using monocytes. These are all sort of preclinical studies as we speak, but the future would be to try and use macrophage CAR, NK CARs, and try and utilize those. The good news is, from a toxicity standpoint, with with the CAR T cells, we've been fortunate. We've not seen a whole lot of negative toxicity. With the bispecifics, I still think infection is a problem because of constant sort of stimulation of the T cells and causing exhaustion and creating all kinds of weird infections. And that's where I think combining with NKs and macrophage CARs are going to be critical.
I think, if we combine the macrophage CAR, then we will actually promote the palatable component of the therapy also. That's what I feel.
Yeah, absolutely. I think combining, which is why, I just ran through the slide of other components. So that's part of the microenvironment, right? And if you can do anything but I also think, I don't think it's going to be one size fits all. I think this is such personalized medicine. So for us to better understand the resistance mechanisms and then use some of these other strategies in combination more from a patient-specific standpoint is what we should be doing.
Agree. Thanks.
There are any more questions? I would like to ask a question, Dr. Ajay. You mentioned about several methods to target BCMA. So which method, like by specific antibody or a CAR on a targeted treatment, where would you feel like the direction is headed? Which would be the most preferred BCMA targeted therapy in the future?
Right. So if all things were equal, right now, I think the best efficacy is with the CAR T cells, obviously. So if your patient is able to get CAR T cells, we would prefer that happen. Clearly, by CAR T cells with manufacturing, etc., it's not as readily and easily available. So while waiting, the one word of caution I would have, though, is if you're thinking of using CAR T cells in somebody, don't keep them too long on a bispecific T cell engager because you might prevent them from being able to generate good CARs.
No more questions. We'll wrap up this session. Thank you, Dr. Ajay, for joining us virtually, and it was a really enlightening talk. And we'll close the session. Thank you.
Thanks so much. Bye.
Thank you, Dr. Nupur Rajay. Thank you, Dr. Aparna Parikh. Thank you, Dr. Naveen Gupta. And next we move on to the session of immunotherapy in acute leukemia. And may I invite Dr. Priyanka Soni. Dr. Priyanka Soni is assistant professor here with us in this university in the Department of Pediatric Hematology Oncology. Along with her, may I request Dr. Kritika. I think she is on her way. Dr. Priyanka, can you start the...
Very hearty good morning to all of you. So we are moving on to the next session, which is very interesting session on immunotherapy in acute leukemias and the recent advances in ALL management. Curiosity keeps leading us new paths. So for this, I would like to invite Dr. Dharma Chaudhary, who is a well-known hematologist and transplant physician. from Gurugram.
Thanks, organizer Dr. Hemant, Dr. Lalit for inviting me to deliver a talk. So I'll speak about the next 15 minutes about what is new in ALL. And so we know adult ALL had dismal outcome. Around less than 40% patients are cured because of high-risk disease, and there's significant chemotherapy-associated toxicity. And we know historically, Ph-positive ALL had bad outcome pre-TKI, and in this current era, detection and monitoring of MRD has become standard of care, not only in stratifying patients, but also guiding treatment strategy, particularly selecting patients for transplant. And there are various newer immunotherapeutic targets like BCR will target TKI kinase inhibitor in the TKI novel antibody construct and CAR T-cell. So all we know about this cytogenic risk group of B-cell ALL, and most of the patients in adult ALL, they will fall into poor risk category. Only good risk will be hyperdiploidy case. And the problem with the poor prognosis in the ALL relapse, because once you relapse, first relapse outcome is usually around less than 10% 5-year survival. And it has been confirmed in 2 studies, MRC, UKLL, and LALA study. And we know the relapse and refractory ALL survival is dependent on response to salvage therapy. So wherever you have a better response, you achieve CR, their outcome is better because they can undergo transplant and they can live longer. So the aim is to convert the patient into CR in the relapsed refractory setting, and CR rate is usually less. And these are conventional treatment regime with varying response in the refractory ALL, ranging from 18% to 50% the response rate in the first relapse or second relapse. So number of relapse is increasing, the response rate goes down. So in India, if you look at the ALL ranging from various studies from adult ALL from 8% to 50%, various treatment protocols are used, and outcome is ranging the overall response rate from the 46 to 90% reported from the AYA to the adult ALL, but overall response rate between 25% to 57% within the median time of 9 to 24 months. And the marrow is frequent relapse site. And the treatment option in India is like most of the patient goes for palliative care treatment, or some patient do accept salvage treatment, but majority of patients do die. So rationale for including immunotherapy in ALL regime is the adult ALL is chemo-resistant. There are always MRD positivity. The treatment mortality is very high, and the improvement in the response upfront of salvage has been reported with various studies as the combining hypersevere rituximab, inotuzumab versus standard of care salvage therapy, immunotherapy, and CAR T-cell in salvage. So we know there are new option, new treatment modality is there. And what makes it an ideal therapeutic target in ALL, because there's favorable antigen feature, with high percentage of blast expressing the antigen, there are high density of antigen expression, and there are lack of expression of normal cells. So you can use immunological target by using these criteria, and the expression of antigen in B-cell ALL basis for practical cell therapy. And we know the 3 targets, CD20, 19, and 22, it's been used, and the drugs CD19 either blinatumomab or Tisacel, or CD20 the inotuzumab, which is available in India now. So coming to the talk, the pH negative ALL relapsed refractory setting, what we can expect is dismal prognosis with CR rate of around 20 to 40%, median overall survival of 6 months, cure rate of less than 10%, even with the intensive salvage chemotherapy in HSCT, and the improved outcome, as I said, INO, Blina, or CAR T-cell, or in BCL2 inhibitor, venetoclax and navitoclax. So this table will summarize the novel agent which is approved as single agent in B-cell ALL. And if you look at inotuzumab, INOVATE, the study which brought the approval of this drug, 109 patients studied, median survival age of around 47 years, CR rate of around 80%, MRD negative rate is around 80%, median relapse survival of 5 months, and overall survival 7 months. So the inotuzumab approved by the study, and those achieved patient CR, they can go into transplant, and then they can have a good long-term survival of around 40%. Blinatumab Tower 2 study of 271 patients, CR rate of around 45%, MRD negativity rate around 76%. Again, median survival is overall survival is 7.7 months. When the other study of the blinatumab, and particularly BLAST study, which was brought the blinatumab to approved for MRD positive patients to after treatment to convert to MRD negative, 113 patients, which median age of 45 years. It can bring the MRD with negativity in the tune of 80%. The overall survival around 4 years, and which brought this one. And T cell, the single agent anti-CD19 T cell MRD negativity rate is around 100% and median survival of 19 months in the study. And the novel agents, the immunological has been also studied with the chemotherapy and the results. So the Blincyto or Inotram with mini hypersevered for these adult ALL who are not that fit, CR rate of around 80%, MRD rate around 80%, HSCT rate, because they are putting these patients into the MRD negativity and you can put them transplant. So 40% of patients can go into transplant. Oral survival around 2 years, it's 40%. So these targeted agent has been combined with the various drugs, and then Inotuzumab has been studied with the CVP or with the venetoclax and navitoclax combination. These all in the relapsed refractory secondary of pH negativity. Around the 25% to 40% of patients can be transplanted and they can lead normal life. So these combination has been studied in frontline pH negative setting, older ALL, and the age is more than 60. Both Blincyto with the mini hypersevered or POMP maintenance, around 66% in the POMP maintenance, and 90% of the patients with mini hypersevered can achieve complete response rate. MRD negativity rate in this study also around more than 90%. And the median survival, overall survival at 3 years is around 54%. Or in the mini hypersevered and 65% in the POMP maintenance with Blincyto. And pH negative ALL, younger ALL, the AYA, sequential hypersevered in Blincyto will be 96% of the MRD negativity rate, and the survival is really almost 90% at the end of 1 year in the study. So the issue comes with the older adult, the frontline therapy. The challenges are the clinical factor, decreased performance status, there's increased number of comorbidity, decreased organ function, there's polypharmacy because of multiple other comorbidity, frequent dose reduction, delay or omission, high risk of adverse event. And there are also biological factors because these all fall into high risk feature, increased incidence of adverse karyotypic like low hypodiploidy, near tetraploidy, and complex cytonics. The lower incidence of favorable risk factor and higher incidence of adverse risk molecular signature, particularly pH chromosome like or T50 mutation, social factor, and other factor, which bring down the response rate to this patient very dismal. Coming to the pH positive relapsed refractory setting, what we can accept in this current era, all the published frontline trial TKI, intensive chemotherapy with TKI in young patients, imatinib to ponatinib, the HSCT rate in this is around 20% to 70%. Overall complete molecular response is around 60 to 80%. Relapse-free survival in all these studies ranging from the 45% to 80%, and highest with ponatinib, and overall survival rate is around 50% to around 80%. So you can use these intensive chemotherapy, those who are fit patient with TKI, and you long-lasting remission, and you can even those patients who achieve the quick MRD negativity, you can avoid transplant. Lower intensity chemotherapy you use for or elderly patients with the same result. If around 50 to 90% of patients, you can have long-term overall survival. And wherever the patient is unfit, you can steroid and TKI, and that you can use TKI with blinatumab, which can give rise to the relapse-free survival rate of around 80% and overall survival of 90%. So the effort has been going in using these inotuzumab, blinatumab with the TKI and giving the chemo-free survival of the good acceptable range. Word about T cell ALL. T cell ALL are usually treated with the same regimen like B cell ALL, have a similar response, except the ETP ALL, where response rate and outcome are significantly worse. There's no novel therapy for T cell, like there's no monoclonal antibodies or CAR T cell. There are limited salvage options, mainly high dose chemotherapy and transplant. So one drug which was approved, the Nelarabine T cell specific analog, which has shown efficacy in relapsed refractory ALL of around 30 to 40% CR, and this allowed patient to undergo for transplant and achieve long-term survival. So Nelarabine, when used in upfront patients in the AYA patients, it can give us to 4-year DFS rate of around 85% alone, and in combination around 90%. But it was not showed any improvement when you use Nelarabine and either upfront chemotherapy in the adult ALL patient who are more than 31 years. ETP-ALL is associated with the lower frequency of Notch1 mutation, the lower response to therapy, high rate of post-induction MRD positivity, and there are inferior survival compared with non-ETP-ALL. Thus, and ETP-ALL cells are preferentially sensitive to BCL2 inhibitor like venetoclax. So people are using this venetoclax in the combination wherever ETP-ALL comes. A word about Nelarabine as salvage therapy and bridging to allo transplant. As I said in the beginning, those patients who achieve complete response with the chemotherapy, their long-term outcome is better. So when you do transplant in CR or PR with the using of Nelarabine, your outcome is particularly 2 years after this, there's no relapses. So curve is flat and you can achieve the 40% of overall survival, 5-year probability in these high-risk T cell patients with Nelarabine. Another word, the immune target is CD20 positivity in B cell ALL. So we all know that addition of anti-CD monoclonal antibody to multi-agent chemotherapy is standard of care for patients who are younger, below 60 years, with CD20 B cell ALL, which is defined as expression of CD20 is more than 20%. And the standard is 12 doses of rituximab added to hyper-CVAD, improved outcome of patients who are younger than 60 years, CR duration of around 67% versus 40%, and overall survival of 3 years at 75% versus 47% compared with hyper-CVAD alone. So that in the CD20 positivity, if you used rituximab with the hyper-CVAD intensive chemotherapy, your outcome is as equal to AYA patients. And these results were confirmed in other studies also. Second generation anti-CD20 agent ofatumumab, which has higher complement-dependent cytotoxicity and slower dissociation rate compared to rituximab. And what is the benefit of ofatumumab is that it has been evaluated in phase 2 study in patients with combination with hyper-CVAD with any level of CD20 expression. So even low level of CD20 expression around more than 1%, ofatumumab can work. And the clinical benefit was seen in across all CD20 positive group, whether CD20 expression is less than 20 or more than 20. These results appear similar to historical control treated with hyper-CVAD versus with rituximab, with 4 years overall survival and event-free survival rate of around 60% and 70% respectively. Therefore, ofatumumab is a reasonable option for CD20 positive ALL, especially with the lower level of CD20 expression. And these two agents is actually, if you routinely use, and rituximab is very affordable in this country, the outcome can be improved in adult ALL patients, at least and AYA patients very well. So word about in the current era, incorporation of MRD into therapeutic decision making. So earlier, the pediatric ALL, everybody was looking for MRD-based treatment. And adult also now, the consensus guidelines recommend MRD assessment to be done after induction, in early consultation after approximately 3 months of therapy, every 3 months thereafter, and prior to transplant. So regardless of method used, either you do flow space, PCR, or NGS, minimum sensitivity of 10⁻⁴ is recommended for adequate MRD assessment. In pH positive ALL, this you do PCR with BCR ABL, genuine preferred method of MRD monitoring. Optimal timing of MRD assessment is treatment dependent. Early achievement of MRD at the end of induction has generally been associated with the better outcome than MRD negativity achieved later. So MRD detection and monitoring has not only prognostic but also therapeutic implications. Patient with MRD positivity derives benefit from HSCT in this adult ALL group. And blinatumomab has shown greater efficacy in patients with MRD positive disease. And the BLAST study, which brought the blinatumomab approval for MRD directed therapy, 116 patients studied those who have MRD detection level of more than 1%, an MRD clearance rate of around 80% after 2 cycles of Blincyto. The 4 years overall survival was 40%, which compares favorably to expected outcome of MRD positive patient around 30%. So Blincyto was approved as MRD directed therapy. So roll-up transplant in the current era, we know all the adverse certain feature in adult ALL, low hypodiploidy, near tetraploidy, complex karyotyping, which is more than 5 chromosomal abnormality, and pH like ALL are indication of HSCT in CR1. In T-cell ALL, ETP ALL is derived benefit from HSCT in CR1. The presence of NRAS and KRAS mutation or PTN gene alteration, other risk, high risk molecular feature among T-cell ALL, which can be considered for transplant. The advent of MRD assessment has defined the treatment landscape of all AML in pH positive ALL, and now after the ponatinib, probably those patients who are treated with hypersevere with TKI without HSC, 4 years overall survival around 66% in patients who achieve CMR at 3 months, suggesting that HSCT may not be needed for all patients who are pH positive ALL. So early 5-year-old survival patient treated with HSCT with ponatinib who did not undergo HSCT is around 83%. So the root is that if you achieve MRD at 3 months with the TKI and the chemotherapy, you may not need the transplant in pH positive ALL. So this is what this is recommended now. This pH negative B cell ALL, MRD negativity, poor risk category patients you consider for transplant. Otherwise, you can do consolidation or maintenance chemotherapy. MRD positive, these patients, they should undergo blinatumomab or inotuzumab before transplant. Consider HSCT after achieving MRD negativity. pH positive ALL, we all know about TKI or with chemotherapy, or those who do not achieve CMR within 3 months, then you use Blincyto or inotuzumab. Blincyto is approved. Inotuzumab is still in clinical trial. Consider HSCT based on MRD responses. T-cell, those who achieve MRD negativity, other than ETPL, probably you need to consider only continuing chemotherapy and maintenance therapy. Wherever the MRD positivity, you have to treat MRD directed therapy and then consider for transplant. So what NCCN says about this pH positive ALL or AYA or more than 65-year TKI along with chemotherapy or whatever the response can be assessed by more than 65 years patient, whatever the treatment can be given. Ultimately, it's all patients who achieve CR and MRD dependent treatment is guided. pH negative ALL is again the same. Blincyto should be considered those who have persistent or rising MRD. So I'll end here and probably take the question, because in the relapse refractory setting, probably we all have to accept that these agents which is available freely in immunotherapy landscape, Blincyto and inotuzumab, if we use them or rituximab or ofatumumab, probably we can improve the outcome, and MRD assessment should become a standard of care. Thank you.
House is now open for questions.
Thank you, Dr. Dharma, for a good overview of this presentation. I have a simple question, is that do we have any data, Indian data, on the use of Nivolumab? How many patients have used it? Because theoretically, we every time say Nivolumab, but practically at our center, I will say that whenever patient of T-cell comes with relapse, we give an option of Nivolumab. So far, we have never been able to use this Nivolumab. Do we have such any data in our scenario?
I looked at this no data for Nivolumab, published data from India. People use theoretically sometimes, depending on patient choice. Dr. Reena, probably Tata has any data. Yeah. Yeah. We also have the inotuzumab, which is officially available, so we can use in most of the patients. But otherwise, it's been to gray market and it's very difficult to procure and put for most of the patients. Yeah.
Excellent and comprehensive talk, Dr. Dharma. So my question is related to pH positive ALL. So you showed about the data of 3-month CMR and avoiding transplant. So till now we have data which is retrospective, say from multiple centers. So my question to you is that do you really use that 3-month CMR benchmark to decide transplant versus no transplant in your patient, both pediatric and adult? I want answer for both.
So till date, we are putting Ph positive as a high risk, and wherever possible, matched sibling donor, I take them for transplant.
Irrespective of molecular response.
Irrespective of MRD.
Okay,
So we try to bring them MRD negative before taking for them to transplant. So it's not early achievement of MRD. We will discourage them for transplant if there is matched sibling donor is available. Rest of the patient, I continue with the chemotherapy along with TKI, and then give TKI as in maintenance also. That's what is our standard of practice as of now. Because this ponatinib, we are not even able. So imatinib and these other. But the problem with dasatinib or whatever Indian dasatinib use, there's so much of break because of proliferation and toxicity. So we don't know whether really we will be doing justice to these patients.
Thank you.
So any comment from the expert here, Dr. Rina?
Sir, I have one question. So in PH,
This one.
At MRD negativity now. We do look at MRD negativity now, and we are beginning to become comfortable without taking some of these earlier high-risk patients for transplant. The problem is those who are high-risk and MRD positive also, not even 20% can go in for transplant. So they also continue to have the same TKI-based therapy. My question will be pH positive, in remission, MRD negative, finish treatment for 2 years post TKI. When will we stop TKI in these patients?
So we continue till 2 years with the like pump maintenance or any. So
Yeah.
we are stopping at 2 years.
Okay, we are kind of a little stuck. We haven't yet stopped, and some have gone into 4 and 5 years. And there is always this doubt when you stop, what happens. So
there's no clear-cut guideline.
I mean, adults we continue till they can continue, just like the way we continue in CML. But in pediatric, colleague from our institute, they stop it after some time.
yeah, these are, the young adults which we would be treating, and I honestly don't have an answer, but I thought I can ask you.
Samir, any comment from you? It's in pediatric.
Okay, so my comment is exactly what I am also confused, but what we do is we continue till the end of maintenance. And after maintenance, that is the only time I do the molecular workup for BCR-ABL. I monitor for around 1 year. If it stays negative, then I stop it 1 year after completion of maintenance. That's how I do. Again, I'm not sure if that's the right approach, but that's what makes me comfortable.
We also continuously monitoring MRD as at least BCR-ABL through the blood regularly in these patients who comes from follow-up. Yes, but Priyanka.
the same question regarding pH positive ALL. I just wanted to ask, like you said, 3 months. So do you really evaluate 3 months, or we because we follow mostly we monitor by flow MRD. So do you prefer doing qPCR for all the patients, or you monitor by flow MRD also?
So the currently recommended best MRD monitoring for pH positive is molecular, because this is the more reliable BCR-ABL. So flow tests there is so much of variation from even center to center. So I would not recommend for pH positive ALL monitoring with the flow.
And what is your preferred TKI?
We use dasatinib for all pH positive ALL. Wherever possible, because there's CNS penetration, you have multiple advantage, and dasatinib, no imatinib or nilotinib as of now upfront.
Thank you, sir. Any other questions? Okay.
Thank you so much.
Then we can close the session. It was very enlightening and concise talk. Thank you, sir.
So for the next session, may I request Dr. Ruchi Chaudhary Dr. Ruchi is faculty in Department of Pediatric Hematology Oncology at SMS Medical College Hospital, Jaipur. And along with her, Dr. Pawan Sulania. Dr. Pawan is also in the Department of Pediatric Hematology. Thank you so much for joining. Please come forward. The next talk is by Dr. Hari Menon. On the screen also, Dr. Pawan, it's on the screen also.
So good morning, everyone. So the topic is immunotherapies in AML, way forward into the future. So I would like to invite our speaker, Dr. Hari Menon. He is the professor of hematology and head of medical oncology, St. John's National Academy of Health Science, Bangalore. Okay.
Good morning, dear friends and colleagues. Greetings from Bangalore. I hope you've been having a good conference, and I wish I could be there today in person to be attending the 4th annual Congress of the Indian Oncology Society of India. So the Immune Oncology Society of India, I'm sorry. So the topic for discussion today is a little bit of a difficult topic, but I'll try to do justice to the same. And it's on immunotherapy in acute myeloid leukemia, the way forward and into the future. So when we talk about acute myeloid leukemia, we are looking at a very, very diverse kind of a disease, and it's genetically, epigenetically, and clinically a very heterogeneous disease. It's characterized by accumulation of immature myeloid cells, which leads to which eventually leads to a marrow failure situation, and many of the clinical outcomes in patients with acute myeloid leukemia still remains suboptimal. So we do understand that the bone marrow microenvironment in myeloid leukemia is profoundly altered, contributing to the severity of the disease. And this probably gives us a window of opportunity to prompt or rewire a proficient anti-tumor immune surveillance. Now, when we look at the survival of acute myeloid leukemia, we are looking at not a great improvement in the last 20 years, but truly the understanding of the tumor biology of the disease and the better improvement in supportive care, and also the advent of better transplant measures in acute myeloid leukemia and newer strategies of doing transplants in acute myeloid leukemia has led to better survival. And we still are left with these curves where we are having the good risk acute myeloid leukemia doing well, but still to the tune of about 60% cure rates, closer to 60% cure rates, with the poor risk continuing to do worse, and the intermediate risk, which is a whole load of diverse acute myeloid leukemia having varying outcomes, again to the tune of about 30%. So we also understand that the outcomes are quite dismal in the elderly population, wherein we encounter more of adverse profile acute myeloid leukemia. So the questions that emerge are, can we improve the outcomes in acute myeloid leukemia through other approaches, and is there merit in exercising immune manipulation in the form of immunotherapy in myeloid leukemia? But always a question asks us, why immunotherapy? And for that, we need to understand the mechanisms that are involved in how the leukemic blasts escape the immune system, what is known as immune evasion in myeloid AML. And also, what are the strategies we can exploit or we can implement to overcome these immune manipulations? So the current options that are available for immunotherapy in AML and the outcomes are are probably the most robust way that we can deal in the form of immunotherapy in acute myeloid leukemia, which has stood the test of time, is allogenic bone marrow transplant. So this is something that the EBMT in a megafile analysis of more than 8,000 patients brought about. What we do understand among the hematological malignancies, even though the chronic myeloid leukemia stands out as one of the myeloid neoplasms which maximally benefits with an allogenic stem cell transplant, we understand that with the advent of tyrosine kinase inhibitors, the indication for chronic myeloid leukemia as a disease, as an indication for allogeneic stem cell transplant, has declined tremendously. But at the same time, we do understand that there is a clustering of responses into which even acute myeloid leukemia falls into, which is included within the cluster of acute lymphatic leukemia, lymphoproliferative disorders, myeloproliferative neoplasias, plasma cell dyscrasias, and the myelodysplastic syndrome. And the responses to these are profoundly affected by the intensity of the acute graft versus host disease, and also to a large extent the chronic graft versus host disease. But if you look at the forest plot over here, you will appreciate that this maximal responses are seen more so in chronic myeloid leukemia and not so much in acute myeloid leukemia, which is quite contrary to what we thought of about more than a decade ago. So thereby saying that irrespective of the responses, I mean the remission rates or long-term durable cure rates that we get in acute myeloid leukemia, the intensity of the acute graft versus host disease, whether it is grade 1 or grade 4, does not seem to impact so much the outcome of acute myeloid leukemia. In fact, the acute lymphatic leukemia is something that has shown better responses in terms of the incidence of graft versus host disease correlating directly with the long-term outcomes in acute lymphatic leukemia. So why is this so? And that is why we come to the concept of whether graft versus host disease is the same as graft versus tumor effect. And in a nutshell, the answer is no. They are quite different entities. For example, graft versus host disease has profound impact on relapse-free survival, and a potent graft versus tumor effect is certainly associated with graft versus disease, but it is not completely dependent on the graft versus disease. And this is particularly seen in acute myeloid leukemia, where we might have a graft versus tumor effect which is independent of graft versus host disease. And that is why we seem to have a clustering of the myeloid leukemia even in the clusters of the myeloproliferative neoplasia or the acute lymphatic leukemia in terms of the protective effects of graft versus host disease being added upon by the cure rates that are induced by the graft versus tumor effect. So there are other non-T cell mediated alloreactivity occurring in the absence of GVHT, which operate beneficially in acute myeloid leukemia. Similarly, there are polymorphisms in the natural killer cell receptors and their ligands affecting the survival of patients transplanted for AML. Similarly, there is also the natural killer cell mediated graft versus tumor effect, which is a very important factor in inducing remissions in acute myeloid leukemia. So these are again evidenced by the fact that in more recent times, when we are doing T cell depleted transplants, we still continue to have excellent responses in acute myeloid leukemia. So this is just a cartoon to demonstrate that the different forms of transplants that have evolved in the last 2 decades, which includes an unmanipulated T cell depleted, haplohemopoietic stem cell transplant, the conventional allogeneic stem cell transplant, and the NKT cell transplant, and also the T regulatory and the conventional T cell haplohemopoietic stem cell transplant, all have induced excellent outcomes in patients without increasing the graft versus host disease. So, so the morbidity associated with graft versus disease, even though one might think that these induce a better cure rate, may not hold true so much, because it is probably the graft versus tumor effect induced by other immunocompetent cells that are translating into better outcomes following transplants in acute myeloid leukemia. So the other forms of transplant which we do, which we'll allude to subsequently, is the allogeneic NKT cells and the autologous allogeneic CAR T cells and the NKT cells. And also you have other modalities of cellular therapy that we will discuss briefly in the subsequent slides. So it is important to understand how to navigate this maze of immune manipulation by first understanding immune evasion in AML. So the pathological immune microenvironment is a distinct occurrence in acute myeloid leukemia. There are both intrinsic and extrinsic immune evasion mechanisms that are involved. So AML expression of antigen is considerably altered in the myeloid blasts. You have expression of overexpression of inhibitory T cell ligands, which include PD-L1, the GAL9, and others associated with the AML blasts. And you also have a release into the bone marrow of reactive oxygen species, especially indolamine to dioxygenase, IDO, arginase, and extracellular vesicles, which results in inhibition of cytotoxic function of the T and NKT cells, NK cells, sorry, and drive the effector T cells, which is T exhaustion and apoptosis. Moreover, there is also an induction of regulatory T cells and myeloid-derived suppressor T cells following the release of reactive oxygen species and the various other enzymes. And they also promote the switch of macrophages from an M1 phase, which is an inhibitory form of macrophages, to an M2 phenotype where they are exhausted. So, so the targets for immunotherapy that one can exploit in myeloid leukemia, and these include the PD-1, the PD-L1, and the CTLA-4, which is conventional, which is also being used in several of the solid tumors. And you have the T-cell immunoglobulin MUC containing, in short, the TIM3, which are involved with the macrophage activation system. And you have also the lymphocyte activation gene, or the LAG3, and the leukocyte surface antigen, which targets the, includes the CD47, which we will allude to. So there are also the immune targets in the leukemic cell, which includes interleukin-3 receptor subunit, and also the myeloid cell surface antigen, which is CD33, which we have been exploiting for quite some time, but not in the strict sense as in for immunotherapy, but as a target to deliver an immunoconjugate in the form of gemstuzumab osigomycin. But in the strict sense, that may not be considered as an immunotherapy. And also you have the C-type lectin-like molecules, or the CLL1, which I had described in the previous cartoon. So what about immune checkpoint inhibitors? So you have various forms of immune checkpoint inhibitors, which is just like any of the other used in lymphomas, wherein you have a domain, transmembrane domain, which is an activation domain outside, and there's a conventional chimeric antigen receptor T cells, which target the CD33 on the surface of the leukemic blasts. And you have the bispecific and the trispecific antibodies, and the DARTs, or the dual antibodies, which are also used, which also have been developed for use in treatment of acute myeloid leukemia. And besides, of course, the antibody drug conjugate, which is gemstosumab osigomycin. So these are some of the clinical trials of immune checkpoint inhibitors in AML and in MDS. And these were some of the things which have been published in the last 5 years in relapse refractory. And we have managed, and they are all phase 1b/2 studies, which have been induced modest responses in terms of or to the tune of about anywhere between 18 to 35%, except for one study which included an incorporation of chemotherapy, the standard chemotherapy, along with nivolumab, which induced a response rate of almost 78%. But this was basically used in the upfront setting in high-risk MDS. So one would expect those kind of responses when used in the upfront setting. But you do get modest responses by saying that there is activity of using immune checkpoint inhibitors in acute myeloid leukemia. Similarly, I'm sorry, I think we have, I think I just skipped to, I've repeated the slide. And then you have the additional studies which have also looked at the immune checkpoint inhibitors published by Zaidan and also by Lindblad, which again looked at refractory AMLs, and they have used pembrolizumab over there, again with response rates ranging with a CR of about 10%, with stable disease encountered in up to 40% of the patients. The other thing is to use as inducible pluripotent stem cells, derived allogenic NKT cells. And these are phase 1 studies, dose escalation studies, which have used NKT cells to treat acute myeloid leukemia. And they basically are CAR T cells, but using an NKT cell for targeting the CD33 and the leukemic blast. And there have been early phase trials of NKT cell, and again, the only thing that we see is there is a transient decrease in the blasts in about 14 to 38% of the patients. These have been very modest responses. And probably the use of CAR T cells in acute myeloid leukemia may not be as good as what we encounter in some of the lymphoproliferative disorders and in the acute lymphatic leukemia. The use of bispecific antibodies is another aspect that has one used, which is using the targets of mainly CD33 or CD123 on the leukemic blast and the NKG2D. We have some of the clinical trials which have used the bispecific antibodies, and again, the modest responses in these are again quite similar to what we encounter with chimeric T cell receptors, the CAR T cells, which is to the tune of about 12%, and in some situations also when we target the CD33/CD3 phase 1 study, we have responses to the tune of about 66% also in the study by Eisenberg in 2018. But on an average, we seem to be getting responses to the tune of somewhere between 20 to 25% in these patients. Flotetuzumab is a bispecific antibody which is between the CD123 and CD3, and it's a bivalent bispecific antibody which is a construct co-engaging T cells with tumor-associated antigen. And you have a low affinity receptor for IL-3 over here, and usually they are present on basophils, monocytes, hematopoietic progenitor cells. So flotetuzumab is engineered to redirect the T cells to kill tumor cells and recognize tumor regardless of the T cell receptor and the major histocompatibility complex. And these are the results from the phase 1 study in primary induction failure patients and early relapse patients, wherein there was early responses which lasted almost about 16 months, and you had CRs and in about 50 patients, which is in the numbers, it was seen in about 50. I mean, the total number of patients in which is looked is about 50, wherein about 12 achieved CR, about 18 had incomplete CR, and so on and so forth. So in a proof of principle, there is an activity for these bispecific antibodies targeting the CD123 over here. The other important thing that is an entirely different concept is Magrolimab, which is targeting the CD47. CD47 is expressed on the cancer cells, and it says, "Don't eat me" signal. And when they bind through a receptor protein with the macrophages, and it says, "Don't eat me," and antibodies targeting the CD47, which prevents the interaction between the SIR4 protein and also the CD47, releases the exhaustion that the macrophages are associated with, thereby triggering macrophage-associated blast lysis and destruction. So Magrolimab is an Ig4 anti-CD47 monoclonal antibody that eliminates tumor cells through macrophage phagocytosis. So this is that if patients have a high CD47 expression, they seem to do worse off than patients who have a low CD47 expression. And exploiting antibodies to prevent the interaction between the leukemic blasts, and thereby changing the "don't eat me" signal to "eat me" signal, allows for phagocytosis by the macrophages, and thereby improves better leukemic cell kill in these patients. So these are some of the molecules that have been used for targeting the CD47, and these include lemzoparlimab, which is an anti-CD47 antibody, evorpacept, which is a fusion protein between CD47 and SIR-P4, which is the protein that interacts with CD47. And these were all used in newly diagnosed patients and are in phase 1 and phase 2 study. So these were some of the immune modulations that one can look at. Allogeneic stem cell transplant and newer techniques of doing stem cell transplants remain still the #1 strategy as immune therapy for acute myeloid leukemia. But impressive progress has been made in the molecular understanding of the tumor immunology, and the clinical application of immunomodulatory agents in recent years has modestly improved outcomes. However, to effectively incorporate different immunotherapeutic agents in AML is going through a learning curve, and is particularly hampered by the heterogeneity of the disease and the immunoevasive capabilities of the AML blasts. So the inherent genetic and epigenetic and clonal complexity of the disease also continues to be challenging in terms of identifying best predictors of responses in different immunotherapeutic interventions. Ultimately, the successful application of immunotherapy will depend on thorough mechanistic understanding of the immunological genome, genomics, and the microenvironment, and the complexity of AML. It continues to be a difficult disease to treat, but there is some merit in exploring immunotherapy in acute myeloid leukemia, perhaps as a bridge to transplant. But certainly there is some headways being made in primary refractory disease, and also in the relapse refractory disease, and especially in those with high-risk AMLs, wherein even transplants have brought about only modest responses or long-term outcomes about 30 to 35%. And with that, I conclude. Thank you for your patient listening. Thank you.
Thank you for such a wonderful talk. You started from very basic and reached to the top. And we are now open for question and answer session. So any questions, please?
Thank you, Dr. Hari, for this talk, a good talk. When a relapse AML comes, we just think of azacitidine, transplant, and flag protocols. In the light of your presentation, what is the Indian scenario? what is the option, how to start and where to start? Or has any center started in the light of your presentation, these sort of modifications in terms of immune things?
Great. Thank you for that question, Doctor. So the thing is, we have not, most of, if you see, even in those published, they are all in the phase 1 and maximum in phase 2 studies. And as you know, much of the things are taken forward if you have a little bit of a signal which tells you that there is an impressive response. But to my mind, I think there's not yet a situation which has actually replaced an allogeneic stem cell transplant in these settings. So, still, the strategies to exploit immunotherapy is still evolving. But if you ask me, I think targeting the microenvironment in acute myeloid leukemia is the way to go about it. And one of the molecules which I discussed in the last slide, which is Micronutrients, is actually proving to be something of significance when we treat these patients. So, and of course, the use of chimeric antigen receptors, targeted therapies, T cell therapies are evolving, and as you know, there is a significant leap in the use of CAR T cell therapy in India, and we hope that that can come into the picture and we can explore to explore its use in acute myeloid leukemia subsequently. But it is actually quite difficult, as is true of the primary disease. The use of immunotherapy, the immune evasion in myeloid leukemia is incredibly heterogeneous, as heterogeneous as the disease itself. And so there can be a redundancy of the ways we manipulate immunotherapy. So it's not like a 1:1 over there. There are very many other things. So to my mind, it might be multiple ways of targeting targeting the disease through immunotherapy over here. And currently in the relapse setting, I think still, if there is a scope for getting the patient into remission in some ways, it would be the way to go ahead to take a full transplant, because we know that patients who are not in remission may not do as well, or even near remission may not do as well with a transplant. Now, coming to talk about azacitidine, now azacitidine has got a role to play in immunotherapy, because even when used with some of the agents, it has got a tendency to upregulate some of the, for example, upregulate CD47 downregulate or convert what I talked to you about, the don't eat me to an eat me situation over there, in terms of interacting with the binding protein between the CD47, and so it has always been in combination with some of the immunotherapy agents. So there is merit in even trying and getting the epigenetic mechanisms in place along with the immunotherapy to synergize the benefits of treatment. But this is, again, exploratory, more seen in mouse models and in the laboratory, and probably not yet ready for real time.
Thank you so much.
Yeah.
Thank you. Thank you for your nice talk. I just wanted to know, you mentioned in your one of the slides that the polymorphism in NK cell or ligands also would affect the outcome of AML.
Yes.
Referring to CARE, are you referring to any other markers that you're talking about?
CARE is more for an allo transplant when we are looking at allogenic stem cell transplant, but it has just basically been, I would say, sort of identified as some of the targets that can be exploited for graft versus tumor effect in AML, which I alluded to in the past. Because contrary to what one used to believe earlier, GVHT may not have that much of a role to play in tumor control as against graft versus tumor effect. So that will enthuse us to think more about using immunotherapy over here to manipulate the NK T cell environment for better outcomes in these patients.
Dr. Hari, Jyoti Kode here. It's nice to see you virtually, actually. We started with the project together, but then you shifted out. So I just wanted to give you one update about that project, that team 3, what we are seeing, that, there is a beautiful correlation with the diagnosis and remission level and relapse. That is what we are seeing. And second thing, which we have started later, is we are looking at the different plant extracts, which are giving beautiful, results against leukemic, of course, in preclinical models. So you think going for these lakhs and 2 lakhs or 4 lakh modality treatment, or would you like to even venture into working out these few extracts, which are being, they are part of dietary components? They will be less toxic or no toxicity, but have a good effect against leukemia. What would be your take on this?
So we need to see what is the probably the bioavailability of these abstracts and how much it can come into, because you know about the curcumin story when we thought that curcumin can do so many things in terms of its effect through the NFK-kappa B pathway, etc. But the problem was, is it there in the system to do the activity that it's supposed to do when we take these plant products? So that is something that has to be worked upon. Many a time when we talk about activity in the laboratory, it may not translate into the same thing in vivo, but you need to look at mechanisms, how it can be made available, and whether in vivo it would work in tandem with the microenvironment to do the job that it's supposed to do.
So at preclinical level in vivo, it's working. And here again, I would like to bring it a point that everybody thinks about go to phytochemical level. They ask what is the active component, but what we have seen in the comparison of phytochemicals and the main extract of those, the extracts are working sometimes better because they give that wholesome effect, where the phytochemical sometimes becomes more toxic. That is what we are seeing. Maybe curcumin at phytochemical initially it shows good, but at the human trial level, it starts giving more toxicity.
Right.
So the extract part probably contains that, wholesome effect of avoiding, reducing toxicity. You must have seen so many integrative Ayurveda that the extracts act work basically to reduce toxicity. And if they have anti-cancer potential also, I think probably they will have some cheaper answer to the system.
Yes, as you said, TIM3 is a very potent area to manipulate as far as the immune system is concerned in myeloid leukemia, because it is really, really an active pathway over there for mediating immune responses, especially as far as the macrophages are concerned. And we have seen in one of the slides, which is with the antibodies targeting the CD47, which is actually bringing about better responses in AML than many of the other immunotherapy modalities that we have used. And it's certainly worth exploring. And I think in myeloma, nothing is enough. I'm sorry, in acute myeloid leukemia, nothing is enough because of the heterogeneity of disease. And I strongly feel that it has to be a multi-targeted approach rather than a single, because of the redundancy of pathways that allow for survival of the myeloid blasts in the system. Yeah,
okay,
which is also contributed by the genetic makeup, the microenvironment, and also the also cytogenetics of the disease. Actually, yeah.
Okay, thank you. Lovely meeting you online.
Thank you, Jyoti. It's nice meeting you too. Yes.
Thank you. If we don't have any further questions, we would like to conclude this session. Thank you, sir.
Thank you.
This wonderful talk once again.
Thank you. Thank you very much. Thank you.
I would like to invite Dr. Aparna Parikh from Mumbai. She is the Executive Director of Global Scientific Affairs. We welcome you for our next session, ma'am. And the next session is special consideration in clinical trials with immunotherapy drugs.
Thank you very much. So thank you, organizers, for inviting me. And I'm going to be as brief as possible because we are running behind schedule. I see that. And so I'm going to talk briefly about clinical trials with immunotherapy drugs from a clinical trial perspective. So I represent IOSICON Private Limited Company. I've been working with them for the last 20 years. This is a leading CRO in the world with more than 40,000 employees globally. And we have presence in over 50 countries with about 150 offices across the world. We have 4,000 employees in India. We are actually not just a CRO, but a healthcare intelligence organization. And we've used this healthcare intelligence for mobile health platforms, decentralized clinical trials, which were particularly very useful during the pandemic. How is it? Yeah. So I've been working with colleagues globally, and in India, we've conducted more than 50 global clinical trials in India and more than 200 sites. I've had the privilege of, in fact, working with the organizing secretaries of this conference as well, and the sites that they're working with. Our major therapeutic areas have been oncology, pediatrics, infectious diseases, cardiology, metabolic diseases, as well as neurology. Next slide. Let's just go down. Yeah, so as you are all aware, the pharma market here is, globally is $360 million, and of which 25%, more than $90 billion is related to cancer drugs. And of these 15 top cancer drugs, 3 of them are immune checkpoint inhibitors. So this is a huge market, and therefore more and more companies are coming out with immunotherapy drugs and testing them before they can be marketed. Next. Yeah, so this is just a snapshot of all the clinical trials that are going on in immunotherapy. I don't want you to go into the details, but there are at least 800 plus or even 1,000 immunotherapy molecules which are currently in trials in the market globally. I'm sorry. So what are the typical features of clinical trials? We need to look at the examples of endpoints that are commonly assessed in cancer clinical trials. The adverse events of special interest, serious adverse events, the measures of tumor growth or shrinkage, or time-related endpoints such as overall survival. And what are becoming increasingly relevant are novel measurements, which are used as endpoints for all phases of clinical trials. And these endpoints include the functional status of tumors by imaging, circulating tumor cells in the blood, tumor-specific biomarkers, and biological measures of target inhibition of a targeted therapy. So there are a lot of critical issues for immunotherapy trials in India. Ask Dr. Gaurav Narula, he was with us yesterday, I don't see him today, and he had to wait for almost 5 years to set up regulatory guidelines with the help of NIH for his CAR T cell therapy. So immunotherapy clinical trials, what kind of population do we use? Just as in chemotherapy, we cannot test in normal, healthy volunteers, human volunteers. What dose do we consider? There is no maximum tolerated dose, or there's no dose limiting toxicity like chemotherapy. So we need to find out the dose, what dose, whether we use low doses, what is the frequency of duration of treatment, and how do we enrich the population that is most likely to benefit from the immunotherapy drug? What are the predictive biomarkers that we are going to use? So we've all heard about PD-L1 testing and the results and how the sampling is done, but there are a lot of variables involved. And this is right from the sampling method to the sites, to the antibody clones and the platforms that are used in the immunohistochemistry assay, as well as the thresholds and scoring algorithms which are used in the interpretation stage. As you will see from the next slide, based on the staining, whether it is moderate staining or weak to moderate or strong, the staining would change the scoring pattern. And so you could have a heterogeneous PD-L1 expression pattern. And therefore, there could be a lot of inter-observer as well as intra-observer variability. And so we need to have a central point where a scoring can be done. And a central lab would be very essential when we are conducting clinical trials in immunotherapy. So what are the biomarkers that we need to consider beyond PD-L1 testing? So these also need to go through clinical trials, and this could be tissue TMB, it could be immune gene signatures, tumor infiltrating lymphocytes, T-cell receptor diversity, gut microbiomes, blood TMBs, neutrophil to lymphocyte ratio, etc. So again, as I mentioned, we talked about the dose. We are not sure what dose to use when we start a clinical trial in immunotherapy. We also discuss when we are initiating or planning a clinical trial, what is going to be the duration of the treatment? What are the endpoints? Sometimes the response actually starts only after the median survival is over. So endpoints also have to be carefully decided. As you'll see in the next slide, often a plateau is reached between 20 to 25%, suggesting a functional cure. And it is often debatable whether to continue treatment beyond the labeled duration. So whether the treatment should be given for 6 months, whether the treatment should be for 2 years, and what if the patient wants treatment beyond 2 years? What are going to be the long-term effects, whether it's going to continue to be efficacious, whether the patient, if he's responded, continue to respond. So this is just the graph to show that there is where the graph is the same, and at about 6 months, the response is the same, and after which you see a difference, and about 20% that respond and show a functional cure. So again, beyond the dose and the schedule, we need to talk of drug combination studies, whether we are going to use immunotherapy with chemotherapy. Is it in simultaneous? Is it going to be sequential? What is the dose that we are going to use? What is the frequency of the dose? What is the schedule? Are we going to be able to use dose expansion cohorts? What is the sample size of these cohorts? And we also need to look at neurotoxicities. Yesterday also we heard about neuropathies and what the long-term toxicity of these immunotherapies would be. We also have heard and seen about Parkinsonian-like syndrome. So these are some of the toxicities that we need to look at when we are talking of long-term follow-up. So coming to that, how long after active study medication administration should we follow up these patients? What after that? Are we looking at only efficacy? Are we looking at toxicity? What are the real problems of hyperprogression, or is there pseudoprogression, which is related to inflammation, and you see a pseudo growth or pseudoprogression of the tumor? Some of the serious side effects of immune checkpoint inhibitors, including infusion reactions, autoimmune reactions that involve specific organs, lungs, intestines, liver, kidneys, the endocrine system. And in the real world, we often use prednisolone out of fear. Are we doing harm? Are we missing differential diagnosis of the side effects? All these need to be studied when we are conducting a clinical trial. This is just to show you the awareness of side effects related to ICI, the immune-related adverse events. And this was a study done in Japan amongst the oncology nurses. And there were 196 survey responses from 109 centers across the country. And only 27% of these nurses had some knowledge about ICI. And only 15% had overall immune-related adverse event knowledge. And most of it was related to pulmonary dysfunction, and only 1% had any information or idea about neuromuscular dysfunction. So when the nurses who were treating these patients did not have enough information, it is very difficult for the patients themselves to have an idea of what kind of adverse events or toxicities that they could have. So these toxicities tend to be organ-specific. They do not involve multiple organs at the same time. The onset is delayed, 4th week with ipilimumab, 10th week with nivolumab, and sometimes even after the immunotherapy treatment is over. This is not dose dependent, as we've all seen over the last 2 days. And frequently this requires permanent treatment discontinuation. There is no dose reduction that is usually done. ICI toxicity with combinations. You have agonists, you have bispecific antibody toxicity profiles, you have more frequent cytokine release syndrome. And within minutes to hours after treatment, you may see fever, rigors, chills, and in severe cases, there could be hypertension, hypoxia, life-threatening adverse events. And in such cases where we are using combinations, a dose on an infusion rate reduction may benefit. So this is just to show where a combination was used. The grade 3/4 toxicity was much higher, 59%, and treatment discontinuation was higher, whereas Nivolumab and Ipilimumab, when used individually, the toxicities and the treatment discontinuation rates were much lower. This is just to, again, acknowledge Dr. Narula. These are the various US FDA-approved CAR T-cell therapies. Thank you, Dr. Narula, and we hope that CAR T-cell therapy is soon available to our Indian patients. Yes, grandfather. So in conclusion, there's a lot of excitement and there's a lot of potential to cure patients with immunotherapy drugs. As mentioned, there are several hundreds in clinical trials. The hunt is on for better biomarkers. The toxicities are different and they are of concern. Long-term toxicities, particularly very significant. And of course, the new kid on the block is CAR T-cell therapy from India. Thank you very much for your patience.
Thank you, ma'am. Yes.
Thank you.
Thank you, ma'am, for wonderful talk and then telling us about that it's more than 800 of the studies are already going on for immunotherapies. And if you have any questions, please ask.
Ma'am, thank you so much for the presentation. Can you throw some light on biosimilar trials? Like if someone wants to do biosimilar with the biologics, so what should be good trial endpoints or the trial design or the indications? Because considering that Pembro, for example, pembrolizumab has got several indications. So what should be the proper indication that we should go ahead for the trial and the duration of trial points?
I think you should ask the oncologists, the esteemed oncologists sitting here in the audience, but we would need to use a marketed drug as a comparator, and I don't think the DCGI would allow a placebo, which would of course bring up the cost of the trial significantly. So at this stage, I don't think a placebo would be approved.
Sure.
Any comments on that? Thank you.
Thank you, ma'am.
So thank you, chairpersons, and thank you both the speakers, Dr. Hari Menon and Dr. Aparna Parikh. And next we will be having a panel discussion. There is a running tea, coffee at the lunch area. So anybody wishes to have, they can go and have it. Next is about the panel discussion. So to moderate this panel, may I request Dr. Sameer Bakshi. Dr. Sameer Bakshi is professor in the Department of Medical Oncology at All India Institute of Medical Sciences, New Delhi. Thank you so much, Dr. Sameer, for accepting our invite. May I invite the panelists also to join me? So, Dr. Upendra Sharma. Dr. Upendra is Senior Consultant, Medical Oncologist at Bhagwan Mahavir Cancer Hospital in Jaipur. Dr. Lingraj Nayak. He is Assistant Professor in the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. Dr. Vishnu Sharma. Dr. Vishnu is Associate Professor in the Department of Hematology and Bone Marrow Transplant Physician at SMS Medical College Hospital. Dr. Vikas Talreja will be joining us on virtual platform. He could not come here. He is senior consultant and head of the Department of Medical Oncology at Regency Hospital in Kanpur. Dr. Naveen Gupta. Dr. Naveen is associate professor in the Department of Clinical Hematology at Shri Ram Cancer Center here in Mahatma Gandhi Medical College Hospital. Dr. Amul Kapoor, I'm not very sure whether he'll be joining virtual work. Dr. Raja Pramanik. Dr. Raja is Assistant Professor in the Department of Medical Oncology at All India Institute of Medical Sciences, New Delhi. With this, over to you, sir.
Good morning, everybody. So we have had multiple talks from on various topics. And in this panel discussion, normally in a panel, what we try to do is we try to bring out key discussion points which each one of us as working clinicians have our problems on. We don't know what to do. We'll take views of everybody in the panel and see where we reach. I will share some of my own thoughts and some of the thoughts that are available from the literature. Thank you very much, panelists. We'll now start. So I will start with this interesting diagram, which probably you have seen, that the immunotherapy can be targeted through either cellular therapy, PD-L1, PD-1 drugs, which are the checkpoint inhibitors. We had a very good talk about action through macrophages on eat me or don't eat me. We have Pola, we have CD19, and we have the bites. In this panel discussion, yes, Vikas is there. Yes, I'm aware. And in this panel, our key focus will be on the checkpoint inhibitors, because there's a separate panel on CAR T cells, on cellular therapies. So let's start with the first question, and my first question will be to Upendra. Upendra, may I just ask you a question? If you were to answer this MCQ or this two question, which of the following lymphomas is more susceptible to checkpoint inhibitors? And then I would come to the second question, and that would be why.
So for among the Hodgkin and non-Hodgkin lymphoma patients, they are more susceptible to checkpoint inhibitors.
Okay.
Because they are having some mutation on chromosome 9p that leads to more that is the mere point for this expression of PD1 and PD-L1. So that leads to for this is the main reason why these patients have more susceptibility to checkpoint inhibitors. And apart from non-Hodgkin lymphoma patients, there is not much of expression of PD1 and PD-L1 in those patients. So these patients, they have less expression of this and not susceptible to these inhibitors. Of these non-Hodgkin lymphoma, most common are the primary CNS lymphoma, primary industrial large B-cell lymphoma. Yes, sir. So those patients are, but of these Hodgkin lymphoma patients are more susceptible.
So I think Dr. Upendra has very rightly said it is the Hodgkin's which is more susceptible. And I'll give you a concept, probably you have been told about this. Like solid tumors, we have immune-related solid tumors and non-immune. You can actually classify all solid tumors into immune or non-immune. And it gets very difficult in lymphomas to classify them as inflamed or non-inflamed lymphomas, because they are ultimately arising from the lymph nodes. But the answer is yes, even lymphomas are either inflamed or non-inflamed. If you look at the left, it is dominated by tumor cells and very little inflamed cells. The ones on the right have tumor with a lot of inflammatory cells as well. So they are inflamed lymphomas. And as you rightly said, Upendra, that there are increased copy gains of 9p24, which makes them inflamed. And even the genes that are expressed by the so-called inflamed lymphomas, that is Hodgkin's, or the NHLs which are inflamed, are such that they release inflammatory cytokines or they present immunogenic antigens. Okay, so the inference is that, as you rightly said, Upendra, that Hodgkin's is an inflamed lymphoma, and with all the molecular signature, including gains of 9p24, I want to add one more, EBV. So EBV presence is higher in Hodgkin's, and EBV results in NF-kappa expression or modulation, and that again results in a checkpoint inhibitor sensitive phenotype. By virtue of this, one also has found evidence that the BNHLs that have EBV have markers to suggest that they may be more sensitive to checkpoint inhibitors. Okay, I will now go to Lingaraj. I think Dr. Upendra had touched upon it, but let's hear from you. Which type of BNHLs would be closest to Hodgkin's in their inflamed state and thus likely to be susceptible to checkpoint inhibitors?
Yeah, so thank you, sir. So as you rightly alluded, sir, the EBV is, you have seen in Hodgkin, EBV is mostly associated with Hodgkin. So there are a few non-Hodgkins where EBV is closely associated. One is NK T cell, and second is EBV DLBLs, where they are EBV associated, and they also has that immune-rich microenvironment, which can be helpful, for benefit of immunotherapy.
Okay. So I think one of them, Upendra had said, primary mediastinal BNHLs, EBV positive lymphomas, and there is a subtype of BNHL. So BNHLs that can actually be classified as 9p24 copy gains and 9p24 not copy gains. The 9p24 copy gains of BNHLs is a specific subtype which is associated with non-GCB type. It has a molecular signature more like primary mediastinal BNHL and likely to be more sensitive to checkpoint inhibitors. So I'll now come to the first case and we will see what our panelists have to say. This is a case that I encountered. A 15-year-old boy with Hodgkin's lymphoma with stage 4 disease, liver involvement, was refractory to ABVD, ICE, and then BEGVP. In fact, he was being treated by somebody else and was then sent to us. And the question is, Vishnu, may I ask you, how would you proceed on this? What would be your take?
So 15-year-old boy refractory to primary chemotherapy, ABVD, that is standard of care.
Three lines have been tried and
yes,
the patient is still refractory to treatment.
So it is time to proceed for checkpoint inhibitors. Nivolumab may be the best option, and now we have data of low dose Nivolumab also, so we can try.
May I ask you, if you were to choose between brentuximab or immunotherapy, what would be your choice here?
I think
I don't know what's the right answer, but what would be your choice?
We have more experience of using brentuximab, so brentuximab based chemotherapy is the first option, followed by checkpoint inhibitors.
Okay, Vikas online, may I ask you what would be your choice?
I would say that it's a very difficult choice to make. Again, I think anything would be right and wrong in this case, but I would definitely like to do a rebiopsy just to see why it's so much relapse and refractory.
So we did a rebiopsy and it was Hodgkin's lymphoma classical.
I believe it's a chemo-refractory disease. So none of those salvage regimens of ICE or GDP were going to be there. Would like to see how the performance status is. Brentuximab or Nivolumab. I believe there is a very good data of Nivolumab phase 2, especially in this situation. It has been approved also in this situation. So taking into account the financial factors, taking into account the performance status, would like to add the target point, either brentuximab or immune checkpoint inhibitors. My preference would be immune checkpoint inhibitors in view of a very robust data and a minimum side effects profile for the same. We have been using it into solid malignancies a lot, and also in terms of the response rate, Nivolumab does score over brentuximab in terms of the CRs and the duration of those CRs in relapse refractory. I believe there is around 70% rates of the response rates with Nivolumab, and the duration of those response rate is quite higher.
Okay.
Down the line, I would be thinking of also transplantation if he goes into CR.
Okay, so and this case actually was treated around 4 to 5 years back, and at that time, brentuximab was way too expensive than what it is now, and now it has become a little bit easier to get, and this was a time when it was even more difficult to get. We anyway started for this patient Nivolumab every 2 weekly, and after 4 cycles, his general condition improved and he achieved the PR. I heard panelists Vikas saying that he would like to go for transplant. And so that answer is sorted out. He said he would like to go for transplant. But I have a question to my other panelists, Naveen. Naveen, he said he would like to do a transplant. May I just ask you, would you like to do transplant or you would just like to continue Nivolumab?
So if we go by the literature that is available to us, transplant still has a role to play in Hodgkin's lymphoma. If we look at it completely from a disease biology standpoint, ultimately a transplant is delivering myeloablative chemotherapy, and the disease is documented to be chemorefractory. So in such a case, a transplant, well, because it's a standard of care, it should be offered. But I would be very skeptical to say if I would be like, I would be expecting a long or durable response with a transplant. There would be some role of a maintenance checkpoint inhibitor in such cases. A transplant alone would not suffice.
Later. So this point, what would be your choice? You want to continue or you want to do transplant?
I would offer a transplant, but transplant would not be the end of treatment.
Okay. So I'll tell you what.
Dr. Bakshi, can I interrupt? So my approach for this patient will be if we can combine both agents, so brentuximab and
Nivolumab,
or brentuximab plus pembrolizumab. So achieve CR for those patients and then go for transplant.
Then go
that
for
should
transplant.
That should the standard of care for those patients.
Okay. So you would like, we have Upendra saying that we would like to combine a checkpoint inhibitor with brentuximab, achieve a CR and go for transplant. And I kind of agree with him, but we didn't do this way. And I agree with your approach, but we didn't do it this way. And I'll tell you why we didn't do it. So at the time when this patient came, just prior to that, I had had 2 transplants post immunotherapy, and they were pretty toxic transplants, very toxic. Some of my colleagues who did transplant post immunotherapy also faced the same. Although the plan that is suggested by Upendra is well accepted, I want to just share some data on transplant post immunotherapy. And there is some indication that the engraftment syndrome is way more. In fact, one patient died of cardiac arrest during harvest. One patient had acute respiratory failure. So relatively, the complications are more. Maybe it was a chance. At the time when we did those transplants, we experienced far too many complications in almost all the patients. And actually, I chickened out. I decided not to go for transplant, and I actually continued Nivolumab. He achieved a CR, and we continued for a total of 2 years. 1 year later, he continues to be in CR and is now an engineering graduate. But I would infer, based on what Upendra has said, that checkpoint inhibitors are an option, a very good option in relapsed refractory Hodgkin's, is a very good bridge to therapy with a slight suggestion that toxicity during transplant may be more than usual.
But sir, we can in between you can go for some cycles of brentuximab and then
Sorry?
some cycles of brentuximab in between and then
yes.
transplant.
So
because
what I meant was
you have to continue
either a checkpoint inhibitor with or without brentuximab.
because in this case till how long we have to continue this?
So normally it is 4 cycles. It is 4 cycles of immunotherapy followed by assessment and transplant.
In this case,
here I continued because I chickened out for transplant because of my own personal experience. But I would say that the indication would be to go for transplant after checkpoint inhibitors and with or without brentuximab, with the observation that the toxicity during transplant is likely to be more than usual.
Sir, may I add one
Some
comment?
other points?
Yeah, sir, I think this question will be answered best by the keynote data of pembrolizumab. The phase 2 data of pembrolizumab in almost 60 odd patients who were given for 2 years and stopped. And the 5-year update was presented in 2019 ASH, where the patients who achieved CMR and stopped after 2 years of pembrolizumab, almost 60% are doing well at the end of 5 years. So maybe the worst group was those who had a PR. Even after giving 2 years of pembrolizumab, probably they are the worst group where they should go for transplant.
Okay, point well taken. Okay, I'll come to the next case. This is a 40-year-old Hodgkin's lymphoma treated with ABVD. He relapsed after 18 months. He was then treated with ICE for 3 cycles and after achieving CR underwent an autologous stem cell transplant. 6 months after the transplant, patient again relapsed. How would you like to treat Raja? May I ask you this question?
Yes,
so we
sir.
have 3 choices. You would like to offer chemo, brentuximab, or checkpoint inhibitors?
So, sir, my plan will be to bring this patient again into CR.
Okay.
Into CR and to continue. So this, all these 3 are options. So my personal preference will be checkpoint inhibitors in this patient, but we have data for brentuximab also, and we have the combination of brentuximab and checkpoint inhibitors is also a very good option.
So, okay. So you are saying you would like to use checkpoint
Checkpoint
inhibitors,
inhibitors.
but brentuximab is also an option. Yes, option is there, certainly. But if you were to choose, what would be your choice?
So my choice will be checkpoint inhibitors.
Checkpoint inhibitors.
Just
Okay.
because it's my I have more comfort
You have
using
more comfort. with this.
more experience
What
using
about the
this.
data? If I leave out your comfort level, what would be the data on the comparisons of various? Lingraj, maybe you would like to add?
Sir, for this patient, I think the final goal will be an allogeneic stem cell transplant because the patient has relapsed after an auto. Now, I have one chance to put this patient into CR, so I will take the combination of brentuximab and checkpoint inhibitor and achieve that highest probability of getting a CMR and then go for allo if there is a full mass sibling. But if transplant is not on the cards, transplant is not on the cards, then I would prefer a checkpoint inhibitor because that's the comparison of brentuximab versus checkpoint inhibitor, pembrolizumab phase 3 RCT, where pembrolizumab has shown better responses and better progression-free survival.
So, you know, you have raised another point that you would like to go for allo, definitely, or you would like that to be the option. But my personal point is that with checkpoint inhibitors now, perhaps the role of allo in some of these transplants is going to go down. And the data suggests, based on this interim analysis, I'm not sure if you were pointing to the same study. This was actually a post-transplant data, and it clearly shows that checkpoint inhibitors have a longer PFS than brentuximab, and hence the choice would be checkpoint inhibitors. I actually don't know what would be the allogenic transplant toxicity after a prolonged or a reasonable number of doses of checkpoint inhibitors and then taking the patient for allo transplant. If a patient is in CR or response, I would perhaps be more comfortable, as Raja said, with checkpoint inhibitors. But it's open to discussion. I would also like to state that the checkpoint inhibitors were better in every subgroup, including the primary refractory Hodgkin's lymphoma. So I would infer from the data that checkpoint inhibitors are the preferred choice for post-auto relapse in Hodgkin's lymphoma. And the next question comes, Upendra, maybe you may like to answer this. How long would you like to continue this checkpoint inhibitors? And we have two scenarios. If a patient is in CR, if a patient is in PR or stable disease.
See, just Dr. Lingraj has said.
So it says the post-transplant.
Post-transplant.
Relapse. And now you start checkpoint inhibitors. You see a response. You will have two ways. You have a CR after 4 or 6 cycles, or you have a PR or stable disease. How would you like to continue for how long?
So
that's the question.
So for those patients who achieved CR, maintenance therapy for say Premazumab for 2 years and then stop. For those patients who are in PR or stable disease, then continuation of the checkpoint inhibitors.
For
these patients. So these patients say if these have relapsed on auto transplant, our intention is to bring this patient into remission. We can combine with Brentuximab for these patients. And once in remission, then allogeneic stem cell transplantation. If you want to stop therapy, else continue with the therapy because those patients are in PR or stable disease.
So for CR, there is reasonable data from solid tumors that if you continue up to 2 years, patients continue to have prolonged, sustained remission. And the same thing is applied in Hodgkin's lymphoma as well. Some people may even stop it after 6 months, but preferably 2 years would be the desired choice, to continue for 2 years. And in PR or stable disease, the thing is to continue till progression because people are unsure about it. I would like to add here that even if it is stable or some progression, but the patient is not sick, there is data that if you continue immunotherapy, the next line of treatment gets delayed significantly. That means the benefit continues despite a progression seen after immunotherapy. So the question now comes, what if this patient recurs after stopping the checkpoint inhibitors? You're stopped, now what would happen? So maybe Vikas, I would like to ask from online, because you're not in front of us, so we forget sometimes where is Vikas. Vikas, what do you think if this patient recurs after stopping checkpoint inhibitors, is he going to respond or not respond?
Definitely yes, because we have an extrapolation of data from solid tumors that when there is a response and you stop after a limited duration of immune checkpoint inhibitors pre-interval, there is always that responsiveness that is maintained. So 60 to 70% of them tend to have a good response rate, either CR or PR. If the disease relapse after the stopping the checkpoint inhibitors. Also, it is very important that what is the treatment-free interval. So 2 years after stopping, if it relapses after a year or 2 years after that, the magnitude of responsiveness would be higher as compared to a relapse within 3 to 4 months of it. In that case, I would be inclined to use a parallel agent to induce responsiveness along with checkpoint inhibitors. So checkpoint inhibitors, reintroduction is must, but
okay. So I think what we are, I would say that I kind of agree with Vikas, although I'm not sure if we have very robust data on the duration of response of initial checkpoint use and then a subsequent response. I'm not sure if we have the data, but kind of you can take the way it works in imatinib. If you stop it, the patient recurs, you retreat, there's a good chance of response. So there is preliminary reports that retreatment, you can almost expect a 70 to 100% response rate after stopping. So it is, you are okay to stop if the funds get exhausted and then give the breathing time, see maybe the treatment is working for a long time and then give the treatment again after a break. My next question is to Naveen. Would you give checkpoint drugs as maintenance treatment post-auto transplant in those with high risk for relapse in Hodgkin's lymphoma?
So if these patients have been brought into CR with a checkpoint inhibitor and they have high risk features.
No. I have a patient with a relapse refractory Hodgkin's with all adverse features. You transplanted, he achieved a control after now he is in CR. So the question is, would you like to give any maintenance treatment of any sort, or maybe it is not needed?
If the patient had achieved a CR before transplant and continues to remain in CR, then I would not prefer to use any maintenance.
Okay. Raja, your thoughts on this?
Yes, sir, I agree with Dr. Naveen. So no checkpoint inhibitor if he has not been brought into remission by the same.
Any other drugs?
So brentuximab vedotin is an approved agent for high risk in this situation.
So I think the answer is that data is only there for brentuximab as maintenance, not for checkpoint inhibitors. So please do not use checkpoint inhibitors, irrespective whether it was used earlier or not used. It is not indicated maintenance therapy post-transplant. Would you consider, so maybe I'll go to Raja. Raja, would you consider checkpoint inhibitors for relapse refractory B NHLs?
Not routinely, sir.
Not routinely.
Except for the PMBCL cases, cases, and maybe in my limited experience, I have had some responses in PMBCL cases, so that's the lymphoma I'll choose. Otherwise, and the inflamed ones, as you mentioned, and 9p24 mutated. But I don't know.
So in general, if you were to say checkpoint inhibitor therapies in a broad group of lymphomas, the answer is that they have failed. If we were to just have a general statement in NHLs, the answer would be that it would be a failed trial. There are subgroups of lymphomas where it is likely that checkpoint inhibitors will work. And I think Raja and others have already said that the places where it might work is the primary mediastinal B NHL, which is kind of something very similar in its genotype profile to the Hodgkin's, and EBV positive DLBCLs. So, question to Lingraj. Lingraj, what is the current status of bites in B NHL?
Yeah, so there are three data of 3 bites. I think they looks promising, sir, and but when I see those outcomes and compare it with vis-a-vis CAR-T, then there is a long-term plateauing in CAR-T data, but we are yet to see that kind of long-term data with bites. So as of now, I think I'm skeptical about the long-term data of bite, but the short-term data looks though promising.
So I kind of agree with you. We have 2 bites, blinatumab and glofitamab, which is a 2:1 configuration with 2 prongs working on CD20 and 1 on the T cell. As you rightly said, there is some encouraging results, but they are yet not approved for use in non-Hodgkin's lymphoma, except that bites have an approval in BALL, but not in non-Hodgkin's lymphoma. So currently still under investigation. We have 2 minutes left, and I will, in my last 2 minutes, I'll have a question on role of checkpoint inhibitors in T-cell lymphomas. They are a relatively rare subgroup, and obviously the relapses will be even rarer. So what is the thought on the role of checkpoint inhibitors in T-cell lymphomas? Vishnu?
These checkpoint inhibitors has been used in NK T-cell lymphomas, but it is still not a standard of care even in NK T-cell.
Naveen, any thoughts? Any further inputs?
I don't think there is a huge data set for T-cell lymphomas and checkpoint inhibitors. Mostly, I think there would be phase 1 data only in very selected groups. So currently, I don't think it would be an approved use.
So, I don't normally like to put.
So just like other NHL, non-Hodgkin lymphoma, for T-cell lymphomas, then that is not that much robust, and most of the trials they had failed as compared to Hodgkin lymphoma.
So I'll say that the subtype is rare, and in the rare subtypes, the relapses are even rarer. So you have fewer patients to actually do the trial. But as rightly said, there is some encouraging result on NK T-cell lymphoma with response rates being almost 70 to 100%, which makes me think that yes, it is a potential player for NK T-cell lymphomas if they relapse, although again, it's a rare subtype. If you look at the sixth column in the overall response rates, it's not too bad actually in TNHLs, though not yet approved. Even the CR are ranging from almost 30 to 70% in various subtypes of TNHLs, and primarily it is NK T-cell. So I see a future for these immunotherapies in these lymphomas. I will end by, I think the time is just 1 second left, and I will end by saying that there was an interesting conference on immunity and cancer in DHSTI. And I feel that every cancer is immune related. It's just that we don't know. While we did classify lymphomas as inflamed and non-inflamed, perhaps every cancer and lymphoma has some immune background, but we may not know what is that immune background. There are still other immune factors that we have not determined. And if we find those, we will be able to hit them. Like sarcomas. Immunotherapy developed from sarcomas. But we don't have good immunotherapy in sarcomas because we have not found the right targets. I want to thank each one of my panelists for contributing to this panel discussion. Thank you all. I want to thank my institute, the All India Institute of Medical Sciences, where I work, where I learn and gain everything. Thank you all for a patient hearing.
So thank you so much, sir, for the exciting discussions and really brought some good new thoughts, in fact, in the management of these difficult cases. So we'll be moving to the next session, which is Industry Academia Partnership in India. And may I request Dr. Purvish Parikh sir. Dr. Purvish Parikh sir does not need introduction to this call. He is currently associated with the Department of Hematology. He is head professor and head Department of Hematology at Mahatma Gandhi University, Jaipur. Along with him, may I request Dr. Prakriti Talia. She is assistant professor, Biosciences and Bioengineering, Industrial Research and Consultancy Center, Mumbai. Over to you, sir.
Thank you very much, Lalit, for giving us this opportunity. Our next speaker is very important for this conference. It is my pleasure and honor to invite Dr. Narendra Kumar to please come and give his lecture. He is Honorary Emeritus Scientist, ICMR. He is Vice President, Indian National Academy, President, Indian Society of Histocompatibility and Immunogenetics, and is Founder, Head, Department of Transplant Immunology and Immunogenetics, AIIMS, New Delhi.
Thank you very much for those kind words. At the very outset, I want to thank the organizers of this conference to give this opportunity to me to come over here. And I was asked to speak on immunotherapy industry academia partnership. Now that I've left the AIIMS, where I spent 45 years, I've been trying to learn what the industry does. So I want to begin with this slide, which gives you the landmark developments in immunology. And those of you who have been following immunology would know that the last century has been really remarkable, one which led to the birth of at least two branches of immunology, transplant immunology on one side, where I spent all my life on, And these are the three guys who were responsible for that. And then, of course, we went on to learn tumor immunology and then, of course, the immuno-oncology. There was a debate for many years in the immunology field we call onco-immunology or immuno-oncology. I think immuno-oncology probably is a more acceptable term. But what are the strategies to improve immune evasion or invasion of tumors? There are two of them. One is, can we do normalization of MSC expression? We all know from this cartoon that the tumors tend to downregulate MSC on their surface. And that could be full or allelic loss or something. It is not impossible, but not that easy in view of the heterogeneity of the tumors and variable HLA expression gradient. And the second is more important, and that's what the theme of this conference is: genetically engineered T cells or NK cells, where you engineer cells are given an antibody-like molecule called the CAR with the ability to activate and kill the tumor. This is possible and is being done, but requires inputs both from industry as well as academia. And the tumor phenotypes, we all know, we want a picture like this. We want a good scanning electron microscope with the T cells that are attacking a tumor. But that doesn't happen that often. Because of this, there's a transition from HLA-1 positive to HLA-1 negative pattern during tumor development. The road to escape T cell responses. There are two phases there, very clearly shown: the permissive phase and the encapsulated phase, where the tumor, there's a collection of cells, they are still HLA-1 positive, but at some point of time, they lose the HLA-1 or sort of downregulate the HLA-1. And you can say that the T cells are now entering this tumor mass, but they are unable to do anything to it until a stage comes that the whole thing becomes like a AH2-like response there, where the HLA-1 negative granuloma is like a tumor structure. The T cells are only hovering around the capsule. And if you look at the normal HLA class 1 phenotype, each of us should have two alleles of locus A, two of the B, or the C, the three classical transplant loci of the class 1. However, in tumors, there is altered HLA class 1 phenotypes, and that can vary from 1 to 7 types or so. There could be total HLA loss, or haplotype loss, or a locus loss, or more importantly, and that we more commonly see, allelic loss. One of the alleles in either the A or the B is lost. So the HLA loss or downregulation compromises immune surveillance, leading to tumor growth. And there is a gradient of this HLA loss in human cancers and varies from one to the other, and that I'm sure this house knows it extremely well. How do we hone that killer instinct of the cytotoxic T cells? And there are various ways. The three that have been shown in this particular slide: harvest the T cells from the biopsy of the blood, have the isolate or expand the tumor-infiltrating lymphocytes, or you do the genetic engineering of the TCR or have the CAR. So genetically altered immune cells are helping to push life-threatening cancers into remission and generating real excitement. But here you need the way forwards for this would be to shake hands, academia and industry. And I want to show you what is the status of academia-industry partnership globally as well as in India. This is the OECD 2017 report, Organization of Economic Cooperation and Development, where world over, R&D science and technology companies, this is 70% of them is contributed by the industry. The world's top ranking universities actually attract industry funding for their projects and innovations. They're not happening in India as yet. Industry academia collaboration is this engine to drive and broaden the scope of innovation. While universities have access to real-time data, industry drives and disseminates knowledge. And the need, therefore, is to create a flexible and dynamic communication structure between the two. What is the healthcare scenario in India? We know the sustainability, sustained availability of healthcare in India. The two prominent challenges we all know are the affordability and accessibility. Government of India spends 2.1% of GDP on healthcare, but only 0.7% of GDP on R&D in India, compared to 9.7% across OECD countries. Over 55% of healthcare expenditure in India comes out of citizen pockets, and that's a big challenge for us. But the COVID-19 pandemic has been a great experience the world over. Actually, one of the very greatest experiences also in India, where the industry-academia partnership showed the way. To look at this ERC grant, the European Research Council grant, so they aim to support groundbreaking research in all disciplines with the ERC grants. There are a number of types of these grants over there. The focus is on collaboration in R&D, mobility of academics, mobility of students, and going right up to entrepreneurship and governance there. I have had a personal experience with universities in Holland. I was the Dean of AIMS in 2014, and the universities in Holland were sending messages to they want to encourage AIMS, University of Holland's collaboration. So they had a sort of group that came to us, and I took a 5-member group to the various universities in Holland. We were surprised to see each of these universities had a hub, industrial hub or an incubator with them. Besides the laboratories and the university buildings, one of the buildings over there, a very new one, was actually the industrial hub. I have never seen something like this. So this is right inside the university there. So something of that sort will have to come up in India. If you look at the strategic and the integrative approach, the universities are involved with the impact-based research. And they're looking into workforce, human resource development, innovation ideas over there. Industry, on the other hand, looks into market-based research, and they're restrained by profitability. So we need to strengthen the link between the two. The universities must be encouraged to encourage the students to take up industry-oriented studies, add domain-specific subjects to the curriculum. Aggressive meetings have to take place between institutions, faculty, and the industry organization. The universities could invite industry guides as well. This is something that's not happening. Throughout my stay of 45 years in AIMS, I never saw people were saying, oh, the academia cannot really interact with the industry. I think the times have to change now. So the joint research funding and shared incubators to enhance industry relevant R&D. Industry and the academia must be open-ended, knowledge transfer, information sharing, acceptance testing, and create creative type activities there. There are a number of models that one can talk about of industry academia, but you can see that the two work on two ends like this. Industry is more product oriented. They have progress, investment reviews are done from time to time, strategic framework of their academia, on the other hand, is all the time looking into progress and whether my funding can continue or not, expected outcome, the budget, and their focus is primarily on discovery, innovation, impact factors and all. I think the two have to meet, and then only you can have a finalized outcome agreement there. Look at the R&D expenditure in some countries, and look where India is. We are at the moment, and this is happening for the last 10 years, our total spend on R&D in India is not beyond 0.7, and the voices have been now raised. And hopefully in the budget that we will see on the 1st of February, that figure might go up a little bit, but I'm not very sure. But you can see that we are even lower than the low and the middle income countries. Our spend, the GDP spend is very, very low even now. And this is, if you do the comparison between China, India, Germany, and US, you can see the R&D expenditure. And those of you who are very keen to also know the PPP, the R&D expenditure in terms of money, patents filed, research papers, doctoral degrees and all. But our major problem is the R&D expenditure. And the challenges that we have, that in the last 10 years, our higher education system has expanded. R&D needs have increased in all areas, but spending as percentage of GDP has remained stagnant at 0.7. In the 75th year of India's independence, can we expect this R&D to go up to 1? Ideally, it ought to be raised to 2% of GDP in the next 10 years by increasing both the public as well as the private sector spending on R&D. And these are the figures of values, if those of you are very keen to. But we need 80% increase in spending. as to reach the 1% of GDP there. I also brought up this slide from Natural Science Foundation of China. And, they have all this phase 1, which was going from 2018 to 22, phase 2 from 23 to 27. And their goal is excellence in science. And look at the amount of spending that they do. Basic research spend in 2021 was $26.4 billion. And the basic research is just 6.1 of the R&D spend in China. And no wonder, therefore, biotech companies are coming out of China every day. And we are lagging behind over there. The biotech industry in India is very good. But everything is not bad. I want to also show the rosy picture of India, improving landscape in India. There are quite a few programs that the government has made, or the science agencies in government have made. There's the India Innovation Growth Fund of the DST of Government of India, which is aimed at enhancing the Indian innovation ecosystem by enabling innovators and entrepreneurs through stages of idea generation, innovation, and acceleration, and to develop technology-based solutions for the future. There is this Prime Minister's Fellowship Scheme for doctoral research between Science and Engineering Research Board, between SERB and the CII. And you all know about the BIRAC and the Wellcome Trust. Again, it is a support system for translation research for safe and effective healthcare products in India. Scheme for funding industry relevant to R&D, and there is an industrial relevant R&D by the DST as well. But is that enough? And of course, the best example that we saw during COVID pandemic, the partnership between industry and the academia, where the National Institute of Virology was involved in looking at the strains, and these were passed to the Bharat Biotech. And in due course of time, in a matter of months, actually, rather than years, we had this Covaxin formed, and Covaxin was used not only in India, but now we had, you can see that from January 2020 to the end of 21, a number of sort of steps taken for the approval of Covaxin. And WHO finally approved the 8th vaccine for EUL on November 3, 2021. And currently with this, India had approved 10 vaccines, 14 are in the clinical trials, all due to the great example of academia-industry collaboration. And Covaxin is now emergency use listing in several countries around the world. Similarly, there are science startups. The DST and the DBT support. Some of these names you are familiar with: ImmunoAct, InExcel, and there are 75 impactful startups that we have in India, but they're not that many. We are a country of 1.4 billion population. We need to have about 1,000 companies like this, 1,000 startups like this. I myself have been associated post my retirement from AIMS, where I spent all my life, and I've been involved with a startup with my inputs totally as an academician. We have a young group who have established this company called East Ocean Bio, targeting cure for cancer. And the focus here is make these products in India. We will do that. And we have come a long way, since the last year. Our vision is to commercialize curative allogenic cell therapy in India and the rest of the world markets at about the same time as the US and the EU. The mission is to grow into the first allogenic cell therapy company in India, to start clinical trials and launch the first allogenic cell therapy product in the country by 2026. And this is the goals that they made. Most advanced, we will create a product which is most advanced for the allogenic cell and gene therapy, scalable, and of course, economically viable for a country like India. Thank you very much. I just wanted to show you the last slide, the areas of improvement for industry academia collaboration, particularly for a country like India. We need to have an innovation mindset. This is something that we have to work on. We are afraid of innovation and failures. Early research is not supported by public or private funding there. We've been thinking of quantum of funding, something like 20 lakhs. No, nothing. We need to really think big. Funding structure needs to be redefined. Objective thinking, taking lab research to a marketable final product over there. The PhD program should be redefined with right end goals. Current target is just to publish and all that. Then impact factor there. And our students have zero exposure to biotech industry and the market needs. I think this is where we need to improve. So friends, many roads lead to cancer. I want to thank you for giving this opportunity to speak to you. Thank you so much.
Thank you, sir. That was a wonderful overview on the industry partnerships and what is required. One of the comments that you mentioned was China is spending so much more on basic research. But then you went on to rightly point out how well India has faced COVID as opposed to the embarrassment that China is going through. So in spite of spending so much on basic research, they could not come up with a vaccine that could protect their own countrymen, whereas India has done a fantastic job. So I'm glad that you pointed that out really nicely.
I've been to China many times. I think the COVID story is a failure. Their policy of zero COVID does not have locked everybody in. You get diagnosed with COVID, your house will be locked from outside, and no exposure. There is no exposure to the virus. Suddenly, there was this problem actually, the uprising, and they had to open it up, and everybody came out, and there was no community immunity there, and therefore there was this. Yeah, Hemant.
So thank you very much for a lovely talk. Industry academia partnership in our certain academia, say for IITs, they are encouraged to think, innovate, develop, partner with the industry. Why doesn't the same hold true for the medical fields and the medical sciences? You were in AIMS for 40 years. You didn't even think of collaborating with the industry. Why is it frowned upon, this medical academia industry partnership?
Hemant, you have touched the thread. I can tell you, IIT has been doing it for years, and maybe
and they are actively encouraged, sir. And we have 2 or 3 examples in this hall itself where they have done it.
Yeah, I'm so glad that the IIT has been doing it for years. I have been going to IIT Delhi for many years, maybe more than 2 decades or so. They've been working on that kind of academia industry collaboration, but not AIM. I mean, in AIMS, I was once included as a member of the scientific advisory board of Reliance Life Sciences, and they said no, you cannot go. So we were growing in medical sciences even now. The industry is on one hand and here. And as I said, our students have no exposure to biotech industry and to the Chinese have. And I've been to China many times. I think there's a change in thinking now. Now that I have come out of there, I myself could see what is happening in the industrial side. To tell you the truth, I went as a mentor for the SRL lab, and I was surprised that they have a marketing team, they have a sales team. तो मैंने उनको बुलाया, मैं कहा आपका काम क्या होता? I mean, we have not been exposed to even the marketing team and the sales team. It is only after 6 months or 1 year, yeah, they have a role. So we have been really growing in the medical field. We have been only growing in a particular tower, and we are not allowed to go out. I think this is where we need to now come out and lead. Otherwise, biotech industry will remain in the dreams. It will not grow in India.
Perfectly agreed, sir.
Yeah. The
Yes,
IIT guy.
sir, excellent talk. Excellent talk. So what, as a mentor, what would be your best advice to a startup? What they should do the most, or what they should do the first thing, even for the cell therapy space, like allogenic cell therapy space?
Well, I think I find that our youngsters are very bright. The company that I am mentoring now, the East Ocean Bio, very bright students, they're committed, they want to go forward. Sometimes they get stuck up. One is that the funding, we need to have other, more guys. At the moment, they are doing very, very well. We are stuck at a point that we need about 50 CR also. So we have to look for a sort of financier. And even there, I found that there are companies who sort of charge you and they can find a financier for you. I think somewhere the government, maybe the government is all the time talking of startups and startups. Keep a budget of about 1,000 crores, for the startups. And if somebody needs them, give them loan at a very low rate and all that. Number two, now the biotech industry, this kind of industrial startup cannot do everything on their own. They would need anyway the interaction with academia. And we, through our own push and pull, the pressure, the sort of impact that we have in certain areas. So we asked them, we sort of, I sort of called somebody in the academic field, the government academic field, कि भाई इनको थोड़ा सा ये चाहिए तो दिला दीजिए. So they do with hesitation, because it come from me, so they do it, but the hesitation, somebody should not know. I think that barrier has to go up.
Right.
We have to work as a team. The academia industry has to work as a team. I mean, Holland, you look at the country.
My apologies, sir. Can I interrupt?
Yeah.
We have run out of time. Jyoti, you can discuss during the break. Ma'am, you can have the concluding remarks and then we move to the next session.
So thanks a lot, Dr. Mehra, for this wonderful talk and the discussion after that. Any other questions? We'll take after the talk during the Q session. Yeah, thank you.
May I request the chairpersons also to please be here only. Dr. Puri sir, Dr. Kirti. We want to honor Professor Dr. N.K. Mehra sir. Yesterday he was a bit late in reaching to the hall. आइए मैडम. तो सर आपका स्वागत और सम्मान राजस्थानी पगड़ी से और शॉल उड़ाकर किया जाएगा. सब लोग तालियां बजाएंगे. So thank you very much. I did not know that you have so much. Thank you so much. Thank you, sir. Thank you so much. Thank you. So thank you so much, Professor Dr. Narendra Kumar Mehra, sir. And next we have session on the micronutrient in cancer. And to chair this session, may I request Dr. Hemant Malhotra, sir, and Dr. Purna Kutpuri, madam, to please be here. Is Dr. Prakash Chitalkar, sir, here? Yeah, please, sir.
So on behalf of my co-chair, thank you very much. And we'll continue this session now. We have two talks in this session, two really wonderful talks by, one is a virtual talk, I think, is Dr. Lalit, Dr. Vivek Roy, do we have his talk? Okay. So we will do his talk, right? Next. Okay, so Dr. Amit Awasthi will be the next speaker. Are you there, Amit? Amit, are you there? Yeah, there he is. So Dr. Amit is the Senior Professor for Translational Health Research and Technology at the government facility at Faridabad, on the Faridabad-Gurgaon Expressway. and he is going to be speaking to us on micronutrients in cancer. Hope or hype. So over to you, Amit. Thank you.
Thank you very much. It's a great pleasure to visit Jaipur again. I think before pandemic, we were here and Dr. Mehra had organized a wonderful KIMSA meeting. So thanks organizer once again. And I will be talking today about micronutrient and cancer. So some of the work what we are doing in our lab, particularly in the animal models. So this is the team because at the end we keep forgetting to acknowledge people. So the work today I'm going to present is done by Jaigam Abbas, Sugandha PhD student, and the Rajdeep Dalal. So funding agency, obviously, a lot of support from DBT, THSTI, DST Serve, and CSIR. So I will be trying to cover two topics. One is the salt boost anti-tumor immunity through the gut microbiota. And the second one, which is work which is ongoing, is still unpublished, the role of zinc in the tumor immunity. So we know that micronutrients are really very, very essential for us, and they come from the food. And you can, the micronutrients includes vitamins and minerals. And if you go into the minerals can be classified into two different categories broadly, the macro minerals and the micro minerals. So the sodium, actually the salt, which comes in the macro minerals, and the zinc comes in the micro minerals. So I will try to cover both of it in the talk. So as we know, the salt is actually very, make our food tasty. So I know everybody want to add more salt to the food, and that makes our food very salty. But salt is having a bad side effect. So normal intake of the salt should be around, lesser than what we eat every day, right? And that lead to a lot of complications, cardiovascular dysfunctions, and a lot of other, complications. So extra salt, what we get in the food through the fast food, and which you can see on your screen here, all these fast food and more modern food actually having a more salt. Otherwise, if you go prehistorical thing, you have the balanced food, the balanced salt, which is like sodium and potassium. There's a kind of balance. But now we are having more salt than having potassium. So what is the whether salt is having good part? We know a lot of things salt is bad, but whether salt can actually activate the immune system. So that's the question what we actually ask. And the role of salt in the autoimmune disease is actually already known, and a lot of series of papers has been published. And the impact of salt on each of these immune cells has already elucidated at molecular level. So the role of salt in the tumor immunity was not really known in a kind of more mechanistically. So we wanted to understand whether salt induces anti-tumor immune response. So if you see a tumor microenvironment, you can see here the tumor cells as well as have the infiltration of various immune cells. So these tumor infiltrating immune cells are constantly interacting with the tumor cells. And if you go more microscopically, you can see this ligand on the tumor cells and the receptor on the T cells, or receptor on the T cells and the ligand on the tumor cells. They are kind of crosstalk to each other at the molecular level. And that's where the immune cells are actually getting signals to become non-functional and become kind of deactivated. So therefore, if you block these pathways, and we heard a lot about anti-PD-1 therapy, anti-CTLA4 combination. So if you block this interaction, suddenly the immune cells start reactivating and start killing tumors. So that's how the kind of fundamental mechanism has been elucidated by the Nobel Prize in 2018 got by two gentlemen. And subsequently, these therapies are kind of all over in the world in various tumors. So now what we want to do, whether can we activate the tumor can we activate the immune cells within the tumor through the salt? And can we use salt as an adjuvant therapy? This is the question we wanted to ask. And so this is the model what we have used in the lab. So what we do, we inject mouse melanoma cells. We call B16F10 melanoma. This is a syngeneic mouse model. So you can induce tumor metastatic. You can do metastatic tumor if you inject through the tail vein, right? Or you can have the solid tumor if you do subcutaneously. And you can, over the period of 15 to 20 days, you can measure the tumor size. And when the tumor reaches around 2000 millimeters, then we can actually sacrifice the mice and see what happens within the tumor, what kind of cells are being infiltrated. So what we have done, we did the same similar kind of thing, and we have put the mice after injecting the tumor on 3 different diets: normal diet, low salt diet, and the high salt diet. And then we actually did the experiment. What we found that if you put the mice on the high salt diet, you can see here, the tumor regresses very significantly, and the survival of these mice are much more than the mice which were put on the high salt diet, low salt diet or normal diet. So this indicates that salt is doing something, and we have done similar experiment in other settings where we use the metastatic breast cancer model, where we injected 41 cell lines into these mice, biopsy mice, and then we put half of the mice on the high salt diet, and we could clearly see that if you put mice on the high salt diet, there's a kind of very significant reduction in the tumor burden. So what could be the mechanism? We have done detailed mechanism, which is already published in Science Advance, and I encourage you to read that paper. We have really very detailed mechanisms. One of the piece what I want to show you here, that how this salt is actually doing the function. So what we have done, we generated antibiotic depleted mice, where we depleted the microbiota of these mice. And then we did the similar experiment. And what we found, if you deplete the microbiota, the effect of salt actually go away. So salt is not able to induce anti-tumor function when you deplete the microbiota in this case, as well as the effect of salt was coming from the NK cells. So, and we know the NK cells is the anti-tumor cells. So it's through the microbiota and the NK cells crosstalk what was being induced by the salt. So then we did the detailed 16S RNA sequencing from the feces from the mice which got the high salt diet, and we found that one of the bacteria which found very high in abundance was Bifidobacterium. And then we tried to do an experiment. We did FMT experiment, which I'm not going to show here. We did various kind of other analysis. What we also did, we took that Bifidobacterium tablet directly from the Amazon, right? So each tablet is having around 12 billion bacteria, PFU. And then we actually injected directly into the tumor site, and these Bifidobacterium is able to regress tumor by activating the NK cells. And if you actually remove the NK cell component here by neutralizing anti-NK1.1 antibody, the Bifidobacterium effect is actually gone. So now what we show that Bifidobacterium is directly activating the NK cells, and this is happening through the salt. So the summary of the first part was, you have this, normal diet and the high salt diet. In the high salt diet, we show that, gut become more permeable, and this Bifidobacterium from the gut reaching out to the tumor environment, where it actually activating the NK cells and killing the tumor cells. So the second part, I'll quickly summarize, quickly present. This is the unpublished data where we actually try to understand the role of zinc. And we know that these micronutrients and these trace elements are kind of disbalanced between different tumors. As you can see on this side, you have these micronutrients or trace elements are increased, but on the other side, the zinc, particularly zinc, is kind of depleted in most of these tumor settings. And I think if you see really these trace elements, they are in the homeostasis condition, they have nice redox system. There's a kind of DNA integrity is remain nice, and then the cells remain normal. But there is a dysregulation of this, micronutrient. You have this ROS production or DNA damage, and then that lead to the cell damage, and ultimately lead to the, in certain condition, the tumor gens. So we pick up the zinc because in most of the tumor we found the zinc is kind of depleted, and zinc is a kind of gatekeeper of immune system, because zinc deficiency lead to the deficiency in the effector function of the immune system, particularly the T cells. And if you have a nicer zinc, good zinc, then your immune system is remain good. So what we try to do, we actually did an experiment. We put this mice on the high zinc diet, and what we found, the moment you put mice on the high zinc diet, you see the tumor is suddenly increasing tremendously. And even the survival of these mice actually decrease if you compare to the normal diet.
And then we did the experiment using the metastasis model, where we injected these cells into the tail vein, and then we put these mice on the high zinc diet. You could clearly see there's a kind of lot of metastasis foci you can see in the lung as compared to the mice which put on the normal diet. And the survival of these mice, again, much lesser when they put on the high zinc supplementation. The same experiment we did the other way around. What happens if we put these animals on the zinc deficient diet, and you can clearly see if the mice put on the zinc deficient diet as compared to the normal diet, the zinc deficient diet, there is a tumor is significantly gone. So this kind of, you can clearly see this tiny dot, which this is because of the zinc deficiency. And when we start replacing the zinc back to the diet, the tumor start again progressing. And the survival, you can see the mice actually which put on the normal and zinc deficient diet, they survive 100 days as compared to the normal one, which is around 40 days. So that's kind of very, very significant. So what is the molecular mechanism and what is the molecular pathway? So a couple of things which I want to explain here. We know that interferon gamma is one of the cytokines which is produced by the Th1 cells, and these Th1 cells are important for killing the tumor. So when you put the mice on the high zinc diet, the levels of interferon gamma is actually significantly low. So basically, the anti-tumor function of interferon gamma is reduced by the zinc. And on the other hand, the regulatory T cells, which is FOXP3 positive Treg cells, which is a pro-tumor in nature, when you put the mice on the high zinc diet, are significantly upregulated. And these regulatory T cells are known to suppress the effector function of Th1 cells. And as a result, your anti-tumor immunity is actually less. So this is the one mechanism. The second mechanism, obviously, what we found is very interesting, and I think the work is still going on in the lab. What we found that zinc supplementation is actually increases the PD-1 expression across the T cell lineage, whether it's a CD4 cells, whether it's a gamma delta T cells, or whether it's a CD8 cells. So basically, zinc is actually decreasing interferon gamma, increasing FOXP3, and increasing PD-1. So now how we can take this to the next level, therapeutic level, right? So what we have done, we have took the zinc chelation strategy. So what we have, we chelated the zinc in the tissue using the regimen, and you can use this CQ as a zinc chelator, and we have done many other zinc chelator. And what we found, if you actually do the zinc chelation, the tumor actually regresses. So basically, and this zinc chelation, what we have used actually removed the zinc only from the chelatable zinc, from the tissue, not from the within the cells, right? So now, based on this, what we have also done an experiment, which is, I did not show the data here. If you combine the zinc chelation with the anti-PD-1 therapy, right? So you can reduce the dose of PD-1 with the zinc chelation, and then tumor can regress even much faster than the PD-1 alone or zinc chelation alone. So now the next strategy, what our lab is actually embarking on, having the PD-1 and connecting the zinc chelator to the antibody itself. So basically, we have the two things together. You don't need to give zinc and PD-1 separately. You have the antibody which is having a zinc. So this is what we are kind of taking to the next level. So what I show here, that based on our finding that this is a new therapeutic avenue what we are trying to open. The zinc increases the expression of PD-1 on the T cells while suppressing anti-tumor Th1 cells. Zinc chelation suppresses tumor growth by various other mechanisms, and combination of zinc chelation with the anti-PD-1 monoclonal antibody may be used to effectively treat cancer. So with this, I thank the organizer, and I will be happy to answer any question you have. Thank you.
Thank you very much, Dr. Amit. I think a very, very nice talk and some very tantalizing ideas, which are very, very easy to implement in the clinic. So, and I think there's a whole bunch of questions. So we'll do that quickly. We have a general body meeting at 12:30, and we have another talk before that, Dr. Suri's talk. Yes, Dr. Rahul.
Excellent talk, Amit, as always. And as Sir said, very, very some difficult question you will face. One of the question I have is, like you said, bifidobacteria, you are going to inject at the intratumoral site. And then you saw the NK cell activation and therefore the tumor reduction. Why you chose to do the intratumoral injection, not feeding the mice? The reason is the tumor site, the metastatic tumor is a problem. So if you would have feeded the mice, then bifido will go everywhere and try to eliminate all metastatic sites. But you chose to only do the one side. So what was the rationale and why?
Very good question, Rahul. Actually, we have done both the things in the paper. So what we have done the enrichment of bifidobacterium from the fecal material coming from the high salt diet, and then we did FMT, and we found the same result. Then similarly, we use this tablet of bifidobacterium and given to the oral route, we got the same result. The reason what I showed here, because I wanted to directly show that if you inject bifidobacterium tumor, it directly activates the NK cells. So I have done 3 ways, but I just showed the one. This is already in the paper.
Sure. Okay, thank you.
So one very quick question. We have a tight schedule.
Okay,
Thank
sure.
you.
Just a short, because I will ask just immuno-oncology related question, because you have shown the science advance that is based on the mice paper. So high salt you are telling about, even it has a role in NK cell influenza, right? So any data has from the patient sample from PBNC, if somebody isolate the CD 56 positive population and give the high salt.
In case of tumor,
Yes.
no, we are in conversation with Dr. Jyoti. But in case of autoimmune diseases, people have done the salt tablet. People have done the salt tablet, and this is published in the Nature. And the concentration is also known. So I think we are actually on the way to have similar kind of thing in the human cancer patient.
Okay, great. Yeah, we'll discuss later. Thank you.
For the sake of time constraint, we complete this talk, and thank you very much, Dr. Amit, for that very tantalizing talk. There are so many questions in mind, and there are so many questions being asked in the clinic to the clinician about always a diet which should be with the chemotherapy, following chemotherapy and cancer management. I'm sure there will be much more light thrown to this subject, and we will be more objectively answering the patient and their families. Thank you. Now, and now we have a next talk by Dr. Anil Suri on dendritic cell-based vaccine immunotherapy in advanced malignancy. Dr. Anil Suri is a very well-known scientist whom we yesterday awarded, and we acknowledged his contribution to the science and oncology. So I invite Dr. Anil Suri to give his talk, Dendritic Cell-Based Vaccine Immunotherapy in Advanced Malignancy.
So I may wish to add that Dr. Suri, while his slides are being loaded, he is in charge of the cell therapy program here at this very institution. And we are looking forward to our own intra Mahatma Gandhi Medical College Hospital dendritic cell vaccine and therapy program. So over to you, sir. You have 15 minutes.
Thank you very much, Dr. Hemant and his team who have organized a wonderful, I guess, this conference, this Congress, and which talks about the latest advances that actually requires the attention for much needed people in our society. So as the title that you see, the dendritic cell-based vaccine immunotherapy in advanced malignancy, and I am the one who actually gets so much excited with very small kinds of innovations, as Dr. Mehra was putting up, very small innovations which have changed completely the medical fraternity. I always think that how come some of the people can go into that direction. Before I get into that, I would like to dedicate all my oncology surgeons, pathologists, gynecologists from various hospitals, and of course from Sri Ram Cancer Center, Dr. Hemant Malhotra, Dr. Ajay Yadav, Dr. Nitin, Dr. Swati, Dr. Neha Sethi, and Dr. T.C. Sadasuki. And the funding from the Department of Biotechnology, served DST, ICMR, Government of India, National Institute of Immunology. So I was talking that innovation of medical device, that medical invention that changed the hospitals forever. I mean, can you think of, we all, I mean, I am not a part of, I am a part of this fraternity in terms of associated with the clinicians. But guess what? This stethoscope, the person who invented and made was an 8th grade pass sweeper in the hospital. I don't know how many of you know his name or remember him. No? Anyway, he's a Rennick. He was a Rene Lennick in 1815. His invention in making a stethoscope completely changed the medical interventions that we know that is going on. Just a base of that. Similarly, when Dr. Mehra was talking about his creating infrastructures, I must share before I get into my talk in just 2 minutes. I will flip through the slides, and yes, I will not take more than 15 minutes. Dr. M.L. Swankar sir, who has been very kind and gracious enough to support our program for making us do what we want to do in terms of cancer immunotherapy, which is a different kind of immunotherapy. Mostly immunotherapy that we have talked for the last 3 days is based on checkpoint inhibitors and monoclonals. This is a cell-based therapy. And he threw a challenge. He sets the goal for the rest of the world and the rest of the people to come up with something that you can create and facilitate the process of cancer immunotherapy. And guess what? We got this infrastructure which is on the top, which was having nothing, and that had to be converted into a 1,000 particle free facility in the period of 2 years. And right now we have a 1,000 particle free facility in place. And Dr. Hemant Malhotra were fortunate enough before we had a validation to be done for this facility, which is a GMP facility for making dendritic cell-based vaccine in SRC building in Center for Cancer Immunotherapy. Along with it, we also made a laboratory infrastructure which is allied with it, in line, so that we can actually progress what we want to do, in fact, eventually. It is on the service. This was a service floor, by the way. So there was nothing. I mean, there was only AHUs, and there was a hall, and there were hanging wires, and there were dumping ground, and broken tables. And this has been now converted to the state-of-art facility right in the building of SRCC. So having done that, now we are into moving into another arm that we wish that we can start very soon by taking DCGI's approval. This is a true example of Make in India, which is a SPAG9. This is a biomarker that we discovered, and this has we have almost all the patents, and this is also has a trademark. Right now, 3 trials with this SPAG9 priming the dendritic cells-based vaccine are going on. One in the cervical cancer, which is completed. Second one is the ovarian cancer, and third one is the breast cancer. All these cancers are advanced stages who have failed all kinds of treatment, and also the 2 line of systemic therapies as well. I will skip a couple of slides. So the basis of this, as Professor Mehra was talking about, the basic research and to feed to the medical fraternity, started way back in 25 years from bench side to the bedside. And I call this as a reverse translation. Actually, I was walking into the hospitals and getting the material from the hospitals, and then coming back and looking at various types of tissues that I was given by the doctors. So I want to read this very clearly and loudly. A vision is very clear. The passport to discovery is for the cancer research is very clear, where scientists and clinicians should work together. And I always want that now clinicians should come forward and work along with the basic researchers as well to look and translate new scientific discoveries in the improved care of cancer patients. So having said that, we had explored various types of indications looking for SPAG9 expression. And you will see that SPAG9 expression is being shown in the cervical, ovarian, breast, prostate, bladder and kidney, salivary gland, thyroid cancer, and colorectal carcinoma. It's quite important that the molecule which is expressed can be targeted and targeted in a way where we can actually show that, yes, if we can ablate the SPAG9, this protein expression, we can actually kill the cell. Now, this is a scanning microscope that you see, and we were trying to compare with the cisplatin. And here we have used a gene silencing approach where we have actually transfected the cells with the small interfering RNA of SPAG9. And you see at the bottom of the panel that the cells were also killed when you completely ablate, or almost 90% ablation of SPAG9 takes place and cell death occurs. Not only in the cells, we also showed it in the nude mice where we grew the tumor and then we injected intratumor shRNA and the tumor was shrinked, very small. It also actually reduced the migration of the cells. If you ablate the SPAG9, it also reduces the cell invasion. So migration, invasion, and cellular proliferation, where SPAG9 is actually involved, was contributing for the cellular growth and the tumor formation. Now we have almost all the patents available with us. Especially these two patents are very important. And I don't know how many of you would appreciate or not. It was 2004, 2007 that I was thinking about immunotherapeutical compositions or immunotherapeutical approaches that we can use as a dendritic cell-based vaccine were patented. But the patents from Indian government was granted in 2017, and both of them were granted in 2017. So having said that, we have the patent of this molecule. And so I would skip that. Skip it. All right. So the impact of translational cancer research on societal value. So this is a phase 1 trial outcome of one of the patients that courtesy Professor Dr. T. Rajkumar had undertaken. And these were 14 patients, of which this is one of the patients who had come in 2004 with a small lesion. She had a cervical cancer metastasized in her breast, in chest. And it was actually so big by 2005, October, that you can see that circle in the red. And to his surprise, this patient walks back in December 2007 with complete remission, and she's still alive till today. So that gave him such a boost and a confidence that we must, Anil, work on this dendritic cell-based vaccine so that we can actually see if we can go in for newer indications as well. This has almost taken 20 years where we are today. I will skip this. So DCGI approval was obtained in 2015 for cervical cancer stage 3B patients. And we had actually outsourced this to Syngene Biocon for the manufacturing of recombinant SPAG9. And this is the protein profile, which looks very clean. And this is the protein that Dr. T. Rajkumar was given to pulse the dendritic cells. I'm going to show some of the data information that was generated during the trials in vitro so that we could decide on the dose that that would be required to do the priming of the cells. And I know Dr. Hemavati Dandapani did her PhD on the SPAG9, and she's right. I think she should be. Can you stand up? There you go. There she is. I think she should be acknowledged. Please clap for her. She actually worked on this standardization of dose in what is I'm going to show you right now with Dr. T. Rajkumar group and the SOPs that we were providing through Dr. Nirmala Jagdish and our team. And what it shows is that you can see that this is a third party. This is what I say. We do something, we go to another physician, another hospital, and they do the validation, then it brings back the confidence in us. So this is their lab doing by our SOPs supplied to them. So what you see here is the overexpression of SPAG9, which was an inclusion criteria for selecting a patient. And on the bottom, F and G shows the expression of SPAG9 over stages from stage 1 to stage 4. And if you see the blue line actually shows if you have a less expression of SPAG9, which is low expression of SPAG9, the longevity of the patient is much higher as compared to the red line where there was an overexpression of the SPAG9. Now, believe me or not, they were counting number of cells being present and expressing SPAG9. Remember, so that is a cutoff. So their pathologist, Dr. Shirley and their group, they were actually scanning all the tissues and they were studying, correlating all the outcome. This is an optimization of recombinant SPAG9 antigen concentration for priming dendritic cells. So what she did was she had 250 nanogram to 1000 nanogram, and she figured out that she compared that if we use 750 nanogram is good enough actually to stimulate, if you see D or E, to stimulate CD4, CD8, and CD56 good enough. So she pinned down to the 750 microgram of the dose that would be used to actually prime the disease. This is a characterization of mature disease and where she again showed that the different markers versus tumor lysate. Now, remember, Dr. Rajkumar always had this issue in his mind. Even if you have tumor lysate, this is the biggest limitation for dendritic cell-based vaccine. So we have to have some sort of a biomarker or a protein which can be used. And on the same basis, now, while for cervical cancer patients, there were stage 3B cervical cancer patients, so they could have the tumor lysate. But in stage 4 ovarian recurrent and metastatic patients, we are having problem. He was having problem to have a tumor lysate because patient will not come forward to give another biopsy. So we had to drop one arm of tumor lysate. So it was, okay.
Sir, I'm sorry to hurry you up. We have a general body meeting in which
sir.
about 550 international participants.
So this is in summary, conclusion.
Thank you, sir.
In summary, so the overcome limitation of availability of autologous tumor cells as an antigenic source should be overcome, and that is why the recombinant SPAG9 was used. And this is the first report which suggests that recombinant SPAG9 is effective antigen for pulsing disease. And this is a few of the slides. This was the Organization of Pharmaceuticals Producer of India, which gave award to Dr. Nirmala Jagdish for her contribution for the last 20 years. And I always close up my talk by saying, please find a cure before I grow back. Thank you very much for your attention, please.
So that is an incredible piece of work which you're doing, Dr. Suri. I wish we had more time to listen to you in toto and to permit questions. But there are some societal pressures. So thank you very much. Thank you. Really, truly appreciate your talk. So may I request our secretary to please come on the dais. So we will do the general body meeting now. Dr. Gaurav, can you come on the dais, please, as the treasurer of the Immuno-Oncology Society of India? So may I please request most respectfully people in the audience who are not members of the society to kindly take a tea break. We have tea ready for you, and we will continue the scientific program. And I think one of the very important components of the scientific program, the CAR T cell, the Swadeshi experiment, immediately after the general body meeting, which should not take more than 15 minutes, Jyoti. Okay, so over to our secretary, Dr. Jyoti Bajpai, to conduct the proceedings now. Thank you.
So a very good morning to everyone. Rather good afternoon.
So Gaurav, where are you? Can you come over here on the dais, Dr. Gaurav?
Dr. Gaurav Narula, I just saw him. Yeah, he's coming. So without taking much of the time, we are, starting the general body meeting. And I request all the members who are present in the hall, please come in front, so that we can have a close interaction. All the virtual attendees also should participate wherever it is needed. So dignitaries on the dais, the president-elect, Dr. Malhotra. On the virtual, we are having Dr. Chiplunkar with us and other EC members, along with all the general body members. So I'm presenting a brief report of our society's achievements and what has been discussed in the last EC meeting, which is conducted yesterday. So we all are aware about what has been happening with the periodic newsletters and other talks and annual meetings which are happening. But just to put everything into a right perspective, since 2018, while we conceived this society, with all of your support, we are taking a steady progress. We are having international and national collaborations. We are conducting awareness and educational meetings, annual congresses every year, and in between additional some of the educational activities which are happening and which we will further consolidate because now it is post-COVID. In the last couple of years, now we are part of World Immuno Council. We are collaborating with Society of Immunotherapy of Cancer, that is SITSI. Many of
group collaborating with a top laboratory scientist and a lab group. And the culmination of this association is that we will see an Indian car on the road soon. So let's talk about the CAR T cell, the Swadeshi experience. And it's my pleasure and privilege to invite Dr. Rahul Puwar to give us a status update on the developments on the Indian car front.
Thank you so much, sir, for the kind introduction, and thank you to the organizing committee to invite us and giving this opportunity to present some of our work. So just my disclosures, and then you all know, I think I don't need to emphasize to this esteemed members that cancer is a global healthcare problem, and it ranks almost second. India ranks second in global cancer mortality rate, right? If we see this global cancer mortality map, what we see here, that so this here, the more the dark, that means there are cancer death annually for 100,000 people. Although you see that that dark circle is not so much here in the Indian map, but given our population is huge, number of patients in India are really, really very high. And 65% of the total global death burden is now on the developing country. So there's a need of new technologies, new medicines, which are curative or which are more beneficial to the patient. One of the platforms which is having intent to cure platform is the CAR T cell therapy. It's a personalized medicine. That means every patient would get more like autologous cells. So how it works, how platform works is that you take out the patient's blood and isolate the immune cells. And these immune cells in the laboratory, they're genetically modified, and then they call CAR T cell. And CAR T cells are reinfused back into the patients. And these CAR T cells then eliminate the cancer. Right? And these are also called living drug. And why living drug? Because these CAR T cells persist in the patient for a long time, and they keep killing the tumor cells whenever it arises. This particular type of platform has shown remarkable success in mainly in the blood cancer, doesn't work very well in the solid tumor yet. So many trials happening, but so far very good response in certain type of leukemias and certain type of lymphomas. Okay. And this platform really has shown a remarkable response in long-term cancer cure. So here you see the first patient, Emily Whitehead, who was given this CAR T cell therapy almost a decade ago, and now is still cancer-free. And that's how the term cancer cure came, because of this long-term data. When you see even the publication, the scientific publications, and this NEJM in 2018 with this little large cohort of almost 107 patients from UPenn, they have shown that half of the patients, they remain cancer-free even after a long time. Similar publication came for 5-year survival from the Memorial Sloan. They also showed similar data. Half of the patients show almost kind of a cure or long-term cancer remission. So based on this excellent data, now we have 6 FDA-approved therapies: Kymriah, Yescarta, Tactaris, and all these mentioned here. And all these 6 therapies are mainly for 2 antigens. One is CD19 and another is BCMA. So we have CD19 CAR and BCMA CAR. And earlier, when these therapies were approved, they were all approved for the late lines therapy after relapse and refractory tumor. But good news is recent data came out in 2022, which is showing that this can be given as a first line after relapse. So refractory to first line chemotherapy, or that relapses within 12 months of first line chemotherapy, indicating that now more patients can get benefit from this kind of technology platform, because now larger number of patients can get enrolled or are qualified for receiving CAR T cell. So CAR T cell platform, although as I said, it works very well in the blood cancer, but now there are so many trials happening which are not just for blood cancer, but also for solid tumors, especially breast, neuroblastoma, sarcoma, and others. And this platform, not only for cancer, now it is, in fact, a recent paper came in the Nature showing that CAR T cells can even target cardiac fibrosis. That means even heart failure. So CAR T are now moving beyond oncology, where they can even treat heart failures. And most of you know that heart failure is one of the major problems in our country as well. Right. So if we see, so now you must be thinking like CAR T platform seems a good platform. Is it available in our country or not? So if you see these all trials happening across the globe, so there are more than 4,000 different therapies available. And out of these 4,000, engineered cell therapy trials are almost 66%. And non-engineered, like non-genetically modified therapies are almost 33%. But majority is happening in the United States or North America or in China. India, there was nothing. In fact, this report came in 2022 by Beacon. They somehow missed our 2 trials which we were doing in India. But if you overall you see the map, there's nothing happening elsewhere except these 2 regions. So CAR T therapies are not available in LMIC. So if you see the entire African continent, so wherever there's less money, CAR T are not available. Right. So our journey, our collaborative journey, truly collaborative with Tata Hospital, Dr. Gaurav sir, Dr. Hasmukh, and IIT Bombay, we have been working together on this developing indigenous CAR T cell therapy, and we have so many challenges. But some of these challenges are like technical challenges and clinical training. So as you know, this is a complex platform, require a lot of technical skill, lot of clinical training to help the patient, regulatory support. For example, when we started the work in India, there was no guidelines for the gene therapy guidelines. Now, at least in 2019, we can say that ICMR, CDSCO, and DBT, they all come up with a guideline. So India has basically a regulatory framework. Cost and affordability, I think this was one of the major challenges why multinational and others did not find India as an attractive market for the CAR T cell therapy. And I think it is to all of you know that in India, I think Dr. Mehra also mentioned R&D support, the grant and funding is less in this country. So our journey started as a collaborative project almost a decade now. In this together with Dr. Gaurav sir, who is also here. And you heard the previous speaker, he's father of our CAR T cell therapy. And we work together, and I will show you some of the work. Can somebody, okay. So what we did, we are together, we are focusing on technology and the developing new product. And one of the product, first thing we tried to have a CD19 CAR. We constructed many different CD19 constructs. I will not go in many details. And we also have patents for that construct. And we have shown that we can manufacture the CAR T cells. And as you can see here, and these CAR T cells we have made for healthy donors with many patients. And these CAR T really work. So they can kill the tumor cell. They secrete cytokines like interferon gamma and IL-2, indicating their functional CAR T cell. We performed extensive in vivo studies in the mice, where on the left, what you see is mice which are not treated with CAR T. But when we treated these mice with CAR T, it was a complete cure in majority of the mice, indicating it works. So just to give you very brief that we have a unique product which is patentable, which is patented, and we got the patent. We use lentiviral vector as a gene transfer vector. We tested in vivo, ex vivo, we have the patent, and recently we were in the clinic. And I did not show you the data, but all the data is now, preclinical data was published in one of the AACR journal. And in fact, this image on the cover page is of our CD19 CAR. So once this preclinical work was done, I think the major challenge came how to take it to the clinic. So to take it to the clinic, you have to make the GMP facility, you have to convert your entire process into a GMP scale manufacturing process. And for GMP scale and clinical grade manufacturing, closed system. You need to use the closed system so it is not exposed to the environment contamination. So what we use is gas permeable bioreactors, so the small bags, up to the 1 liter bag we can use. So we do the T cell transduction in these bags. They are again closed, and we do CAR T cell expansion. So these are gas permeable closed system. We activate the immune cells, and then we transduce them with the vector with the MOI 5 to 10, and then we got good quality CAR T cells. So these are the CAR T cells made as per industry standards in the GMP facility. Then there are a battery of assays you have to do to ensure these cells are qualified to go into the patient. So you have to check their identity, purity, potency, and safety. So all these assays are done before the cells are injected into the patient. Once these cells are injected, so one of the trial which we will show you, this is the lymphoma trial, and Dr. Gaurav sir will, I think, in the discussion will talk about the leukemia trial, which he has done. So another trial which is done by the Dr. Hasmukh, he has recruited 10 patients at TMH, and we manufacture the CAR T cells at IIT Bombay. And so we within 7 to 8 days, we made the product. So right from the apheresis is done at TMH, then T cell selected and activated, transduced, we remove the lentiviral vector, we expand the cell and cryopreserve till the patient is ready. And then we infuse the cells in the split dose of 10%, 30%, 60%. And so far we had 100% success rate in CAR T manufacturing. As a phase 1 objective is to check the safety of the CAR. In the CAR, there are 2 major safety issues. One is cytokine release syndrome, and another is neurotoxicity. So if you see all these patients, 10 patients, which we categorize in 2 different dosing, less than 5 million per kilogram or greater than 5 million per kilogram, none of the patients develop a life-threatening grade 3 or grade 4 CRS. Majority is had 1 or 2 grade 1 or grade 2 CRS. None of the patients after the first infusion got the neurological event. So there was no grade 3 neurotox, and there was no grade 3 or grade 4 CRS, indicating we have the safe CAR. And in fact, this is also proving our preclinical data. In the preclinical data, the way we said we are novel because the changes we made in CAR design that lead to the less cytokine expression by macrophages, especially IL-6. That was the novelty we proved in the preclinical work, and that's what we published. And now in the clinical trial, similar phenomena we observed that we have less cytokine release syndrome. So this is like translating our preclinical work into the clinical work and proving what we said in the preclinical was correct. As a secondary objective, again, this is only 10 patients. So you can say this is not like a big set of data, but few I want to show you that you see the efficacy. Here is a big tumor in the within 30 days, it was completely gone. And this patient, after almost a year, is still alive and cancer-free. So this was first complete response we had. Another one you can see, again, there are multiple a small tumor. Note you see so many here, and then after day 30, it's completely gone. Another complete response. Here you see a remarkable response. So much tumor burden, but there's a little foci left, and ultimately after a year we lost this patient. So this was a remarkable response, but within a year we lost him. So if you just get a summary of the phase 1. So overall response in the lymphoma trial was 66% at the greater than 5 million per kg. Complete response at greater than 5 mg was 66% again. All 4 patients, they got complete response. And if you see deep response, which patients are still alive, almost like 500 days now. For this patient, ID 13,
ID14, we have the top one is almost like 200 days in cancer-free and is still surviving. This patient we lost because of non-cancer, some other disease. He was in the CR, but still we lost him. And this patient, ID10, is still alive after 270 days. And even at the less than 5 million cohort, only one patient we have right now, he's in CR, but this CR, he had actually CAR T, and we were always surprised that besides having CAR T, this patient was not in the CR, it was still progressing, right? So in the morning or yesterday, we heard that somebody said, I think in the panel discussion, these patients are also susceptible to Nivolumab of a checkpoint inhibitor. So here, I think this patient has got the checkpoint inhibitor. And then the reason we thought checkpoint inhibitor might help is that he had the CAR T, but still patient was not responding. So when we gave the checkpoint inhibitors here, after some time, he came in CR. So this was a very good kind of experimental thing. So we have one more CR, even the less tumor burden. So maybe in future, so this is how what you do the bench to bed, and from bedside you learn something, again try in the bench side. So this is one of those examples where we learn from the clinical trial data, because from the bench we are telling the clinician, we see CAR T here. Clinician says that, okay, we are seeing a lot of CAR T, but why they are not working then? So then they tried the checkpoint inhibitor and showed that it started working. So overall, you clearly see there's so many deep responses. Almost half of the patients receiving greater than 5 million, they're still alive and cancer-free. And even less than at least one patient, we have the cancer-free. Another trial, I think this data, you can talk to Dr. Gaurav sir in detail. He treated 6 patients. He will tell you about this response rate and the cytotoxic or the toxicity. But in brief, neurotox, we have only 1 out of 6 patients had grade 3, 5 of 6, no sign of neurotox. CRS, we had 5 patients had CRS of grade 1 or 2, only 1 patient had the grade 3. And overall response rate 86% and complete response in 3 out of 6. So half of the patients had complete response on day 30 and 2 is still under the deep remission. So here you can clearly see that another difference from the previous versus this is disease biology. Right? So disease biology play a role in the responses. Right? Another question what I get a lot is, now it's okay, you have done brought from lab to clinic, how much it will cost and how it will be delivered beyond TMH, for example, right? So this is is it affordable? So in the lab, in my company now, the Sirish Arya, who is a business partner, and Atharva, they have done some unit economics analysis. And this is interesting because this slide I made almost, I think, 5 or 6 years ago with Carl June, who is a pioneer in the field, who developed CD19 CAR, sold to Novartis. And what he said when he visited BioAsia in 2020, he said a couple of things, but I will not go in detail because of time. But what he said here in interview in Hyderabad, India's involvement can make treatment mainstream, says CAR T-cell therapy pioneer in 2020. And you will be happy to know, actually, we can literally make it affordable. So here is the slide where you see on the left, centralized manufacturing. So it's an only manufacturing cost of Kymriah, Yescarta, Calvicate, all these innovators. So they are making somewhere between $60,000 to $120,000. So average, you can say $95,000. That's a manufacturing cost. Then there's no add-on cost in manufacturing. So if you think them as 100%, recently there's another model is proposed called decentralization model. So decentralization model is you can have manufacture at multiple sites, either in a place of care, which we call it city-based, or you can have a hospital-based manufacturing model using some kind of automatic machine. One of them is Prodigy, second one is Cocoon. There are many companies now coming with their modules. This data coming from Germany, I'm trying to show you, this is $60,000 on a Prodigy machine, a decentralized model in an academic setting. So if you make the CAR T in academic setting, it will cost you $60,000. And truly, when Indian data came from CMC Vellore,
Professor Vikram Matthew group. And what Carl June said that it will make it, India involvement can make things cheaper. It indeed is true that involvement of India in an academic setting of CMC well low by Professor Vikram Matthew, he literally did the cost almost 20 to 30% cheaper, because 35,000 manufacturing cost, he did not include Vector in it, but even if you include Vector, it will come around $50,000. So $60,000, he definitely reduced the cost to $45,000 or $50,000, which is significant cost reduction. But what we have done, because we are making our own Vector, we are making our entire platform ourselves, the place of care, what we are proposing a hybrid model between centralized and decentralized. We call it as regionally decentralized model of manufacturing, and we are planning to have manufacturing around $15,000. So if you see overall cost reduction, if you see 100% decentralized manufacturing, only 16% cost when India's involvement and our involvement came and what we have done. So if you see all these CAR-T approved drugs, all these costs, we have, because of time, I don't think we have enough time to show you how the manufacturing cost, and because now you must be thinking, if in abroad people making $95,000, why it is sold for $400,000? What is in between? So there are major other things which we can talk as an indirect cost, because even the conferences and educational program, they're all funded, right? So cost is all merged together to make that 95,000, 400,000. So I'm not defending that why that much gap should be there, but there are other costs associated with it. So if we say that manufacturing cost of $15,000, the way how it is coming, so it is only coming when we have a scale up. So a scale up, at least I need to treat 200 patients minimum to get that cost. So if I invest in a facility and I want to get $15,000 per unit cost, at least I need to have 200 patients from that facility. If I'm only doing 50 patients, cost is going around $21,000. So scale up is important. That's why our model of regional decentralization model may be helpful. Okay, and total cost, which I was just saying, product development cost, clinical development cost, phase 1 trial cost. If we include all of that together, from 15,000, it becomes around $25,000. So that much direct cost and indirect cost together will be, so how much it will come to market. So this total cost of CAR-T around $30,000. And so we are bringing the cost from $400,000 to $30,000. And there we feel scale up is the key to lower the cost. How we will achieve that? So the model which we are proposing, like a hybrid model of centralized versus completely decentralized, regional decentralization model, where there would be a centralized facility for the vector, quality control, as well as for R&D and training. And there would be various sites across the country which will manufacture the cells. So for example, a facility in Delhi can support all the regional Delhi needs, similarly to the other places. So the key conclusions are that we, at India, we have indigenous CAR-T platform, which is a clinical stage platform, which is producing results as per the international standards. And we have done it from design till the clinic. First, CAR-T cell therapy is safe and shows early sign of efficacy. I'm saying early sign because there's a long way to go. We don't want to conclude anything based on phase 1 data. We need phase 2 data, good data to say that it's really, really efficacious. Regional decentralization model, what we feel is a right model for our country to ensure affordability and ensuring the access of this particular platform. And the last but not the least, really thanks to all the students, all the staff of IIT Bombay, the lab, who work tirelessly because they do the work. We only talk right here, and funding agencies. And of course, this work was not possible without the excellent collaborator like Tata Hospital, Dr. Gaurav sir, Dr. Hasmukh, and all the entire team of Tata Hospital, NIH and NCI Terifry, Nirali and Steve Hypel. They were phenomenal in helping us developing all the assays and everything. In Carl June, Avery Posey and Satwa, they are helping us at our company ImmunoAct to as a scientific advisory board members, and all the funding agencies for the lab work as well as for the ImmunoAct. Thank you so much.
So 2 or 3 quick burning questions. I think everybody is so overwhelmed, Rahul, that they don't have any questions. Thank you very much. Yeah, please come to the mic, please.
Dr. Rahul, good effort. I just had a query that every patient you take, you think that 8-a-day protocol, what is the what do you say? Efficiency? Means all cells, all patient cells get well transduced, or some patients have poor transduction, some are better.
That's a very good question. It's a challenge because every patient is different. Some are less heavily treated, some are very, very heavily treated. And treatment, how they are treated, it makes the T cell good or bad. Right. So some patients who are heavily treated, their T cells don't grow faster. So sometimes we have to go from 7 days to 9 days.
Okay.
Right. So there is a variation.
Okay.
Oh.
Sir, I can ask those who relapse after CAR, because we know around 50% could relapse even after CAR. How do you see their future in terms of CAR therapy itself, whether to increasing the dose may help them or changing the antibody like those, changing the chimerism status will help them? Any comment on that?
So once those who relapse after the CAR, which are almost 50% of the cases, right? As I said, 50% would be surviving long-term without any need, but 50% would relapse again. So the 2 ways for the relapse, one is CD19 negative relapse. That means the target negative relapse, and they can be treated by different type of CAR, like CD22 or maybe some other CD20, CD22 and other CAR. But if they are relapsed on the CD19 positive, that's the time I think repeat infusion might help. And there, our approach that we have the humanized CAR, that would be helpful. Because other CAR of other companies, they are murine CAR. So when we get the murine CAR, our body develop antibodies against murine CAR. So repeat infusion is not so successful. But in our case, our CAR is humanized CAR. So repeat infusion is possible, but again, we will have to prove that it works. But that's our hope, that repeat infusion in those who are relapsing on CD19 positive tumor, that would be helpful.
Thank you, sir.
Thank you very much, Rahul. Please give him a huge hand. Thank you.
So thank you so much, Dr. Rahul, and thank you, Dr. Malhotra, sir. We are moving to the last session of the Congress, and to moderate the panel, may I request Dr. Gaurav Narula. Dr. Gaurav Narula is a professor in the Department of Pediatric Oncology and Health Sciences at Tata Memorial Center. Dr. Gaurav has worked hard, in fact, to develop the CAR T-cell therapy in India. And he has paid huge price in the form of going probably every 3rd month or so to NIH. And may I call the panelist also? Dr. Samir Bakshi. Dr. Samir Bakshi has been introduced to you all. Dr. Chetan Dhamane. Dr. Chetan here? Yeah, please, sir. Welcome. Dr. Vishnu Sharma is a hematologist and he is associate professor in hematology at SMS Medical College, Jaipur. Dr. Ashish Verma. Ashish is probably not here. Dr. Shubhrajit Vishwas from Delhi. Yeah, please come. So he is Deputy Director at Amity Institute of Molecular Medicine and Stem Cell Research, Amity University Campus, Noida. Dr. Hari Menon could not join. Dr. Dharma Chaudhary, may I request you also, please. Over to you, Dr. Gaurav.
Thanks a lot to Dr. Hemant Bhattacharya sir and my dear friend Lalit, with whom I did my fellowship in Tata Hospital. We have old brothers back to a long time. Thank you so much for giving us the opportunity to discuss this very important issue, because now a lot of interest is being generated in it. Till just a few years back, it all seemed like science fiction, and now here we are actually discussing what are the challenges and remedies, because it's already here with us. So you have already been introduced to the panelists over here. I think Dr. Vivek is also not going to be here with us, and Hari also had to excuse himself at the last minute. He was logged in earlier, but I think something just came up for him and he had to log out. So, we have a lot of a few people over here who are working in the cell therapy space, and we have Dr. Rahul and Dr. Gandhari Lal sitting in the audience also, whom I'm sure can come with the inputs, and Dr. Mehra is also here to give us guidance and in anything that we missed. So what I wanted to ask the panelists, and you can give your own perspective to it, that for the purpose of this panel discussion, can we define what we actually mean by cell therapies? Because this is not a session just on CAR-T, it's on all cell therapies. And we are just to remind you that we are an immuno-oncology society. So let's talk about what do you mean by cell therapies in the immuno-oncology space? What kind of therapies are we including? Amit, would you like to start?
Yeah, so
yeah, okay.
So basically, when we pool cell therapies, generally it is called cell and gene therapy. So we have gene modified cells like you use for thalassemias and you use for hemophilia. So that is one aspect. Then you have the cell therapies like the CAR-T cells, which are genetically modified cells again. And yeah, sure. Can you hear me now? Yeah. So basically, you have the CAR-T cells. The CAR-T cells are the ones that are genetically modified, and the ones that are not genetically modified, like your dendritic cell therapy, where you pulse them with Spag9. Then you have NK cells. The NK cells can be expanded, or they can just be given as it is, or they can be just incubated with some cytokines so that they have memory-like phenotype. So these are the different kind of cells. You also have your other cells like autologous chondrocytes that they are using for osteoarthritis. Then you have some of the cosmetic cells that are used for against aging. So there are different types of cell therapies, and each one needs to be taken in a different perspective because they are either modified or they are non-modified. So that is how I think I would try to define the cell-based therapies or classify them.
Right. So then, Samir, would you like to throw some more light on what you would call CAR-T cell therapy out of this? So what distinguishes CAR-T cell therapy from the other form of cell therapies? He's already given us an indication what he means, but just to clarify it further, because we have many youngsters also in the audience behind, and these terms become confusing.
So I think all I can say is based on the previous lecture and whatever, cell modification, you take out cells, they are modified. Not every cell is going to be successful in every patient. So for example, an autologous stem cell therapy, that we expect it to be successful in all cases because there is no modification. But in CAR-T cell therapy, there is a modification, and the modification may not work in all. So that's my concept of CAR-T cell therapy, that it is not 100% successful in all. So out of 100, let's say you may succeed in 80. But an autologous stem cell therapy where there is no modification, you can expect to do it in all the proposed patients.
Right. So Samir has brought out an important distinction between what is autologous stem cell therapy and also what is CAR-T cell therapy, which is also so far autologous, but could also be allogeneic. But I think a key distinguishing feature over here is the genetic modification, which occurs in CAR-T cell therapy. And the genetic modification is in the nature of causing an immunological manifestation on the surface of the cell, which can now target the antigen for which it is being programmed to target. So this is how immune cell is being genetically modified to express an antibody to a known cancer antigen and will go and target that antigen. So this becomes what we call chimeric antigen receptor T cell therapy. And from Amit, I'd like to have some more light on what are your thoughts about this, and then we'll come on to the non-genetic.
I think scientific, technically or scientifically, that there's one more thing about CAR T cell. You can bypass the MSC class.
Correct.
Right. So there is no requirement for MSC class HLA presentation. So this is something like if you do regular dendritic cell therapy, pulse dendritic cell therapy, it has to go through the MSC pathway and then activate all this kind of stuff. So therefore, I think this has become more a kind of bypassing one barrier because HL is one of the key barrier. So I think this is one of the distinction.
Yes, so that's a very important distinction here. By genetically modifying and causing it to express an antibody, which it would not have otherwise expressed in nature, we are able to bypass the MHC class 1 barrier, and it's able to directly target the antigen. Yes, sir.
Yeah, I also want to highlight another thing. Apart from the CAR T cells, we can think about CAR NK cell that is highlighted, because I'm from Amity University, though I'm not a clinician, I'm basic scientist. Even when I did my postdoc also in US, that is I was under MD PhD. So in my lab, that is one MD is working in hospital, and it is regarding the transplant biology, especially in the CTLA4, that is abatacept. That is a treatment going on in the transplant patient element, and where we are trying to figure out what is the influence of the NK cells along with the interaction with the plasticides, macrophages. So those kind of the things now in the under construction, we just publishing paper, and next time we are doing the RNA6 and the genetic modification of the NK cells to transplant back into the patient. So that is also important parameter, and it's an important part of the panel discussion.
Thanks a lot, sir, for bringing that out. So what we can now be very clear in that genetic modification of an immune cell need not be restricted only to T cells. Virtually any member of the immune cell family, whether it is NK cells or whether it is macrophages, they can also be, modified. All of them can be modified to increase their potency to target a particular antigen. So I heard this interesting concept from Ridwan Romi just a couple of weeks ago when we were having the SSCT meeting. He says the immune system is it's a social thing. Like we are very social. Dr. Malhotra has called us for this meeting. So the first thing I want to know is Rahul also coming, is Chetan also coming, who all are coming? I would like to meet my friends here also. The immune cells are also like that. When the T cells come into a place, they call the macrophages also. When the macrophages come there, they say, "Come on, T cells, you also come here. Come, dendritic cells. Let's fill in." So they are a family. They are friends. They hang out together. One feeds on the other, and they all go to make the reaction. We should not be under the impression that when we genetically modify a T cell as a CAR T cell, that the CAR T cell is doing its job all by itself. It needs all these other people to do it. So we can initiate that immunological reaction by modifying the T cell. We can do it by modifying the NK cell, which is the first responder, or we can do it by even modifying the macrophages, which are sort of non-specific responders. So that's what we're trying to highlight over here is CAR T cells, and then you have the non-genetically modified T cells, which also what Chetan was alluding to, and what differentiates them is that they are not being genetically modified. But we are talking about immune-based cell products. So like, Chetan talked about chondrocytes, which can be used for, and we know some successful biotech companies in India which have done that. But that's not an oncology indication. And here, being an immuno-oncology society, we are restricting ourselves to that. So we will talk about immune cell-based products, so which are derived from the immune system and also targeted towards oncology, towards malignancies or malignancy-related issues. And the other thing which characterizes all these cells is that there is more than minimal manipulation involved. So, when the stem cell boom was occurring in research, and like a lot of people were talking about it, or a whole lot of these not poorly evidenced claims for miraculous cures started coming around. We all know about incidents, reports of people taking out stem cells from the bone marrow and injecting them into various tissues, saying this will regenerate, that would regenerate, without much evidence to back it up. And this was something. There is no manipulation involved over here. So all these therapies, they do involve a significant ex vivo manipulation, which involves manufacturing, the kind which Rahul was alluding to in his talk. So this is what we mean by cell therapies as general in the onco field. And we are careful here to exclude gene therapies, which Chetan was talking about, because these gene therapies are different. This is not genetic modification. This is replacing the function of a gene or substituting a gene which is there somatic with another one, or silencing a gene which is already there in the body with another mechanism, causing it to create a function which was missing in the patient. And that is gene therapy, and it works so far best for single gene disorders because it's more complex to repair multiple genes. So therefore, this is mostly used for single gene disorders which don't fall under the oncology domain. So for the purpose of our discussion, we are talking about cell therapies, include CAR T cells and other modified immune cells, and non-genetically modified cell-based medicinal products from immune cells directed at oncology indications. So from all of you, I'd like to know your individual perspectives, starting from you, that what is the single biggest challenge in your perspective for implementing cell therapies in India? That's what we're here to discuss. And what did you face? You can give your experience and what you think is the challenge. And you can highlight different areas of different challenges.
I think as of now, today, availability. So if we are having available CAR T cell for every patient coming to the OPD, readily available on the time, probably that will be the key to start the program, because we all knows that CAR T cells is gonna be answer for many patients who need this therapy. People are looking for. So if it's available tomorrow, people will actually accept.
Right. I think that's a very important issue. Availability is the first most important issue. I think that's what Rahul and I, when we decided, we got together in 2015, there was no approved CAR T cell therapy anywhere in the world. But we realized that when it comes also, we were very sure that we are going to price it, out of the moon. And also probably for the reason which Rahul has very lucidly, brought out, they are not interested in marketing it in India. For them, they know that a product which they are pricing at $400,000 to $500,000 has no market in this country. They have not. Novartis came to India, and they decided not to come back for another 5 years. And before that, they're not even going to come back and even look at the Indian market again. So that's their assessment of India as a market. So availability was never going to happen unless we did it ourselves.
Yeah. So even the cost, probably, when all the rituximab and all the monoclonal antibodies, when they launched, it was very exorbitant cost. But even in India, 0.1% of people are ready to accept that. People go out of the country for these CAR T cell therapy, go to China, go to Singapore, go to US, Israel. So I'm not sure that is the cost is the first barrier. It's available inside the country where you can, reach to the time.
Very important point here. So, but when the prices go above a certain level, we also realize that those who are wealthy enough to afford it are wealthy enough to go abroad to get it also. So availability does remain the major challenge and barrier. So you're very rightly pointed out. So what I think it points towards is to make it available, you need Indian science, Indian innovation, and Indian translation from lab to clinic, to trial, to approval, and to availability. So that's probably one big challenge, and probably that's the way we can go.
This is the way, like the unrelated donor transplant. When the transplant is happening in country, you are doing more and more. So if you need to bring the product from overseas, it's real difficult.
Absolutely right. So next, would you like to say what is the challenge which you would like to cover?
Sir, I think biggest challenge is accessibility and affordability. Even Swadeshi card, as I mentioned in the previous lecture, it will cost around 30-40 lakh. So it will be affordable for only a minuscule subset of patients.
Right.
So affordability is again an issue.
We'll come to that. So whether, so I think very important point that he's brought up is that we have heard commendable work from Rahul and his aims to bring this therapy down to even $25,000 to $30,000 equivalent in India, around roughly translating to 20 to 25 to 28 lakhs in Indian rupees. And this is just the cost of the product. The patient still has to undergo the procedure and the treatment and the CRS management and IVIG replacement and everything else that goes with it. So yes, so even this is unaffordable. Good point. Very good point. So what are we going to do about that? I definitely think you've identified a very, very important challenge over here. Samir, what's your perspective?
So Gaurav, my perception, of course, cost in this is certainly a factor, but I also feel that the regulatory requirements for getting it in place, while they are needed, I'm not saying that there should not be regulations, they are a little bit more tedious than the usual ones. And that, I think you have gone through it yourself. And I think the requirements appear a little bit more slow to get everything in place. So I also feel that as a thing which probably hampers the growth of these cell-based therapies. I'm not sure if my thinking is right or not, but that's my perception.
So yes, I think what Samir has brought out, yes, Dr. Mulasa, you'd like to.
So I think I'd like to elaborate on what Samir is saying, that, earlier there was no path. Now you have a path at least. It may not be a tar paved path, but there is a path at least. So in addition to making these molecules available to us, still very expensive, still very tedious, still about a year away, you now have a path for everything, path for the regulation, path for the manufacture, path for all the stuff which needs to be done, path for doing a phase 1 study, a phase 2 study. So I think this is an incredible achievement. We've at least started moving on that road. So I think it is absolutely appropriate and right to call Gaurav the father of CAR T cell therapy.
So may I just ask, what are the timelines? May I just?
What have you done?
So may I just ask, sir, what would be the timelines?
So I'll just so we'll just address this question first. I think what Dr. Mehta has pointed out, yes, it's right. I think Rahul and I used to often discuss this. We didn't just have to make the car; we also had to make the road to drive it on. There was no road to drive it on. So you're right about that. But to the extent possible, having done that, what we realize is that we are still in baby steps. So what seemed like a huge achievement is actually one minuscule step in the direction of cell therapy. The field itself is so huge. There's so much happening. In the time that we have made one CD19 CAR, the world has progressed and made so much more. And they are actually trying to bring it to the clinic. The field is expanding much more than what even it seems like we did something very fast. But I can tell you it is a very, very small contribution. There's so much more to be done. And regulatory pathways have to be streamlined. The regulatory network is more mature. But we will come to that when we come to the solutions. Right now, we are still discussing the challenges. I will take Chetan's view on board and then Dr. Mehra sir after that, because we just had an intervention from Dr. Mehra.
I think.
No, you go ahead.
Yeah. So I think affordability and accessibility is what we have discussed,
So
and I think
affordability and accessibility, regulatory pathway, affordability, availability, affordability, accessibility, regulatory pathway, and back to that. Yes, Dr. Mehra sir.
Thank you very much. This is a very, very important session. I just wanted to make two comments. One, that the ICMR has already made the national guidelines for cell and gene therapy. Are you people aware of that? Maybe go to the website of the ICMR. There are guidelines made. And if you have any suggestions on that, I have not been personally involved in that. But the second point where I have been involved right from day one is the national guidelines for stem cell therapy. And those guidelines are now available of 2017, and we're going to revise it now in 2023, because you talked about the minimal manipulation and the more than minimum manipulation. There is also the issue of heterologous use and the homogeneous use. And we have been every time in problem and discussion with the DCGI for a long time, were not convinced of this whole issue of minimal or the more than minimal, or the heterologous use and the homogeneous use, because the cells that you take from the individual, and if they are from the stem cell compartment over there, they will not at least survive in the other scenario there. So there are all those kind of issues are there. So I would be very happy if you could really also go through those guidelines, stem cell guidelines, suggest anything that you have in your mind, because the stem cell guidelines are definitely going to go through changes now, revision now during this year.
I think you pointed out a very important point. So just before I come to you, I will, unless you're speaking on the same guidelines.
Yes, same guideline, because it's a language of stem cell in the cell also. It's called unproven stem cell therapy. That is, yes. So the ICMR also has a guideline, even DVT also has a given line. But in the International Society of the Society of the Stem Cell Research, how much documents we are providing from the India, that is the less confidence for us. In terms of the stem cell therapy, it's a bigger challenge. Yeah.
Yes, I think the stem cell story has shown to us how disingenuous technologies and products can reach the stage where the regulatory body and ICMR have had to issue guidelines and warnings that these are unproven therapies, and so that people are not trying to just throw wool in the face of, and that shatters the confidence of the public in therapies as such, because it gives it a bad name. But coming back to the regulatory guidelines, so yes, the gene therapy advisory and the GTAEC guidelines, so to say, they came out in 2019, and we were very much part of that story. And I remember Rahul had given me a call when I was sitting in Guwahati, and I was to catch a flight and come back, and he said the guidelines are out and they are out for public comments for 3 days, and it's closing tomorrow. And in that much time, we had to make our responses and send them in. Rahul sent in from his side, we sent in from the clinical perspective. We made a strong pitch at that time for non-genetically modified cell therapies guidelines to be included in the same document so that it comes up in one go. Unfortunately, that part was not accepted, and it was CAR T cell was clubbed with gene therapy, which it really is not actually. But because it involved genetic manipulation, they thought the same amount of oversight is required. So from that point of view, from the oversight point of view, they clubbed them together. But from the technology point of view, they should have probably been different. And CAR T cell should have been clubbed with non-genetically modified cellular therapies. Now, I believe ICMR, I've heard from the workshop that we had organized last week. Correct. Correct. Yes. So we need your guidance and experience in this. So what I heard is that the immune cell therapy guidelines are still under formulation, but we didn't even know when it came up for public comments. We were on the watch out for that. But I think now Chetan and our group, at least from our side, we are preparing to send our responses to that so that it can be included. So yes, so regulatory is a huge issue and still much to be done. But finally, at least we have a document in place which gives us benchmarks and what to do. At least the guideline is there in place for people to follow. Yes, sir.
So
challenge.
these are the challenges already everybody has alluded. So from the research point of view, I think one of the challenge what I think should be addressed that that each T cells having one receptor. Now you are actually putting the receptor on the T cell. So now the T cells have two receptor. One is the endogenous TCR and one is their CAR T. So it's maybe I don't know whether endogenous T cell receptor is somehow doing some level of interference of this receptor, the new receptor, and that maybe the efficacy of the CAR Ts may be low, or I don't know. So I think I have read somewhere, I don't know whether it is addressed or not, that people are trying to knock out the endogenous TCR first and then introducing your CAR T, and that can be done by CRISPR-Cas9. So that become maybe more effective than because still your MSC and endogenous TCR is working for other antigen, CAR T cell working for other antigen, right? So if one cell is actually being exhausted two-way, right? So I think this is something more exploratory thing need to be done.
Yes, in fact, I wish Dr. Chiplankar was here. She has been working a lot in the field. And also, you're absolutely right. So what you're talking about is the technological challenges. I think the point that he has brought out. So there's a lot more innovation needed in the field. By the time we have developed one CD19 directed CAR, we already see the future lentiviral vector technology probably having a lifetime of only another 5 to 10 years before it's replaced in the clinic. I'm not talking about in the bench, things can move much faster. Clinic, it takes time. Trials take time to establish safety, etc., and long-term outcomes. But we see that the technology is already moving away. We read recently about the first base editing, in vivo base editing trial for a patient in UK, which made the news, first in human trial of that. And already the Sleeping Beauty system was tried up earlier for a non-vector, transduction. And TCR editing has been used for, so that we, like we said, you're not exhausting the T cells because the endogenous TCR is still there, even in a genetically modified cell. So we're not going to exhaust it faster. Technology is moving very fast. So a lot of innovation is required. I think the point that comes out over here is that a lot of basic research needs to go into it to come up with newer technologies. We need 1,000 more people, to be working in the field, coming out with new innovative ideas which can be brought to the clinic down the line as these therapies start achieving the end of the line. Yes.
Just want to add one point. I think that Rahul showed the data when the patient is not responding, and then you add with this anti-PD-1 therapy. So maybe this therapy is actually making the T cell reactivated, and this is because of endogenous TCR is getting exhausted. Because I think the affinity of CAR T is very high. Therefore, I think the exhaustion may not come through the CAR T. It might be coming through the other receptor.
Right. So so at least about the humanized CAR which have been developed by Rahul, I can tell you the in vivo data that we are seeing from the patients. We are seeing very good persistence. 8, 9, 10 months down the line, we are seeing 15, 20, 30, 40% of the circulating lymphocytes are still the CAR T. So this is actually, how each new one is behaving, we will come to know when we give it. So this is a journey which you learn only when you drive, drive on it, so possibly. So I think there were a few more points which I thought, which probably not yet maybe covered, but we have been having so much listening as I think our time is up, but we are just trying to summarize over here. Access, lack of approved therapies has been covered. Not enough trials is a huge address. We need many more. The two which we have started are just a drop in the ocean. Multi-center trials, more products need to come. We have a huge population. Everybody can jump into the field, and there's still place for much more. There are more than 500 trials occurring in the US, more than 800 occurring in China, and there are so many approved therapies on the way. And we are just about handful of companies still over here doing it, though even though it was zero a few years back. So there's a lot of space to grow over here. One key issue which probably I was hoping somebody would pick up: where is all the trained manpower or women's power going to come from, both from the clinical field and from the scientific field, to cater to this growing need over here? So I think that's a huge challenge which those of us and all of us over here who are in the field, who have made some advances, now bear the responsibility to train the next generation. Otherwise, the only way you can get is to get a PhD from outside. Somebody lucky like Rahul comes back to India, or somebody else who's over here, and then you may be a very good PI, but how will you get the junior research fellow who was, or senior research fellow who's going to do the work? So that's very, very important. Training is very important. And the challenges of being a personalized therapy, I think we all brought out. It's a patient-centric personalized therapy and involves manufacturing. It has to each time be derived from the patient. That is a problem with scale. It's not like a pill or an injection which you can manufacture in thousands or hundreds of thousands and send into the market. Like Rahul has already told you, he needs at least 200 to be made before the cost to come down. So these are very important. Another challenge which I thought, which is that CAR T-cell therapy world over, we have seen it started in academic centers, and then we got taken over by companies and rolled out, which is pretty much what's happening over here also. But now also a lot of companies are doing their primary R&D. And probably we are going to see this industry-academia collaboration much more in the field of cell therapies than any other field, because you require the cells, you need to be close to the patient, and it always needs to be personalized manufacture until we go into the allogenic space, which was being alluded to. So with this, I would like each one of you, regulatory framework and guidelines you've already done. So now just to sum up, because I think we've exceeded our time and there's lunch and flights waiting for people. So I would just like quickly from each one of you, for all the challenges that you have identified, what is your specific solution? So you said access and availability. What do you think can be done to improve that?
Can you speak in that mic?
Yeah, the mic is not on, I think. Can you take out mic? Yeah.
So what I said, you rightly said, unless this from the institute, the industry get involved to produce more and more CAR. So this country's need is huge.
So I think your point is that there's a lot more required from industry, but from industry, we already heard the challenges that for startups to be funded, we require much more funding. So I think this is an appeal to government agencies to fund more startups or to exit with hold the hands of those which are doing the work to bring them into to be able to help them to scale up.
Because number of the refractory malignancy, the lymphoma or ALL in everybody's clinics, 4-5. If everybody start looking for CAR, to support them, probably need a huge challenge.
So we need a burst of industrial activity. And I think we should all be common in our voice to the government that biotech industry, and especially in the cell therapy space, already a $450 billion industry worldwide, set to grow in India. We have shown over here the talent is there, the people are there, the scientists are there who can make it, and the capacity to take it to clinic is also there. So this is definitely which needs the attention of the government, and they should hold the hands of startups and invest in more. And so we heard that earlier.
So second biggest challenge will be, as you rightly said, trained manpower. We have to culminate the culture of the science in this country. Right now, everybody's commerce, shortcut, make money and move. So it's a hard, dedicating science required for transplant, cellular therapy. Everybody is in problem. So dedicated manpower training will be huge task.
Yes, definitely. I agree with you. So we have tried to do something about that. I will just say that towards you. Yes.
So, development of indigenous CAR is the only option to reduce the cost.
Rahul, more cars needed. Others also in the field, we require, basically, we are hoping that, the scientific community is supercharged and gets excited about this and diverts their attention into this field, which is really a growth area. So more scientific contribution required into the CAR-T space. Sameer.
So my suggestion is that there should be defined timelines for the regulatory process from the regulatory bodies. And those defined timelines have to be such that it is done in a period that is reasonable. I can't define that reasonable period, but it has to be certainly defined.
Definitely. I think we agree with you on this. We face that challenge, and a suggestion from Rahul earlier and others also, which we heard in the workshop that we had organized, that pre-filing meetings with the DCGI are very much needed so that we can get a clear answer from them as to what they expect us to come back with them by the time we are filing for the IND. So, even at the earlier stages of development, we need to be able to have a window to interact with the DCGI. The system already exists with the US FDA. It exists with the EU FDA. I think we need to get our own regulator also to be, though I believe it's the facility is there, but nobody really uses it, or the ecosystem to use it is not known to us. So we wish that pre-filing meetings can be held so that we get clear clarity on how to go about it. Chetan.
So just to build upon that point, because I think the regulators also need to be trained with the science, so that interaction will help. One of the other things I was I wanted to bring about is that now there will be multiple cars that will come into the market, and then you don't know which one is working, which one is not. So I think a platform where all the cars are registered and their outcomes are rigorously monitored, so that we know which one is better, and as there are new cars, define the indications for each car. So that is something that a society like Immuno-Oncology Society can take up and help guide the science, so that the best car goes ahead, and new cars coming in will supplement that.
Right. So IOSI, I think this is for the IOSI Executive Committee, sir. We need a cell therapy committee probably under the aegis of IOSI to start framing guidelines, or the ecosystem that cell therapy will come forward.
Yeah, not only in the CAR therapy, in the stem cell therapy concept. Actually, I already mentioned about that the MD PhD culture is less in India. That is one big challenge, and it could be a big solution also, because in the United States most of the MD PhD program is there. So along with the academics and the clinic especially, so that is a big solution for the taking the challenge. So it will be work together.
Yes, I think you really hit it. We don't have MD, PhD. That's why MD and PhD have to come together. So we have to, MD must meet PhD and we should work together. I think that is probably, till we get the MD, PhD ecosystem going, we must reach across and hold hands. Amit.
And now the CAR made a budge in India. So I think this is the right time to actually have a push for the funding from the funding agencies like DVT, DST, and ICMR to invest more into the exploratory, mechanisms to understand the questions, what the challenges, technical challenges. So therefore, we can go to the next generation. Now the generation CAR-T we have to go from the one generation to the next generation. We need more funding, right? So I think the IOSI can also become a catalyst to write to these funding agency and make more budge for the funding.
More funding for industry and more funding for innovation and basic science. Both
Yes.
are required.
Yes.
We heard the dismal state of funding right now and how it should improve. So, sir, I was waiting.
Thank you. So I'm going to, challenge one of the statements that is made, and that is that MD PhD, as in USA, is required. And I will tell you the actual scenario of MD PhD in USA. So the interest and the students applying for that is declining. And that is because those who have done MD PhD are finding that they are jack of all, but not sufficiently trained in either. And I can vouch for that because my nephew did MD PhD from NIH, and now he's regretting that he did that.
So all things Western.
No, this is some example, but
right
yeah.
for us. Jyoti, yes, please. Sir, should I wrap up or because the
Just
participation seems to be good?
small point. Because everything, most good points are covered. I just want to bring it to notice that, what happens post infusion. If the patient's mind and, psychological issues are controlled, probably if you come up with some guidelines post therapy, they can have some yoga or meditation or aroma healing. I mean, I know that will be the best integrative system, because I think your system is good. Your car maids are, they are well made. But how the patient takes it, like, if I say, oh, I don't want, with a negative mind, probably it won't work. And if somebody is, yes, I'm going to feel better, I'm going to work, probably it will work also. So support system or post infusion, probably if also looked at better way, I think that will be more success outright.
Absolutely. So
Yeah.
not just the science and the technology or the treatment or the clinical part, but also the mental wellness and the physical wellness of the patient.
So that inpatient, if the 1 week probably in some medicinal herbal garden, if they are given for these, maybe they will. I mean, I feel it would be a positive outcome over there.
Definitely, it's something which needs to be developed as a whole. So with that, I think we have some good points which came out from this discussion. I thank the panelists for your thoughts and also the audience for this very good interaction right at the fag end of the meeting. I was not expecting so much responses, but thank you very much for the active discussion. Thank you once again.
So, ladies and gentlemen, all good things have to come to an end, and I presume that you will agree that this was a good thing. Good thing in the sense that the conference was good. We will just take 10 more minutes of your time. So, if you could just sit down for 10 more minutes, we'll very quickly finish the validatory function. The primary, the aim and the goal of the validatory function is to thank some of the people who worked to make this conference, get this conference to a level where we got it to, and to announce and award the young scientists and clinicians who submitted, made the oral presentations and made the posters. So may I request all the executive members of the IOC to come over here? Please, sir. Dr. Gidarilal, Dr. Jyoti, Dr. Reena. Reena, you can't go away without coming on the stage. So am I missing some other executive committee members? Yeah, Dr. Rahul, please, can you join us on the stage? So, Amit, are you there? So, yeah. So, the first and foremost, Dr. Lalit and myself and Dr. Ajay, the local organizing team, are unanimous in the decision that the driving force for the scientific program for this meeting and getting 12 international faculty on board, मैंने तो उनके नाम भी नहीं सुने थे, but having a one-to-one interaction with them, having them come on board, sit on their computers at 6 o'clock in the morning or 11 o'clock in the evening. There's one person who's been able to do this, and that is Dr. Jyoti Bajpai, our secretary. And in most movies and in most tricky situations, you have a good cop and a bad cop. And they both, when they both work in tandem, then you get the best results. So Jyoti was our bad cop and Lalit was our good cop, and I was the judge who didn't do anything. So I think Jyoti really, really worked hard to make the conference and get it to a level where you saw it. So we really want to acknowledge. She's also the founding secretary of the organization IOC, and there are so many firsts which she's done for this organization that I can't even begin to list them. So Jyoti, we would like to recognize you and acknowledge the hard work you've done and hope that you continue to do that, at least for the term when I am president. After that, you may not do it. So I think, chalo, I number I was. So I think Ajay, Abhi, please आइए ऊपर, and we would like to, personally thank you for your effort and to publicly recognize and acknowledge the hard work which you have done. देखो बगड़े अच्छे So I think the second person who should be publicly acknowledged is my very dear friend, Dr. Lalit Mohan Sharma. He worked very, very hard to get all the nuts and bolts of this conference in place. Jyoti, do you agree? Yes? Yes. So I think whatever final shape you see of this meeting is because of this gentleman. So we must अभी मेरे को थोड़ी देर पहले मेरे कान में बोल रहा था कि सर वो वाला रहने दो आप मेरे को मत करो. But the people who perform, people who've done, people who are instrumental in the success of an activity, they must be acknowledged. So I will very much publicly like to acknowledge the hard work you've done. Lalit, very, very thankful to you. And this conference, the way you see it, is because of this gentleman over here. Thank you very much.
हाँ अंग्रेजों के
So मेरे में इतनी एनर्जी स्टैमिना था, अब मैं वापस ललित को दे रहा हूँ, वो करेगा जो करता है. ललित आ जाओ बस.
डॉक्टर ज्योति की इच्छा है कि सर को भी हम लोग टोपी पहनाएं या सम्मान करें. कितने लोग तैयार हैं इसके लिए आपने? आई थिंक सर जनता की बेहद मांग पे आपको भी we want to acknowledge your contribution and guidance, but that will be at the end. Can we have it right now? भारती मैडम सर की टोपी पहले से तैयार रखती है, कभी भी पहना सकती है.
Yes, I want to do it.
बहुत स्पेशल वाली ज्योति की बात हो रही है.
So the first foremost thing we want to acknowledge is the contribution from our young scientists. And we had, in fact, around 45 total scientific papers. And a jury of judge has selected papers for the oral presentation or in the poster, or few of the papers have not been accepted with due reasons. So amongst the oral paper presentation winners, the third prize goes to Dr. Aniket Goenka. Is Dr. Aniket here? So Dr. Aniket is second year DM student from Mahatma Gandhi University, and the judges, I am very honestly telling you, they were not from our team, they were total independent judges. So Aniket, can you come forward, please? So the topic was pattern of use of immune checkpoint inhibitors in a tertiary cancer center. So will you come forward here, Aniket? Yeah. And the award is in the form of a certificate, a memento, and cash prize.
You are first DM candidate. Exam going next year, you know.
So may I request everyone from the dais to please come forward for the photograph. आइए मैडम आप भी आ जाइए प्लीज.
Yeah.
Yeah, may I request everyone to be there only. So that was the third prize. The second prize goes to Dr. Harshita NJ. Is Dr. Harshita here? Yeah, please.
I suggest you read the title of the
So Harshita's title. Yes, sir. Immunotherapy is first line treatment in metastatic non-small cell lung carcinoma. Harshita is from Manipal Hospital, Bengaluru, and she is the second prize winner.
Two papers we did. Yeah, the week now. Some of you, आप किनको you can hold both. ललित आप भी आ जाओ.
Yes.
So continue to the economy of my city now.
Yeah.
I think we should announce the cash prizes also.
So the cash prize for the second winner is 7.5 thousand. The third one was 3,000.
And please remember to give your bank details if you want the money. Otherwise, we'll keep it in the society as your donation. And have you become a member of the society? Before you go, you must become a member.
It's a discounted membership. Now, Dr. Jyoti has announced some 20% discount on the membership fee.
Please come on board.
And only today, last day.
Yeah.
So can anybody guess the first prize for the oral presentations? So the first prize goes to Dr. S.N. Padmini. Big round of applause. She is again from Manipal Hospital, Bengaluru, and the title was long-term follow-up of advanced non-small cell lung carcinoma treated with immune checkpoint inhibitor as second-line treatment.
Congratulations.
So certificate is being awarded to Dr. Padmini along with memento and cash prize of 10,000 rupees.
Congratulations. Become a member just now. Abhi form bharo.
Rishi, give the forms.
So out of 16 total presentations, 3 were approved for the oral session, and amongst the poster, we had close to 17 or 18 posters. and 3 top were selected. And for the third prize, we had two winners, and both have equal marks, in fact. And the third prize goes to jointly to Dr. Hemchandra Jha. Dr. Jha's topic was morphology and pathological variation in Helicobacter pylori isolated from distinct niche. He is from IIT Indore. Congratulations, Dr. Jha. So in the poster session, you will be getting a certificate, memento, and cash prize of 2,000 rupees.
ललित आप आओ, आप दो।
The another third prize with the equal marks goes to Professor Ridesh Prakash. Congratulations, Dr. Prakash. So Dr. Prakash is from Amity Center of Translational Research, Noida. So the second prize in the poster category goes to Dr. Lakshmi R. Shenoy. Is she here?
She's not here, sir.
She is from Srinagar. So we will.
Please don't fall down. Yes.
So a certificate, memento, and 4,000 rupees cash prize.
From airport. Very nice.
And the first prize in the poster category goes to Dr. Sham Swaroop. Is Dr. Sham Swaroop here?
Yes.
Yeah, Dr. Sham Swaroop. Congratulations. Dr. Sham Swaroop is from Mahatma Gandhi Hospital, Jaipur only. And again, he has done good work on the title shown on the screen. Dr. Sham Swaroop will be getting certificate, memento, and 5,000 rupees cash prize.
What's the problem? So Ranjan, can we sit down now?
रुकिए सर 2 मिनट और दीजिए. So we want to have acknowledgement of other people who has done hard work to make this Congress successful. And the first foremost thing we want to acknowledge is the mice ideas. And from the Rajesh Sharma's team, may I request Nitesh, Neerav, Rambabu. These have worked day and night with us. So we want to acknowledge their contribution. We all had delicious food, in fact, in breakfast, and to acknowledge the contribution for the food and to keep you happy, may I request Prashant from Honeydew, Sandeep and Prashant from Honeydew.
एक जना आ जाओ, है कोई?
नहीं, दोनों हैं.
जल्दी आओ, जल्दी आओ. और यही मिलेगा, चेक वेक नहीं मिलेगा. जल्दी आओ.
Both have worked day and night, in fact, and many recipes they have tried. And I thank to both of you for excellent churma dal bati yesterday. We all enjoyed.
Thank you. Well done, guys. Huh? Good. Good. Thank you. Good. दोनों share करो ये I don't know क्या है मैं Thank you. Food was really well. Thank you so much. Thank you. Thank you. Thank you. अरे एक memento जो ना इनका
And we thank Man Singh ji.
ललित आप इनको memento दो पहले my ideas करो. We will collect on that. Yeah, right. Thank you. Thank you. Just a small question. मान सिंह जी को बुलाया?
Man Singh ji, aa jao. So Man Singh ji, the person who sits behind the curtain, in fact, he controls all the AV system here in this auditorium. And Man Singh ji has been very useful to us since beginning of the conference, and he only keeps everything in place.
And there was a special challenge this time because we had to shift from the lecture theatre to this in the middle of the conference. So, Man Singh ji, आइए.
Next topic. Let's talk to Gizarilal the mic.
May I request Dr. Girdharilal to announce something for the next conference?
Good job, man.
Thank you, Thank you, Dr. Malhotra and team for wonderful meeting what we had here. And I would like to mention that the next meeting is going to be from Pink City to the Oxford of East in Pune. And NCCS will be happy to welcome all of you and looking forward to see you in Pune. Thank you very much. Thank you.
अभी देखो एक चीज रह गई. I forgot to thank Bharti. नहीं तो I won't be able to enter the house. And Indu, where is Indu? Indu's here. So like our better halves, Lalit ji ki better half, Mary better half, they deserve also a round of applause, please. Thank you very much. Thank you.
चलो भाई, congratulations. Heard internet में उसको नहीं पता है यार.
कैमरा ना
So with this, we all will go for lunch and then we close the Congress. Thank you so much.
you.